create another hall. That's how that will be open. Entire thing will be done, but tomorrow will become more bigger hall. That session will start after some time. But initially, we'll start with the challenging cases here, and then it goes on till the lunch, and then again post-lunch session. I think many of you have seen the agenda. Whoever do not have it, you can scan the barcodes behind your badges. You'd go into agenda pages on your smartphones. So again, welcome you all to this year. Great support and link between us and all the faculty, and one of the president and of our FACS Foundation, where Sushil and we started this about 17 years back. Always they're going through. I request him to say a few words of welcome to you all, and then we'll call the first set of chairpersons and presenters. Sushil, over to you for a few words.
Thank you, Srinivas. No, I think this is great. I mean, this has been a long time, more than 10 years that we've been doing this, and it's been different iterations. And sort of the goal is to do what's most valuable. And I think, what we felt like when talking to people, it's a lot of case-based discussion, case-based learnings, learning from complications, learning, how to do things, how not to do things, and sort of a open and free sharing of ideas. I think is important. It's sometimes hard to present the things that don't go right, but I think that's where most of the learning comes from. And really happy and engaged to have everyone participate. It's a smaller room, but I think in some ways, I think this is a lot better because the goal is interaction. And so what I would ask during the sessions is if there are topics, questions, things that come up, or if you said, I would do it differently, or why did you do this? It should be free and open to ask, right? Because that's the way we're going to be able to learn. To challenge one another in a friendly way is healthy and a good part of learning, and that's what we hope this year's meeting will be. So welcome, and I think we should probably get started.
Thank you, Sushil, and I'm pretty surprised all of you now on time in the hall, and it's a very good thing to note, and more people will join. First, we have this challenging cases. I think my friend Ramesh and Sanjog will be joining. Dr. Surendra Ravala sir is here. And many of this time, other good thing happened is a lot of colleagues from Kazakhstan, Russia have come along with people from Mauritius, other countries, have put them on the podium too. Whoever is here in the first set of panelists, I think you can join, and more people will also join up. But I request Dr. Surendra Ravala sir and Dr. Tripti Dev madam to come over and share the session. Other doctors who are there, please feel free to come. Jayesh Bhaskaran, Matthews Paul, and our Russian colleagues, Ramadevi madam, all us whoever is there. Anurag Sharma, please join over the podium. We'll avoid too much announcements to avoid wastage of time. And I request Dr. Surendra Ravala sir and Dr. Tripti madam, you can come onto the podium, and we'll go for the first set of presentations. I think it is there on the phone. We'll also get you some printouts. First is IVUS-assisted calcific RCA PCI with rhodotripsy by Dr. Harishankar. Please come. Go ahead. And pointer.
Good morning, everyone, and thank you, organizers, for giving me this opportunity. I'm honored to begin this conference. So I'm going to present a case which I did IVS-assisted PCI to calcified RCA with rhodotripsy. So summary was that he was a 76-year-old male, came with unstable angina. ECG had STT depression in inferior leads. Echo was normal LVEF. He was triple vessel disease patient at post PCI to LAD and SERC. So that was the angio. Here we can see that RCA is having tram track appearance, severely calcified from proximal to distal part of the RCA. So by seeing the angio only, we decided that we have to go do the imaging, and this patient will require plaque modification and a calcium cracking also. So after wiring the RCA and took the TPI also, because was knowing that he'll require the atherectomy. Tried to do the IVUS first, but IVUS catheter didn't cross. Took the 2O new balloon also, it also did not cross. So if you'll see this guideline, when there is a balloon non-crossable lesion, we need atherectomy devices. As I had the rotablator in cath lab, so decided to go with the rotablator. Took the 1.5 burr and did the rota. Started from the proximal part, slowly went to the mid part, then distal part, up to the distal part, and after that did the polishing also. After that, took the IVUS run. So here we can see this whole RCA was almost calcified, and still it had the 360-degree calcium. Then took the NC balloon, that was the 3O balloon, started from the proximal part. Here also we can see here this dog boning of this NC balloon. So it did not get opened properly. And as this IVUS was showing that there is 360-degree calcium, and this NC balloon, after doing the NC balloon also, it did not give up the lesion. So decided to do the IVL with 3.5 balloon, and it was given in the almost whole part of the RCA from distal to the proximal end. That was the RCA after doing the IVL. Then took the 3.532 DES, 3.532 again in the mid part, and the 4.024 balloon in the proximal RCA. After that, did the NC ballooning from the 4O balloon, and that was the final IVUS. So stent is almost well opposed to the wall and well expanded. That was the final result. So the take-home message is that severe calcification is seen in the 10 to 15% of the PCI. Imaging is must in these complex PCIs. Optimum bed preparation is the key for good outcome and long-term results. Calcium modification is mandatory with lesions with high calcium content, either in the form of rota, orbital, laser, IVL, OPNC, cutting or scoring balloon. Thank you.
So thank you for a great case presentation. I guess I couldn't see in the beginning because the lights were in the way, but did you image just at the end, or did you image to start? Like, does imaging play a role in your choice of rotablator, IVL, non-compliant balloon? And in terms of imaging, intravascular ultrasound versus OCT, maybe you can comment on your thought process as you went through the case. And obviously a lot of things come into thought, but cost efficiency, safety, all of those things, and maybe sort of the algorithm for decision making would be helpful for people to understand.
So first, after wiring the RCA, sir, we thought for the imaging only. As we are having the IVUS only, no OCT. So IVUS catheter did not cross. Took the 2 new balloon, also did not cross. Then we had the option to do the rota only. And after doing the rota, we did the IVUS. And in the end also, after putting the stent, then NC, in the end also we did the IVUS.
I think Dr. Surendra Aula sir has maximum experience in this calcific lesion, started rotablation long time back. You can just tell your comments about that.
I think, it's there's a lot of judgment involved in that. Obviously, when the IVUS catheter did not cross, obviously that itself is an indication for increasing your device selection, such as any ablating techniques has to be used. And one thing, I don't know whether everybody noticed it or not, when the dog moaning was there, I'm impressed actually it did not go into too high pressures there, because on the IVUS in the calcium, you can see not only there is some areas of circumferential calcification, but in the beginning in one area, it's almost like the C cat sign there. If you have done very, very high pressure balloon at the time, I could almost guarantee you got a pericardial drain in the place there at the time. And it's a very good judgment call there. Thank you. Yeah.
So can I ask a question though? IVL is relatively new. And, again, availability cost. After the rotablator, you saw that calcium. What are other strategies you could have employed? Say IVL is not available.
Right. Probably, a lot of times I would do is I'll put a double wire, and then sometimes I use a non-compliant balloon again one more time, as is a poor man's scoring balloon or cutting balloon type of it. And then I still would like to do, if the scoring balloon is available, I will go to that as a next step there. And then once I get adequate balloon expansion there, then I will go into stenting of the vessel will be done there. If the IVL is available, obviously that alleviates most of the problem there itself. That's would have been my algorithm. But of course, in the algorithm, we always has to try with the NC balloon first, and then sequentially we have to do that.
But I guess I'm not I do mostly structural, so I want to ask the questions as a novice. You say in terms of trying the non-compliant balloon, how aggressively do you try? Do you go to 20? Do you go to 30? Do you go higher? What does trying mean? Because the part of the challenge is how do you know when to stop, and where is that point before you end up with a perforation or a major dissection?
Very good question there, and I think probably I will do at the most 12 to 14 atmospheres with a non-compliant balloon, and I would not go to 16 or 18 at the time there, because I don't have any scaffolding at the time there. At the most, probably nominal pressures to 12 to 14 is my limit for the NC balloon prior to embarking on the other devices.
And because IVL is expensive, the cutting balloon acts most of the times well, I would say. Especially Wolverine knows better quality cutting and slightly more trackable also now compared to the old versions. A lot of times we save usage of IVL because Wolverine cutting balloon cuts, especially in the ostium. It's a great thing. Always you try that. And then you can avoid usage of IVL because of cost. And IVL also, it is a little bulky. Don't think it just goes, unless you prepare it with a good 2 mm NC balloon, IVL doesn't go. I think those are some of the things. But I wanted to check with Surendra. The most of the times where you feel imaging is good, the problem is the imaging catheter itself won't go. So before we have our closure of time, what are the tips you take the catheter, imaging catheter inside till the lesion? You have your own methods like a buddy wire, things like that. Can you just throw some light on that?
Yes, I always start very simple in the sense, putting a second wire there, so it will kind of give you a little bit more support, obviously good guiding support. I tell my fellows all the time, most of any coronary intervention is as good as your guiding catheter. 80% of your cases are completely done and safely done if you had a good guiding catheter and good guiding support. If that is not, even the double wire technique is not adequate to get your IVUS catheter or OCT catheter across the lesion, then probably, even a guide liner or guide extension catheters will be used so that you can prep the lesion as much as you can, and then utilize the IVUS catheter or the OCT, whichever is available at your institution. Yeah.
I think guide liner is a very good value addition. I think time is up.
So one quick thing. You talked about cutting balloon. Do you do cutting balloon at sort of regular pressures and then go with an NC after? Like the cutting balloon sort of scores it a little bit, then the NC at higher pressures will expand? Is that the strategy?
Yes, the cutting balloon, you don't want to go too high pressures also, because you do rather slowly over a period of 30 to 45 seconds, unlike the traditional balloon. And the same concept applies also when you're deflating the balloon also, so that, the blades or the scoring complex, which the wires will squeeze in back to its original configuration in a safe manner there.
Yeah. I think that's an important point, because all of these balloons don't behave the same, so we have to sort of use the technology in a safe manner.
I think we'll move.
Would be
Working.
it be possible if you don't have a rota, to go ahead with the orbital. Orbital because it's a circumferential calcium.
Sure, yeah.
Yeah.
I was a part of the orbital trial with Columbia also with Dr. Kitane and that group there. And orbital is, and I use a lot of orbital still a lot. It's a very useful device, and I don't see a huge difference except maybe the cost difference wise in terms of the technology of the devices in per se.
I think we'll have more discussion with similar cases coming up. We have Barua also coming. One thing I wanted to tell you people is you scan the barcode behind, you go to the app, and then the app has a facility to answer questions, ask questions with your name. It comes displayed, and we can answer them to save some time. We will move on. I think second presenter.
Thank you, sir.
Second speaker, Dr. D.K. Barua, shockwave and tears, a case of coronary perforation following the lithotripsy.
Can I ask them to turn those lights down and put the room lights back up so that we
Good morning,
can see the screen?
chairpersons. Thank you very much, ACVS, for this opportunity. I'll go details into the case. This is a 71-year-old lady treated in another hospital for acute STEMI and came for further management. She had an angioplasty 10 years back with this, and she had hypertension, diabetes, dyslipidemia, CKD, and she's a frail lady with anemia. ECG, as we have shown there, is assessed by interval MI, and LVEF was around 48%. And there's a creatine 1.4, hemoglobin 10, and there's hyperlipidemia, and sugar is not very well controlled. Angiogram was done there, and there's a double vessel disease with LAD ISR and with RCA disease, and they advised PCI. Here also discuss about, because he had a post angioplasty, we discussed regarding surgery, but he opted for PCI. Okay. This is an angiogram. You can see that LAD has got a ISR with heavily calcified disease right from the proximal to the distal. And there's a very, maybe around 70% to 60 to 70% in-segment distal disease and diffuse ISR, though angiography doesn't look very tight. And RC has got a diffuse disease with, again, heavily calcified artery, RC right from the proximal to almost distal artery. You can see the calcification. And because this kind of case, always you try to avoid if you can spare the LAD with medical treatment. That's why I did FFR also, make sure that it is not very significant. So FFR found to be very significant. So we have decided now to treat both LAD as well as this RCA. You can see the RCA has got a significant calcification. So although this case may be a very good case for rotablation, but I started with a 1.5 milligram and semi-compliant balloon, crossed the lesion, then pre-dilated, followed by 1.5 OP and NC balloon. Then we try to now treat with a balloon itself, 2.5 millimeter cutting balloon. Then because we have to treat the both LAD, so I have selected the IVL of 3 millimeters so that I can C2, so that we can treat the both RC and LAD. So 3 millimeter IVL, we have used that mostly that, you can see the calcium nodule, this kind of situation. What we have the tools now for the treatment of calcium nodule, IVL is supposed to be better than, unless you get a very good, favorable kind of wire bias with a rota. IVL, that's why all this calcium nodule we thought IVL will be better, so we did IVL. And finally, proximal part, because the 3 millimeter IVL, which is proximally is a 3.5 millimeter vessel, so IVL may not be useful in that. So I didn't waste to the IVL, so we went to the cutting balloon 3.5. So we've used the various balloons, but we could get a good result with it. You can see that post preparation, RCA is very good. We did OCT also, we found RCA is open very well. So in that case, probably we can put it a stent, 2 stent we put proximally and distally. And finally, we had a fairly good result with OCT evidences of good MSA. So this is the RCA. Actually, today's my case is basically the LAD. I just want to see what happened for the LAD. You can see that LED, there's a significant calcification in the proximal LED, non-stented segment, as well you can see the stented segment also I have written there. It's a very circular calcium 360 degree, intra as well extra stent calcium. So this is a very heavily calcified lesions. You can see the balloon open little bit 2.25 distally. And we have taken the same balloon, 3 millimeter IVL balloon. We have tried to open up the stent with IVL. With OCT, it was, you can see that a significant calcification right from the distal to the stent to the proximal. Entire segment is calcified. Now, after IVL, usually we did this. I wanted to see the with OCT. You can see the OCT run shows there is a multiple perforation. We never expected. It's very unexpected actually. We never expected that this case will land up in the perforation where in the stented segment. You can see the arrow. There is a perforation there at the mid of the stent and the proximal part of the stent also. So multiple perforations in. So this is the time patient develop chest pain with hypotension. Even we are lucky to do the OCT easily. Suppose you have done angiogram without OCT. I don't think we have done OCT. So we have done the OCT. That's why you can see the perforation in the OCT as well. You can see that total whole and both areas entire is totally perforated those two segments. Now problem comes with the patient develop hypotension. So here most important is there will be very rapid action because the patient has had multiple perforations. He will go into tamponade definitely. We cannot prevent tamponade. So we started IV fluid just to maintain a little bit of blood pressure. So main issue here to attack the perforation. So we put a balloon, just a balloon tamponade we did. Didn't work that much. Although there is some reduction, you can see that mild reduction is there, but it didn't work. So out of this frustration, we thought maybe we will put a stent so that it will tackle this perforation. We put a long stent covering the entire perforated segment, multiple perforated segment. And this also didn't work. In fact, if you see that it's aggravated the entire thing, perforation is increased. So this is the time we'll have to do very rapid action. So we have decided finally that we put a cover stent. But here challenge is that there's a big diagonal sitting there near to the perforation. And what we kept for the diagonal, with that wire, the cover stent is not being negotiable. So we have to pull out the wire because perforation is more important than diagonal at this stage now. So we'll have to sacrifice some diagonal also. But however, we put the stent very carefully, just to think that because you can see the perforation very clearly is just below the diagonal. So we put this stand graft at the mouth of the diagonal, not just above that. So we put the stand graft there, then that perforation got sealed. And one important thing I should say here, if you put a stand graft, you can see that immediately after the stand graft, there is still some perforation is there. So it doesn't mean that the stand graft is not working. So stand grafts should be deployed very high pressure. That's the most important thing. So next we have taken a 3 millimeter balloon, went to 18 atmosphere. Even after that, I took a 3.5 millimeter, we have gone to 20 atmosphere. So never deploy stand graft below 18 atmosphere. It has to be expanded very well. You can go up to even 4 millimeter. This stand will go up to 4 millimeter. So you go to very high pressure. You can see that after very high pressure that this perforation got closed totally. So that's very important. So once you get a nominal pressure, it will not work. It will go to high pressure. So finally, you can see that perforation got sealed, that entire thing. Of course, subsequently, we will put a pigtail and the aspiration was done. This lady recovered, though she had some kind of increased creatinine, hemoglobin came down. There is some hematoma in the groin because radial was not there because previously angiogram was done outside. So we have to do from femoral. Finally, you can see there's a good result. We have tackled the perforation. Most important is that we could save the diagonal, which is very important for her because she had some LV dysfunction. This diagonal was big. So we could save the diagonal with a fairly good result. And we have deployed the stent with the OCT. You can see that stented the graft area also very well deployed. Other area also well deployed. And we had a good MSA right from the 5.5 to almost 8. We got MSA from distal to proximal LED. Key learning points in this case is the treatment of calcified IS are challenging. This kind of cases even can be treated with a ROTA also because it has been done 10 years back. But again, that is also again challenging. We need to take a lot of precaution. Imaging is very useful for ISR. We'll have to do almost all cases better to do imaging and find out what exactly happening there. IVL is not complication free always. Whatever studies we have less than 0.5% perforation has been documented. But in a calcified ISR, in the ISR, this kind of situation, it is very, very unexpected. I never thought that patient will develop IVL. This is really surprised during this procedure. And I went to the literature. They says that if there is the calcifier sitting in the external part of this stent, when you when you inflate the IVL, because that will generate a pressure of up to 50 atmosphere. So that spar will hit this kind of outer layer of the artery that can produce some trauma that can produce perforation. Second is the oversizing. Here we have done little oversizing because distal artery is about 2.7. Because we'll have to think about I have to think about the RCA as well as proximal LAD also. That's why we taken 3 millimeter balloon, but that's not very much oversized. But oversized that extent also very important in the normal artery. I mean non-stented segment. But in the stented segment, I thought it will be safer. But still, we had a perforation in this case. So oversizing is not good for IVL. So 1:1 is always better. And every second is very important for this. This kind of cases, the rapid sequences of your kind of intervention is very, very important. You do very fast. You should do very quickly, whatever you do, and try to seal the block and immediately do the aspiration. Trade-off and DAPT is very important. Many times we don't have to worry about the diagonal or all. Suppose in this case, suppose I could not have closed that. I would have put another this kind of cover stent, even sacrifice the diagonal also. Sometimes you'll have to do that. And most important, this kind of situation, the DAPT should be continued for a long time because stent thrombosis in the stent graft is not uncommon, and you need to follow up this case. This case is doing well till 7 months. I'm planning to do angiogram maybe at 9 months and see. Thank you very much.
Questions are, nice outcome. Congratulations. I always, again, teach the fellows too. Whenever you see a straight LAD, always be careful with it because that's part of it could be the intramyocardial course also. There you have to be careful about. That's one. And on the OCT, you can see, and again, as I've just mentioned before, there's an eccentric calcification. So when you go to higher pressures or oversize the balloon, and obviously the area of least resistance gives out, that's the reason why it had the perforation. And the difference I would have done probably, I know it's, we're not there, we are what we call the peanut gallery, we're commenting after the case, and you are in the middle of the case there. So rather than doing the stent at the balloon tamponade actually was done, and then rather than putting another stent there, the reason is it's not going to help us in that sealing the tamponade or the rupture of the vessel. There is one fundamental principle is whenever you see a rupture there, the port of entry is always proximal when you're coming antegrade wire. When you see a rupture in a retrograde case, like a CTO case, the port of entry is always distal to where you see the rupture there. So that's the difference between the proximal and the retrograde entry, antegrade and retrograde entry there. So I think what I do is whenever I had this problem, I have to check where the balloon tamponade is, make sure that the balloon tamponade is helping. There is no contrast leaking out there. That's where the point of entry is. Always it is proximal to where you think it is. That's why you have to put in a little bit of longer stent graft or even putting in a proximal to where you think it is. But at the end of the day, it's a great case and great outcome. Congratulations.
Thank you very much.
So I just had one quick question/comment. When do you think the perforation occurred? You wrote in your slides about acoustic-driven perforation from IVL. I haven't heard of that. It was a low pressure inflation with the IVL, and then you post-dilated? Is that when the perforation occurred, or?
Generally, the most common cause of any coronary perforation is actually not the ablative devices. It's actually the NC balloon, because then you're oversizing them. In this case, I believe you mentioned it's 2.7, 2.8 LAD, and it was used about 3.0. Balloon was utilized. It's an oversized balloon. Again, the calcium, if you see it on one of the OCT images on the left side, it is clearly eccentric, like the C sign, and that's one thing that you have to be very attentive when you do those things, because the softer area yields more, and then the intramural hematoma extends outwards there.
And I think one learning point you made
this has happened immediately after IVL. we never post dilated.
Right.
Yeah.
Even there,
Yeah.
because the balloon dilatation has been there, so that's what IVL, it doesn't matter, right?
Actually, after balloon dilatation, we checked it. It was not there. No. Then we did this IVL. After immediately IVL, that's why when we didn't check the angiogram, we thought I'll do the OCT only.
Yeah.
During OCT, we could.
Yeah, no, which is unusual with the low pressure inflation. But
Yeah.
the one we have to move on. But one learning point I think is after the stent master was the graft master was put in, you still had leak. Rather than going to another covered stent, you post dilated,
Yes.
which is hard to do sometimes emotionally when you've just had a perforation. But these grafts that you're sealing perforations, you have to implant at higher atmosphere. So don't go quickly to put another covered stent. If you think you covered it as you did, the right thing to do, which is what you did, is a more aggressive inflation, which is stressful to do, but that's an important learning point.
Absolutely.
Great, thank you so much. We'll move on to the next case.
The next case is a dual intracoronary imaging and planning to limit contrast and get optimal morphology evaluation, followed by orbital atherectomy in complex calcific multivessel PCI. Dr. Ravikant.
Good morning, everyone, and thanks for the opportunity to the organizers. And here I'm presenting a case where both of them the two cases have elevated serum creatinine, so GFR is low and heavily calcified vessels. And we have gone through, as usual, like viability assessment and rest. Before discussion with the attendants regarding CABG option and all that. So this is the first case. This patient actually presented to us in last year, March 2025, somewhere in January with heart failure. And heart failure was treated and his creatinine was around 2.1 and around. So after treating the heart failure, this patient was eventually subjected to viability assessment, and all the territories are fully viable. Ejection fraction was around 30%, and heart failure stabilized. Angiography was done. So that was showing this was not the angiography what was there in somewhere in March last year. So initial angiography, left main was appearing good, and then there was of course, heavily calcified vessels with triple vessel disease. So if you look at this, when we took for intervention, so we can see that left main also is heavily calcified. Sorry that RCA picture is not there here. RCA shows moderate disease. The maximum stenosis anywhere is around 40%. Otherwise, diffuse disease, heavily calcified vessel, but RCA doesn't need an intervention. So with all this, we thought of, you can see how heavily calcified vessels are. So there was a discussion about CABG, all that, and finally we planned for a intervention. So the first thing we did is check shoot, which showed critical stenosis of left main, heavily calcified vessels, and hardly any flow in the distal LAD. So then OCT, or for that matter, any imaging catheter would go in, and creatinine is 1.7. That was in my mind. So the first thing I wanted to do is try a OCT catheter, but then before that a balloon. So I could realize a normal NC balloon was not going in. So then I took a Ryuri balloon 1.2, something like that. And then first I dilated the distal LAD lesion, which was quite critical. And that is about 3 times. And it is, of course, soft balloon. And then if you look at straight away, we took a Viper wire and exchanged it with the normal wire. And then we started to do the sanding. So sanding was slowly started with 80K. And I think about first 3 to 4 runs. And you can see And this is most of the times we would not give injections much. This is by auditory feedback. You can see when you're standing, when you're doing the orbital atherectomy, you can clearly see whether you are doing it on the rock or whether you are doing it to softer side. So with that auditory feedback, we started sanding, and I think this was the initial 3 runs, but overall we have done around 15 runs in LED. While doing these runs, always in the operator's mind, you will be worried about slow flow. Other one is the perforation. These two will be in your mind. So the sanding should be naturally very slow, and you should have a lot of patience, and which we did it for a longer time. And after this, also we could realize there is something around ostium as well as ostium of LED, distal left main, and then ostial LMCA. So after doing 80K sanding, so RPM of 80K, and then last one you can see we have done a OCT run. And this is the OCT run you can look at. So OCT catheter could go easily after this run. And you can see the calcium is still, there's no good debulking around the distal left main. The distal left main is actually elliptical, and there is a significant calcium, more than 1 mm thickness calcium, and it's medial calcium, intimal calcium. So even in ostial left main it is there. So you can see this extreme right end, the elliptical shape of the distal left main. And though there is a good sanding and good debulking around mid-end proximal LED, the ostial LED and distal left main still need something. So we did it with, rather than 80K, we went to 1.2, that is 1,20,000 RPM. And did around 7 runs there, and did a sequential ballooning with 2.5, 3.5, 3.5 dilatations. Then took, after this, you can see now the lesions healed, and initial distal stent is around 2.5 into 23, and the proximal stent is 3.5 into 33, and finally 4-row balloon and 4.5 balloon dilatations for proximal optimization we did. And LCX ostium has disease, but it is a diminutive vessel, and we didn't get any trouble with that, though there was a slow flow in it and some drop in a pressure at the end of the procedure, and it is not due to ischemia. Actually, it was due to a small retroperitoneal issue, which he recovered from eventually. So this is the final run post OCT. And we minimized, if you can see, it is a mixture of saline and contrast. So I always try to push entirely saline, but in left main you won't get good pictures. So you need to align it properly, and the clearance would not be so good. But a lot of times I try to push only saline. This is a mixture of saline and contrast. So this is actually more saline. You can see that is a saline, more saline run, less of a contrast. So there was some under expansion which he addressed with 4.5 balloon, and you can see LCX, which is diminutive, is not flowing, but eventually it opened up. So this is the first case which I wanted to show you. This is entirely OCT, and despite a renal failure, and saline we used is very less. Eventually, I think it's less than 100 ml finally with this intervention. That is because of mixture of saline and contrast which we did. And this patient is still coming to us for follow-up, and his LV function normalized, and he is able to walk about 30 minutes a day. And his creatinine is at right now 1.5 to 1.7, hemoglobin 10, and LDL under 50. So all going good with him.
So
So
maybe,
this is
should we just discuss the first case just because in the interest of time, maybe it's worth some conversation because I think the issue of renal failure and how to manage it or renal insufficiency and how to manage it, OCT versus IVUS, maybe some thoughts and because you have to give, and especially if you're looking at osteal left main, OCT versus IVUS, maybe I think that would be a good learning point for the discussion.
I think, as especially for osteal, because of the displacement of the blood is difficult. IVUS obviously has had an advantage over OCT. And OCT, as Dr. Ravikant has mentioned, used the saline flushes up to 10 to 15 cc, you can use it, and then there's good imaging there. But for the ostium of left main or the ostium of the right coronary, obviously, IVUS does have an advantage over OCT, that's for sure. And again, coming back to your point of the auditory response with the orbital atherectomy, I do slightly differently than you did, in nothing criticism-wise. I always give about half a cc to 1 cc of contrast after each run, just to make sure that there is no perforation there. I always do that.
I'm always worried about
right, I always do that quick injection, like not more than a cc, and then I know what it is, and then that's all I need to know. And
Do you believe orbital is safer than a rotational in these type of scenario? I think there's a lot of discussion about that.
It depends upon the operator, obviously, there. You know what I mean? I have done both of them for a long time. So for me, it really doesn't make a huge difference either one of them I took or I take.
Maybe just I'm sorry to interrupt, but people that don't do a lot of it,
Right.
is one safer than the other?
I don't think there is any difference in them there. I think, the one suggestion I would make is don't take the most complicated case like this as your first case. That way I can tell you that. Do the average or the middle complication, middle line complex case, and then you can get better experience with it. Both devices do the job. And the advantage of the Viper wire, however, is you can primary wire it. It's a great wire, so you can torqueability is excellent with the wire when compared to either rota floppy wire. Rota, stiff wire is difficult, so you have to use microcatheters to advance your wire anyway. That's something that you can, even without the torque, you can advance the wire there. And give nitroglycerin, make sure that, the vessel is not going to spasms there. And because it's a bidirectional sanding, the centrifugal force is the one that dictates the orbital atherectomy. However, I will make one point. Rotablation is much quicker. Orbital atherectomy, you have to be gentle and slower, like 1 millimeter or so there. That's the key difference. If you don't follow that, that's not going to help you.
And I think you emphasized that in your presentation, and that's a key point, is you have to be slow with orbital, and I think you made a great point of that. We have to go on, but can I ask you one question? What was your pharmacology in these type of cases? You're worried about slow flow. Do you do anything different? Do you try to keep their blood pressure a little bit higher in case they do get slow flow? Do you do anything different in a case like this where you're worried about slow flow?
Actually, I want the blood pressure to be more than systolic. If you take it, should be more than 100 or 110. So that should be maintained, number one. Number two, as Sir was quoting, you are always worried about slow flow and perforation. So in between, when you keep sanding, when it is extremely slow, you won't get that at all. And if you are, if there is a slow flow or something, the pressure drops down. So immediately, and I keep everything ready. Like most of the times, this is probably 22nd case of orbital atherectomy. So earlier also, I've never used IABP in these cases. So but noradrenaline, dopamine, all vasopressors will be ready to keep in. And I want my mean arterial pressure to be higher. So anywhere it comes down, I try to first check whether there is anything, any leak from the groin or any perforation there. And if they are not there, you will try to push some fluid and then along with that vasopressors. And I want the pressures to be higher. And about slow flow, I keep checking. And if it is slow flow, I've seen one is majority of times you go down with the catheter and give some injections like nicorandil and then rarely nitroprusside. One case I have given nitroprusside. And I'm always worried. You have already low pressures. You want to give these drugs. It's really shaking. But I never had a problem in orbital atherectomy. One perforation happened in RCA, right coronary artery. We recognized immediately and put a cover stent. So in fact, I presented that case as well. That was the only case I had a trouble. That was RCA.
Thank you so much. We'll have to move on.
120.
Went with 120. Yeah.
Yeah, 120K RPM. That is because the diameter of the LMC was huge. So 80 wouldn't be sufficient. And we wanted a good debulking there, especially Australia LAD and Australia LMCA.
Wonderful. Thank you so much.
Thank
Great
you.
case.
Next one is Catch Me If You Can, Stent Migration Story and Retrieval by Dr. Kedarnath.
As you're joining, many of you are asking for agenda. One is that the back of this has a barcode. If you put your phone, it straight goes to agenda. That is one. Other thing is we distributed these newsletters that also has agenda. If any of you are interested. And this barcode, once it goes, there's also a feature called Ask a Question. You type it on it, then it will come to chairperson, and we'll one of them the better case questions. We'll try to get you on for discussion to save some time.
Good morning, everyone. Thank you for a very great opportunity. I'm from NRI Medical College, Guntur, and I'm presenting this case on behalf of my team. I'm one of the fellow under Dr. Surendra sir. So this is a routine right coronary artery PCA, planned PCA, which was converted to femoral snaring and retrieval of a malpositioned RCA ostial stent. Our patient is a 67 years old male, hypertensive and dyslipidemic. He has undergone previous CABG with patent lima, but occluded SVG and SVG to OM and PDA grafts. His EF is 50 and he has a previous PCA to LCX. Now he was admitted for elective PCA to his native RCA. This is the baseline angiogram of RCA. So we went on as all of us would do through right radial approach, JR catheter and wide with BMW. You can see there are significant lesions at a mid and proximal RCA. Proximally, there is at ostial RCA, there is a dampening. So we need to disengage and give the injections to prevent the dampening. So the lesion was prepared with 2.5 mm score flex balloon, both mid and proximally, followed by it was stunted with Zines 2.7528 at distal end, and then second overlapping stunt at proximal end of 3x38. After two stunts, this is his angiogram. There is a residual significant ostial disease that need to be addressed. So ostial lesions tend to dampen, and there will be a geographic miss. So we used a Sepal technique. In this Sepal technique, what we do is we place a second wire in the coronary sinus, and we abut the guide towards the ostium so that ostium is not engaged, but we will know the detailed anatomy and the exact point where the ostium arises. We positioned a overlapping 3.5 into 12 mm stent at the ostium, and despite the instructions while inflating, patient has a sudden movement with deep inspiration immediately prior to the deployment. This shifted our stent posteriorly into the aorta. So we attempted rescuing this by optimizing with 3 and 3.5 NC balloons at high pressure post dilatation. But the ostial stent is failed to flare adequately. You can see there are multiple stent threads remained unopposed, hanging freely into the aortic root. So this need to be tackled, or else there will be a thrombosis, or it may prevent the future interventions like again doing PCA or during TAVR. So our strategy shifted to immediately retrieve that proximal stent percutaneously. We attempted snaring through existing right radial route using both JL and AL catheters, but they didn't give much vector support or backup support. So we switched to femoral axis, and with the help of the AL catheter to provide maximal coaxial and backup support, successfully engaged and snared the distorted ostial RCA stent using a gooseneck snare. This is the stent that came out, which was distarted. It is a short stent so that we can easily snare it out. So we switched it back to 6 French JR4 and successfully deployed Zines 3.58 mm precisely at the ostium. So this is the final angiogram, got a TIMI3 flow with overall good stent apposition, symmetric expansion, and no residual agitation. So what's the case? This could be prevented by deploying the stent at a deep inspiration or asking the patient hold the breath, so the diaphragm moves less and there will be less movement during inspiration and during cardiac movements. And we should favor a longer stent at the ostium whenever feasible to minimize watermelon seed effect at the ostium. So the aorta-ostial stents remains highly challenging due to cardiac motion, respiratory variation, and precise geographic boundaries. The technique we used is a Sapal technique, a floating technique, or other techniques are Sebo technique. They are valuable techniques to safeguard against excessive aortic protrusion and geographic miss of the ostial stents. Despite this, sometimes patients' respiratory cycles and some sudden patient movements can lead to complications. We should be familiar with diverse snare devices which is critical for complication management. Thank you.
Thank you.
Excellent presentation, Kedar. The 2 points I think everybody should be familiar, especially for the right coronary ostium intervention, is the Sapal technique or the floating wire technique, where the stiffer portion of the wire actually should be in the aorta. So that whenever you are going to deploy the things, the key thing that most of the times a lot of people miss is not to advance the guider. You have to push the guider into the ostium as much there, but it's not going inside because the stiffer portion of the wire prevents it, plus your balloon complex also prevents it there. It was done in this case, however, because of the breathing patterns and everything you have to be careful about. And interventions are getting complicated and complex, and you should be familiar with all these things. If these things are not done, there is no other way you can access this right coronary again in the future. You can leave it, but the risk of thrombosis is there. But again, as Dr. Kedar mentioned, their future TAVR or future right coronary intervention is going to be extremely difficult. One point I will always make to the fellows also is, whenever there is a right coronary ostial stent, the best guiding catheter you should try, don't even worry about JR4, AL 0.75. That actually sits the best there, and that's one tip I can give you that for that. And that is one of the best guiding catheters to engage the ostium properly there. And again, the key is don't panic, just do the thing slowly, and then you'll be fine there. Excellent presentation, Kedar. Thank you.
Thank you.
I guess the only question is 8 millimeter stent. Is there, I just generally almost never use an 8 millimeter, especially at the ostium for this reason. A little bit of length, and then you, even if you hang out, you can flare it with either a dedicated balloon like OsteoFlash versus just post dilating aggressively and manipulating the guide. You made that point. I think that's important to consider. Like a little bit longer stent is probably not a bad idea, just for safety reasons. Is something that, and then instead of snaring, whether you could have put another stent more distal, anchored it, and then flared more aggressively. But so much of it was out that I think that was a challenge.
The problem is, once you had 2 stents there, then the ostial restenosis is going to be very high also because of the location of the stents. So you don't want to have 2 layered stent there, because in the future, again, the key is whether we can access the right coronary there. Coming to your point of putting a longer stent, apparently it looks you got the 30/38. So you don't want to have too much overlap on the other stents there too. I'm not a big proponent for too much overlap of the stents, because I just want to minimize the overlap, because that's point of restenosis also as much there. And again, good case. Thank you. Any questions, please, there?
So I can't read them from here. Can you read them?
I do.
Okay.
For the questions which are displayed there, most of the questions were in sizing of the balloon 1:1. I think that's important to keep the size under control. Now you can go a little high pressure, but the sizes should be kept under control. That's a mantra both for, I think, even for high pressure OPN versus that answers 2-3 of those questions. And what is the protocol for inflation of Scoreflex balloon? Also is saying 1:1 is charted. This cutting balloons don't go like a NC balloon to very high pressures. You need to keep go up to the pressures what is limited at 6 atmospheres per Wolverine. Each balloon has it on it. Don't go too much high pressure. And one other precaution is once you did dilatation with this, they are not the balloons to rub in and out. That will produce a lot of problems. Like a routine NC balloon, don't use the cutting balloons to go in and come out because it could produce low flows and problems. Be careful, get it out. And as Sushil mentioned before, if you want to post dilate with the bigger size balloon. The other different NC balloon, I mean. So orbital antigrade sanding, slow speed, and retrograde high speed. What is the protocol? Dr. Pramesh is asking. Can you say some?
Yeah, I can answer. There are three questions. I can combine them together. One question is size of the particles generated. Does orbital causes more slow flow or the antigrade versus retrograde? And I can answer all of them in one context. Then the size of the particles is approximately about 9 to 10 microns, which are taken care of by the reticular endothelial system, either the rotablation or the orbital atherectomy. The orbital actually, as the previous Dr. Ravikant, I believe, has done that. When there is a concern for slow flow, orbital atherectomy is an advantageous device when compared to rotational atherectomy because of the bidirectional flow. Plus, it is an orbit there, so there is a space for the blood flow to happen. Then the heat generation is probably much less in orbital atherectomy when compared to rotational atherectomy. Rotational atherectomy is central, as you can see, it's like a bulldozer is just going through, whereas orbital is generally around there. So the heat generation tends to be somewhat less. And again, you're banging in a way there, you're going opposite to these walls there. It is like in the rubber industry, in the car tires and everything, that's what they use, when you really kind of make any material softer as much as possible, it never goes back to its original shape. So that's what the orbital atherectomy or these atherectomy devices do, because they're hitting the wall and then the wall becomes fractured there. In fact, actually, I don't know, Dr. Ravikant didn't show it there, but in the B pointed image as labeled as B, you can see the orbital atherectomy has a scoop-like. Actually, it is almost like a cup-like cut there. It was there. And, that's a classic orbital cut that you can see even without knowing anything. Once you see that in the image, orbital atherectomy was used. And I think the predilatation, the slow flow phenomenon is somewhat better with orbital atherectomy, meaning it's less when compared to rotablation there. I hope it answers your questions.
Thank you so much. I think that's helpful, and we'll continue to pay closer attention to the questions as we go forward. We're a little bit behind, so we're going to try to catch up a little bit. Now, our next speaker is Dr. Sen, a heavily calcified left main bifurcation nodule managed by OCT-guided bifurcational rotational atherectomy.
Good morning to judges and chairperson and audience. And thank you so much for giving me an opportunity to this conference. I'm Dr. Sen. I would like to present my case is heavily calcified nodular left main bifurcation when managed by OCT guided bifurcational direction, both directional rotational atherectomy, PTCA. The case history is a 78-year-old male presented with unstable angina. He was treated as a 2004 with bare metal stenting, and another ISR was developed in 2005 and done the debilitated stent over there. Severe risk factor like hypertension, diabetes, and dyslipidemia and COPD. Fortunately, was not CKD and creatinine was normal limit. The ejection fraction about 50% and EGFR about 61. Symptomatic unstable angina with despite the all medical management, the Euroscore 2 was 3.1%. The syntax score was 33. As per the 33 syntax score, the class 2 or 3 indication, as per the guideline, though we calculate that other syntax 2 score, the PCI for the 55 and surgery for the 68. Though so little bit higher the mortality, we have discussion with the heart team and go for the PCI, left main PCI. Imaging is very important, so we have chosen the OCT guided over the IVUS and the calcium modification, rotational atherectomy, and no mechanical support. The ejection fraction was 2 and patient was hemodynamically stable. RCA is supposed to become non-critical codominant vessels. Look at the angiogram. Heavily calcified nodule, the distal bifurcation of the left main. We can see the nodule easily, and the disease, the 111 Medina classification, and we just have chosen the OCT over the, because of we can see the image is very much important to just enter the balloon and dilatation as per the NC balloon. So we have taken the image by the OCT. Because of the calcified nodule is a heavily calcified nodule as a classification about type 4. The both directional, the calcified nodule, the IVUS or OCT, both option is there, but the OCT just identify the deeper calcium and better the depth of the calcium is as compared to the IVUS. Look at the OCT run. The mid part of the LED, the stent, previous stent was there, and some calcification, new antima thickness and atherosclerosis, and go for the left main and just check the calcified nodule just 5 o'clock, and another image from LCX to the left main. Calcium, the 360 calcium and the proximal, and this nodule, the about 2 or 3 o'clock, heavily calcified nodule. What we have chosen the two, either 1.25 mm or 1.5 mm and 1.75 the size of the wire, but the chances of the stacking of wire is the high size. So we have chosen the first 1.25 to run with the 160 to 180,000, and another left main to the LED. Another size of the left main, again we did the rotablation by the 1.5 mm wire, and second step, the rotational atherectomy done left main to the LCX side. This is the angiogram, post-rotational atherectomy. We have done the imaging again after the rotational atherectomy. We can see over here some debulking of the plaque and calcified nodule. After that, we did the pre-dilatation kissing, dilatation of the ostium of the LCX and left main to the LED, and stenting to the LCX, the Onyx stent 3.0 into the 16. Press the stent by the balloon from the left main to the LED, and rewiring and kissing 3.0 and 3.5, both balloon and pot with 4.5 into the 10 mm. This is the final result. But without imaging, we just finalize this image. Okay, this result is good, but imaging is must. See the image after the decay crush. This is this first image from LED to the left main. Initially, in the left main, the good expansion and good apposition, but the left main side, the malapposition and under expansion. And another image from LCX to the left main. This stent is okay, good expansion and good appose without any dissection and complication. So we finalize the kissing balloon inflation with the high pressure pot. After the high pressure balloon, and change the balloon size and 1:1 and kissing. This is the kissing. And next image is the final pot. We have chosen just 0.5 mm higher side, the 5.0 into the 8 mm balloon with the high pressure because of the calcium. And this is the OCT final result. good expansion, good apposition, no dissection, no stent deformity. The left main. Good result. And see the angiogram. Good T3 flow without any complications. Take home message. The rotational atherectomy is good choice in case over the cutting balloon, scoring balloon, or IVL in the both directional or type 4 calcified heavily nodule. In complex left main, calcified perfusion legislated nodules. The imaging is must in the every setup case of the nodule. We are looking for the angiogram. The which IVUS or OCT we can choose any type of the imaging, but in this case we can choose the IVUS also. But fortunately, the creatinine was normal, and the deeper part of the calcium we can see easily with the OCT over the IVUS. Although the IVUS is a guideline, as per the guidelines, a choice. And another is the technique. We already familiar about the DK crust technique for this bifurcation nodules. And OCT and IVUS is very pretty choice to handle this case. Thank you so much.
So can I ask a question? A eccentric nodule in a big vessel like a left main, what is the best debulking, and what is the role of like guide manipulation, wire choice, changing the angle of entry or trajectory to try and debulk as best as possible? And do you go from both the left circ and LAD in those choices? And does OCT give you any clues? Sorry, a lot of questions, but the eccentric nodule, how do you manage?
My first point is excellent, great case, congratulations. At least for the new learners, what I would do slightly differently is I would have a right heart cath at least to see what the LVEDP, because we're doing the left main situation there. Then that gives me an idea whether I need some sort of support there. That's one thing. Second thing is to answer left main is bigger. It's probably 4.5 in anybody there. And orbital atherectomy does not have the same caliber to achieve that more than 3.5. So rotablation is ideal, or IVL is there. The calcific nodule wise, still I prefer in the other vessels, plus in your situation, rotablation makes sense because you already had a stent in the proximal to mid LAD, so you don't want to use an orbital atherectomy in that situation there, so you can save the devices there also. That's one. I think the trajectory wise, my course of action is always the LAD because the wire tends to be more straight, so that I can avoid any wire bias actually there. Just a key point there to avoid the wire bias, the simplest technique you can do is advance the wire as distally as possible with any other assisted devices like balloons or microcatheters. But rotablation is the right choice in this situation there, and I think it's an excellent outcome and excellent result there. Thank you.
Thank you.
Thank you very much. Great case. Thank you. So we'll move on to the next speaker, who's
heavily calcified left main bifurcation nodule. Oh, no, I'm sorry.
No.
Expect the unexpected coronary perfusion in PCI, Dr. Jitendra Jain.
Very good morning, and at the outset I would like to thank ACVS for giving me an opportunity. So my case is about expect the unexpected. Like you see, when you see that most of the times we feel that the case is easy and sometimes we land up in complications. So this is about a 68-year-old male who presented with chest pain with breathlessness, diagnosed as unstable angina. 2D echo was fine, EF was around 55%. Angiogram was done initially, which showed a left main with triple vessel disease. So these are the images. You can see the left main in the epicaudal, which is significantly calcified as well as significant. In the epicranial, LAD is type 3. You can see even on fluoroscopy also heavily calcified at the mid part of the LAD, at the diagonal and the septal. Which is almost heavily on both tram taxane you can see there, but significantly disease up to the mid LAD. Circ, it looks like borderline lesion, not much. RCA is a dominant vessel with a significant calcium. Even on fluoroscopy you can see the mid part of the RCA is heavily calcified and significantly diseased. So the option, revascularization patient was symptomatic. We thought of the option of both CABG and multivessel PCA, but patient opted for multivessel PCA. So my strategy was, to do a bifurcation strategy that is a provisional from the left main to the LAD. As it was calcified, imaging was mandated to understand the calcium extent and distribution. So depending on that, I wanted to select the calcium modifying strategies, whether it's IVL or a cutting balloon and so on. So started with a run through wire, first pre-dilated so that my imaging should go down. So I thought of using an IVUS. So initially pre-dilated, you can see the dog boning in the proximal LAD, which is heavily calcified. So after that, we dilated up to the austere part of the LAD with different balloons. It was a fair result here, nothing significant. I did an IVUS. So I was from the mid part of the LAD because my strategy was to from the left main to the LAD, a provisional stunting. So LAD, you can see the vessel size was around 3. There is a fibrotic lesion which is starting from the mid LAD. And especially at the septals and the diagonal, you can see there is a nodule there at 10 to 12 o'clock position, which is significantly, almost 360 degrees of calcium is there. So among the calcium modifying strategies, I thought of using IVL for this case rather than a cutting balloon because the nodule, for breaking the nodules, always IVL is better. So a 3.5 12 shockwave lithotripsy was used from the mid part of the LAD up to the austere LAD. So I gave almost 80 to 100 pulses. And you can see at 6 atmospheres, the balloon is well expanded. So it's nothing much in the here. So there was at this time, I was not expecting much of perforation there. So I started from the left main to LAD with 3.5 under expanded, going with 6 atmospheres so that the distal part of the LAD was 3. So after that, I did a post dilatation with the 3.5 and then 4.5. In the mid part of the LAD, I could see there was some amount of under expansion. So I took again an NC balloon and tried to dilate it. And this is the result on the left side. Nothing much. Circ is flowing well. LAD is fine. I did an imaging. There was some amount of under expansion in the mid part of the LAD. Even with an IVL also, I could get an MSA of only 4 to 4.5. Not much. So again, I dilated with a 3.5. So 4.5 was acceptable at this time. So this was the LAD. This is the final result. After that, I took the RCA. I thought, RCA was not much heavily calcified. Not expecting anything. I did a pre-dilatation. Took an guide, the mid part of the RC was difficult for me to negotiate the balloon. And at that time, I did an IVUS. IVUS showed a fibrocalcific lesion, not much like you saw in the LAD. It was like 270 degrees of calcium, superficial calcium was there. So I took a 3.5 scoring balloon at the mid part of the LAD and dilated it till the ostium. Suddenly I noticed patient had a chest pain. There was not much of hypertension, but suddenly I realized that there was a perforation in the mid part of RCA. It was a Ellis type 3 perforation. So initially, as per the guidelines, we started with the balloon tamponade, started with 3.5, kept it for 5 to 10 minutes. Multiple inflations were done. And after that, I rechecked with an angiogram. Again, there was still a staining there, leak was there, persistent. So I thought I will go with a covered stent at this time. So it was easy for me that bulky stent to negotiate to the mid part of RCA. And even though the guideline was also there at the shelf. So I took at the lateral projection for me to clearly understand exactly where I'm locating. Like sometimes, like I said, always the proximal part we miss if we take a shorter stent. So a 2.819 graft master was taken and deployed at high pressures. So after that, the sealing closed. But you need to post dilate, especially when you take a conversion stride. Post dilate with 3.5, and after that, the sealing was totally the perforation sealed well. Then the rest part was easy. Patient was stable. There was not much of changes. So I did the proximal part, and with the 3.548. Distally, after the cover stent, I noticed that there was some haziness there. and I was showed some amount of dissection. So I covered the distal part also with another stent. So I was done. This is the final I was. So the I was run showed a well opposed stunt. There was no dissection there. So I was mostly interested on the covered stunt, whether it's properly expanded or not. So this is the covered stunt. You can appreciate the hyperechoic area because of the PTFE graft. You see the acoustic shadowing there, which is well opposed. So these are the MSAs. I got a good MSAs. The final result was good. Patient was stable. It was a 3-meter flow, no dissection. So always in my case, if you look at the perforation, my case patient was elderly. It was a procedure related, which was not expected. The main problem was the cutting balloon, which I oversized by 3.5 in the mid part of the RCA and then gone up to high pressure. So probably that is the reason where I had a perforation. But luckily, the cover stunt went and I was able to, do the procedure successfully. So thank you. Thank you for this.
Very nice. Mhm. Nice result there. If I can go back to the IVUS of the right coronary, please.
So I think it's got. Can you
Stay on
play
the
the
slides, please?
Stay on his slides, please.
Can we go back to the slides? Thank you.
Post balloon, I mean post cutting balloon or post balloon.
Yeah. So it's not playing, I think.
And I think one of the, in the right lower hand corner, one of the images, you can see there is a little bit of an hematoma there on around 4, 5 o'clock position. I can tell exactly. I know I don't have the picture here. And I think that's kind of prelude for us there that it is something might happen there. It's probably because of the overstretching of the vessel and everything. It's a nice image, actually, you can see it. Sometimes you can see those speckled pattern just in the media towards the adventitia there. That also is the blood cells. Then that also gives you an idea that impending rupture might happen there. And again, the key is to stent as far as proximal also, because the port of entry for the rupture is not exactly where you think it is. It's always proximal when your axis is antegrade.
So there's some couple questions here about the strategy of managing a perforation. One, do you always use the ping pong strategy with the second guide? I guess it depends a little bit on the hemodynamic stability and your deliverability, what you think will be the deliverability of the stent, correct?
Yeah. In this situation, I think the patient is stable as the concept of block and deliver concept there, meaning single guide, or the ping pong or the double guide catheter there. At this time, especially, I think you mentioned she is a small female, I believe there. So probably doing a single guiding catheter, probably I would have done the same way, because then you're risking the more groin complications and everything there. And I think that technique worked, and it looks very good at the end there. And that's a great case, actually. Ping pong technique works the best, but obviously in this situation, you have handled it very well. And interestingly, you didn't have to do pericardiocentesis. You know what I mean? That is lucky, and sometimes it can happen that way there. And actually, the clean criteria, as they call it there, the CLEAN criteria in terms of coronary bypass surgery, or the length of the lesion, the age, and ejection fraction, also calcific nodules, the CLEAN criteria are very predictable. Actually, they predict very well. And also, as I mentioned before, not to repeat myself too much, but the C-type or the C-cat sign actually on the ultrasound, which this patient had too also. Always want to be careful not to oversize in the situation there, because it gives you the point of least resistance.
So patient had only mild pericardial effusion at that time. So the patient was hemodynamically stable, so there was no need for pericardial tamponade. And second thing we expected, actually, it was the left side when I was doing NIVL. I was thinking of, probably there could be the reason, but it was the RCA, which was a surprise.
Thank you so much.
Thank you.
Thank you. So we're going to move on to our next case presenter, Dr. Divya Sai, on laser, light, and protection, salvaging a thrombotic SVG graft.
A very good morning, everyone. Thank you, organizers, for the opportunity. I'm Divya from NRI Medical College, Guntur. I'm one of the fellow under Dr. Surendra sir. So I'm going to present a challenging case titled Laser Right and Protection. It is a story about salvaging a thrombotic SVG graft. Coming to the case details, he is 81-year-old male, post-CABG in 2007 with a patent Lima to LAD and sequential SVG graft to OM and PDA. With the comorbidities of paroxysmal AF, hypertension, dyslipidemia, heart failure with reduced ejection fraction with biventricular ICD, and on CKD stage 3. Importantly, he has a history of prior SVG PCI in 2023. Now he presented with intermittent and worsening exertional angina over 2 weeks with progress to 2, constant substernal chest pain, and he was admitted for ACS evaluation showing elevated troponin levels and ruled in for NSTEMI with recent left ventricular ejection fraction around 45 on guideline-directed medical therapy. So this is the EKG of the patient. As mentioned earlier, he was on ICD. It is a ascensed V-paced rhythm with frequent PVCs. A brief history about prior cath in 2023. He underwent intravascular ultrasound-guided angioplasty and stunting to saphenous venous graft to obtuse marginal. 3 overlapping stents were placed, which was post-dilated with a 4 NC balloon. And this procedure was complicated by no reflow and cardiogenic shock requiring IRBP support. So this is the present cath of the same SVG graft. Initially we have taken left radial axis, but later switched to left femoral axis due to tortuosity and significant spasm. Here we can appreciate SVG was engaged with AR modified catheter, and we can appreciate significant ISR in the proximal area of 99% with intact distal OM2 and RPL branches. And the Lima is patent, reassuring that anterior circulation is protected. And this is the native TVD showing a significant disease in LM, LCX and LAD. And this is RCA with this large vessel, and diffuse stenosis was noted in a range of 90% in multiple areas with distal CTO. So at this stage, we adopted a staged PCI. So first we intervened LCX. So LM to LCX intervention was done. And the result was good. So after intervening on LM to LCX and having the knowledge of prior complications during SVG intervention in 2023, we planned a staged procedure for SVG, anticipating a complex intervention with knowledge of significant no reflow phenomena in this graft area. And these 2 days, patient was continued on heparin, integralin, IV infusion with anticipated SVG intervention, which is going to be complicated. So after 2 days, patient was brought back, and this is the repeat angiogram of the same graft. And he was, in spite of giving continuous infusion of heparin and integralin, now we can see there is a total occlusion of the proximal graft with the heavy thrombus burden, a clear progression when compared to angiogram done 2 days earlier. So intervention was done from right radial, AL1 guiding catheter, and cyan blue wire was used for crossing. So at this point, we are dealing with a highly degenerative SVG with a heavy thrombus burden with a prior history of no reflow. So adequate intracoronary medications were given, nitroglycerin, adenosine and heparin was administered, maintaining adequate ACT. And the intracoronary integralin was utilized here. So coming to this complex lesion with the thrombus superimposed on ISR, so we considered laser for ablating and vaporizing this thrombus to minimize the distal embolization and no reflow or no slow flow and reflow phenomena, which was there in previous intervention. So the idea is to achieve adequate lesion perforation before any further intervention. And we utilized a laser atherectomy. So this is a Vitase 0.9 mm laser catheter. After adequate saline flushing, initiated at 45-25 fluency and rate, and subsequently increase it to 60-40 and thereafter 80-60. Multiple passes were made with each energy and time. And then OCT run was taken. Here we can see still a large residual thrombus with the predominantly red thrombus at the lesion site and thrombus protruding into the lumen. So again, we decided to do the lasing again. And after multiple passes again, and the result was good. Restored a TIMI3 flow with a good distal runoff. And later, as planned earlier, we decided to place a embolic protection device filter distal to the lesion before going into further intervention. So here a filter by reset 5.5 was utilized and placed distally. And then as it's an ISR, we adopted a balloon angioplasty with drug coating balloons. 2 overlapping DCBs were utilized of size 3/530. And then final OCT image at the lesion site. Significant thrombus reduction we can see here. And a good luminal area of about 8.96. And this is the final result with the good TIMI3 flow and a significant reduction in thrombus burden. And also importantly, no complications of distal embolization and no reflow. And the distal OM2 and RPR are also patent. So the key learning point from this case is having knowledge of prior intervention history and complication history will definitely shape our strategy. And it helps us to prepare the case in advance and having right tools for successful outcome. And intracoronary medications plays a major role in reducing the no reflow phenomena. And definitely laser has a great role in high thrombus burden lesions, especially SVG grafts. And embolic protection devices are very effective in reducing these complications. And lastly, intracoronary imaging adds real value in guiding these complex interventions. Thank you.
Thrombosuction?
Any role of thrombus suction? Yeah.
Any role of thrombus. The problem is there is so much thrombus there. The concern is whether to put in bigger catheters that will embolize more. So that's why we just a simple wire and then we ablated the thrombus as much as possible. And our strategy is very similar, especially for an osteal LED lesions, especially off the left main. If you see a thrombus or a meniscus sign, which you like in a concave shape, then we always like to use the laser, especially the newer one, because the activation time is much shorter, so that I'll have a channel there and the embolic phenomenon is much, much less. That's our strategy. That's the reason why, if you see, the filter was not put in right away. The filter was put in at the middle of the case there, once we knew the thrombotic burden is much less there.
We have no laser.
What if no laser?
That's a great point. That if you have no laser, then you have to take our choices. The key thing here is probably giving mostly the intracoronary drugs, as much as adenosine nitro and verapamil and whatnot. You can give Nicardil, whatnot, and then probably a small aspiration catheter, and then see whether how much you can, angiojet will do the job also there. But the problem with all these bulky devices is, especially given the history for this patient at an outside hospital, as per the reports, because we never had the angiograms per se, the risk of embolization is very high. And as you know, once no reflow happens, the mortality goes higher, heart failure goes higher, the hospital stay goes higher, every complication can happen there.
I think one important point that maybe question from the audience.
After revascularization of the native L circumflex, what is the need for graft PTCA, number one? And second thing is, when you want to put a distal protection device, generally when you have space, it's better to put at the beginning, is my opinion. 2, 3, in the context of this much thrombus, actually, what is the efficacy of drug-coated balloon? Because you have to oppose it to the media, that's where the drug has to go. The drug-coated balloon is just an agent to deliver the drug to the media. Here the graft will be somewhere around 5 millimeter. IVS would have been a better bet than OCT to image. That is one more comment. Can you give that?
So the first question is why to intervene if you open the native circ? What is the role?
Sir, here we can see the SVG is also supplying RCA. It's a sequential graft from LCX to RCA. So for LCX, we have revascularized, but for RCA, it's better to do SVG intervention because RCA CTO, the distal RPL is supplied by SVG.
Anyway, that native circumflex would do the good job, right?
Right, but
LM
the problem is that OM graft, actually before the OM graft, the native OM where the graft is attached, the osteal, has significant lesion also. So you don't have any retrograde flow coming into the circ also for that, And we thought about it there in a way where we should even avoid that. But I think, that's the reason why even the small OM, we protected that before we did the vein graft to give as much benefit as possible. Coming back to your point of the IVUS versus OCT, the graft is about 3.5 millimeters there. The key factor for people who make mistakes in the vein grafts is they want to go to high pressures there. The data for the vein graft says you should not do high pressures at all because most of the clot will extrude actually through the stent grafts again there. The stent struts again. So the key is nominal pressure there. The vein graft's going to degenerate as much as possible there. That's the reason why when we did that, we did the OCT one more time to make sure as minimal thrombus burden is there. That's the reason why we did so much laser before we did the TCP also there.
Distal protection device, doing it a bit later actually. That almost you put a stent, you did everything, and finally putting distal. How much protection it's going to give?
It is, but in the beginning, you don't want to do the distal protection device because it is a bulkier device, right? Again, the key thing here is the history. That's the reason why we presented this case, as we all learn. I don't think they used much distal protection device as per the reports from the outside hospital when they did it. That's our concern at the time there. That's the reason why once the thrombus is less, it's not that the distal protection is going to protect you from every thrombus. You want to take every precaution so that the no reflow phenomenon does not happen there.
Great. I think these are important points in discussion.
DCB sizing here, what they've used, and with the OCD, I think most of the grafts will be somewhere around 4 to 5 mm, to be frank.
But delivering drug to the side, the stent, the size of the stent, I think you're sizing it. There,
we just
making contact,
just
make contact and deliver drug to the neointima there.
Wouldn't have done just.
And also, you have to understand there is not that much media in the vein graft either.
Yeah. So I think we have to move on. Thank you so much. Excellent case. So our next speaker is Dr. Lokre, IVUS guided left main to LAD, provisional bifurcation, reverse T-like stenting with double kissing balloon. So before we go on, I think one important point on that last case, that waiting for the to do the intervention and pharmacology is an important component. I think don't rush into those cases. I think just to highlight for all the people out there, waiting 2 days, letting pharmacology work as much as possible is a good step as well. Wonderful. Thank you so much. Get the slides up, please.
With your permission. Thank you. Namaste to everyone. I'm Dr. Lokre from KIMS Gachibowli. Before I actually start my case, I'd like to ask how many of us do osteal stenting, osteal LAD or osteal LCX? At least did in the past. Quite a few of us, I hope. So this is one of those cases which went wrong. Actually done elsewhere. How do I move my slides, please?
I think you went past. There you go.
Yeah. So my patient was an elderly gentleman, hypertensive, chronic kidney disease. Please make a note of that with a creat of about 1.7. So a GFR of about 40. Old stroke with residual hemiparesis. Although he had a decent functional capacity now, has a history of stenting to the circ, osteal LCX, as it was mentioned in the report about 2 years ago. Then currently he presented to us with an NSTEMI, good LV function preserved. Then he also had an acute kidney injury on top of a chronic kidney disease with a creat of 2.2. We hydrated him. And then this is the angio. So not playing. How do I? Can somebody play it for me, please?
I can.
Can I present from there?
No microphone here. I can play it.
Yes, sir. If you could just play the angio for the audience, please. So I think it's quite clear. There's a distal LMCA significant or tight lesion. There's an ostial LAD tight lesion, and there seems to be some disease at the ostial circ as well. So this is an ostial LCX stenting done in the past, and there is disease at the LMC and ostial LAD. What would we think? Probably something had gone wrong at the ostial circ or the POC. So what are the issues I have now? The foremost I would consider was a CKD, significant contrast limitation. It's an acute coronary syndrome setting, and he had a stroke in the past. Although he had a good functional capacity now, I don't want a repeat of the same this time. And of the coronary factors, it's an LMCA disease. It's a left dominant system. It's a bifurcation lesion, LM bifurcation, Medina 110. However, the 0 here means an ostial LCX stent and possibly protruding into the LM, which we will know we can't see on the angio, but possibly we can see on the IVUS. So initially tried to pass the IVUS, wouldn't pass. The small balloon 1.5 wouldn't pass. So I had to perform a sequential dilatation with 1, 1.5, then 2, and then eventually IVUS passed. And this is the pre-IVUS run. So I would like to bring your attention to a few frames here where you can see some stent struts are actually protruding into the LMB. There are some pictures there which show the same. So indeed, there was some stent protrusion from the ostial LCX into the LMB or the POC, which is causing some turbulent flow across the flow divider there, and therefore there's a disease developing there, which has extended onto LM as well as LAD, causing significant stenosis in both of those. So what do I want to do now? I want the struts away from the ostia, both the ostia, and also maintain the carina. So I want to do a kissing. Actually, prior to any stenting, I want to do a kissing first so that I could centralize my carina. Then I want to stent across from LM to LAD. Then I want to prevent carinal shift even after stenting, so I have to do a double kissing. And then for that to be done, I need to do a part prior, and then of course a part after the kiss. And of course, everything has to be optimized under imaging. So I used IVUS as it is a kidney disease patient. Not that I had the luxury of OCT, but yes, predominantly it was a medical decision. So these are some of the representative pictures. Now, note that these are after the dilatation with a 2O balloon. The diameters were quite evident here, but notably distally there was some mild diffuse disease, so I needed to use the intima to intima diameter. And so applying the MLD max, which is usually applied in OCTs, we have a morphology of predominantly a fibrotic plaque with some calcification. Lesion length turns out to be 15. There was mild disease, as I mentioned, at the distal landing zone, so I needed to use the intima to intima diameter, which came to about 3.2 instead of the 3.8 vessel. And the stent choice depended on the length of the vessel, the lesion, the diameter, and the expansibility. So we understand the Zines 3.5 can go up to 5.5 easily without fracturing. And LMCA being quite roomy, we may have to take it to 5, 5.5, or even beyond if needed. So we chose a Zines Sky Point. So I want to prepare my LAD bed, a 2.5 cutting balloon, initially 3O NC, and then the first kiss, then same thing. Then after the kiss, I stented across from LM to LAD, and then the first part with the distal marker at the bifurcation point. And then rest of it is fairly the usual. Remove the wire and recross across from the distal strut, then sequential dilatation, 1.5, 2, 3, and then a second kiss, and then a repart, taking care to avoid touching the neocarina. The marker is pulled back slightly, or the balloon is pulled back slightly, and this is the post-IVUS run, which will now show you that there are no stent struts across the LAD or the ostial circ areas here. Now, although the expansion could have been perhaps slightly better, as I said, it's an acute coronary syndrome situation, the kidney disease situation, elderly person, old CVA. Keeping all those in mind, and that we had decent areas according to the required criteria. We had nearly 8 mm square in proximal LAD, 8.5 in the ostial LAD, 15 in the distal LM, and over 20 in the osteal, in the proximal LM, which were quite satisfactory. So these were the ones which I mentioned. There were no medial dissections and good apposition. These are the final angiographic pictures, which seemed fairly satisfactory. So we ended there, and what I learned from this is the so-called osteal stenting LCX or LAD is kind of a myth. We either have a geographic miss or have some stent strut protruding into the bifurcation, which makes it quite difficult later on if there's a disease developing there. Imaging always helps in these cases. Wherever you have a suspicion, look at it through intravascular imaging. The plaque characteristics were quite clear. We knew we had to use a cutting balloon or better tools there. And because there was no significant calcification, we could know prior that we would achieve decent expansions. And the pathology is quite clear, and it also shows the lack of any edge dissections. Expansions, as I said, angiography, it looks fine, but by imaging, we know for sure that these are the criteria which we have to achieve, and then we could stop there. And kissing balloon, as we mentioned, especially double in this, as in this case, when before and after would help us, centralize the carina and prevent any struts across the ostia of either of the vessels. Thank you very much. And before I end, I would like to show this case and hope nobody will do an osteal LAD stenting to this case. Thank you.
Thank you so much. So is there a reason not to do a double kissing balloon in any of these bifurcations? There's been a lot, and it takes time, it takes effort. It's a little bit more time consuming.
Absolutely.
But is there a reason not to do it?
Not to do it in this case, or
any bifurcation lesion? Is there a scenario like LAD large diag where you wouldn't do that to really open up the carina?
And I think most of the data really is for the left main bifurcations there. And I am not a huge proponent of LAD diagonal bifurcation or OM circ, to cause so much metal there, because I think probably the side branch is always dealt with an LAD diagonal or a circumflex OM scenario. Probably a DCB will do a better job with the primary stenting of the primary vessel. Left main is a different story, obviously there. Left main is, as long as the circumflex is also a good caliber vessel, I will always do the kissing, kissing balloon stuff and double kissing, and then see how things are. That's my strategy.
Right. Now, I raised the issue. I know this is left main, left circ, but in the U.S., we're always a lot far behind. I mean, DCBs are much more recent, right. But it's changed a lot of these bifurcation strategies. And are you changing how you approach it now in the set of DCB? Yeah.
I think as you're asking, LAD diagonal is definitely changed. OM bifurcation is definitely
but left main
changed.
circ has not.
Left main, if it's bifurcation, we still, I think, would go ahead and do a stenting. But isolated LCX ostium, that is different again. Nowadays, we started doing a good orbital preparation, and then probably end up doing a DEB there, and then image everything. If the area what we got is finally because it's good, then we might leave it without. And some people have the habit of doing crossover, and then if the struts are okay and the LCX flow is all right, then that's where we might open up little struts with a little low pressure. That's all. Not a very aggressive kissing. There is another place where we don't do aggressive kissing. But if you have any doubt or suspicion of L6 having some trouble, it's always better to follow two stents and take it to double kiss again.
Just interesting because the conversations have changed quite a bit in terms of bifurcation with DCB, right?
Absolutely. Absolutely. And the worst case, any case, the restenosis you are guaranteed is the osteal circ. Yeah. You put a stent in and it's going to come back, no matter what you do.
Antonio Columbus says after doing that, if patient has come back, it is invariably L6 osteal stenosis.
Yeah.
That's why it is. And the areas I think he has highlighted already, the Kang's original criteria is now we found it as suboptimal. They themselves modified and the areas have to be better now.
These were above the 8, 10, and 12 criteria, the XL2.
Thank you. We'll move
Your
on.
areas were amazing there. So great job. Nice case. Great presentation. So we'll move on to the next speaker, which I think is ultra low contrast IVUS guided bifurcation multivessel PCI and advanced CKD by Dr. Ramkrishnan.
I think another important thing I would say is not a real thing, but real game changer in interventional cardiology, I feel. This worry of contrast and patients worried of doing, not many patients who had creatinine high we would have left untreated. Now with the real low contrast ultra contrast IVUS imaging, That worry is not there. We have experience of doing 6.5 creatinine is also being tackled multi-vessel PCI. Ramakrishna is my colleague, and we did tackle such cases. There was supposed to be some other presentation, we dropped out, but we wanted to have this top, and that's why I requested Ramakrishna to present. We'll have some discussion after the presentation. Over to you, Ramakrishna.
Very good afternoon, everyone. I'm Dr. Ramakrishna. So thanks for the opportunity. I will show you some case examples and how to reduce the contrast in these cases. So the definition there are previously we call it as contrast-induced nephropathy. Recently the KDIGO has changed this terminology as contrast-induced acute kidney injury, and it is based on the if creatinine goes above 1.5 times or more over the baseline within 7 days, or a plasma creatinine rise of more than 0.3 milligram per deciliter within 48 hours rise after exposure, or a reduction in urine volume less than 0.5 ml per hour for 6 hours. So this is considered as contrast-induced acute kidney injury. So if the patient had eGFR of 45 to 60, there is 8 to 10% risk of developing contrast-induced nephropathy. Or if GFR is 30 to 45, 13%, and if eGFR is less than 30, there is almost 27% risk of development of the contrast-induced acute kidney injury. So if the patient had CKD and along with contrast-induced nephropathy, his mortality is almost 1 year mortality is almost 20 to 25% compared to a non-CKD, non-CAN patients. So how to reduce the contrast, how to calculate. So this is a little rough guide. With the patient, you should contrast volume by eGFR. It should be roughly 1 or equal to 1. If the eGFR is around 40, try to maintain total contrast volume less than 40. And if the eGFR is less than 15, use diluted contrast and as minimal projections as possible. For RCA, only one injection, that is cerebrovascular view. So that gives proximal and distal. And for LCA, epicranial and epicardial. These 3 views are enough to have a maximum information, but in separate cases you can use additional based on the creatinine value. And you need to have a good hydration, that is non-negotiable in all these patients. So you need to plan the case. If the patient underwent angiogram outside, keep playing those angiogram videos and don't use again and again angiograms. Use a smaller guide possible compared to a 7 French guide, 5 French guide. You can reduce the contrast volume and adequate hydration. That is the most important thing. So while engaging the guide, don't use the contrast. Rely on previous angiogram or pressure monitor or moment, because we are all know the moment of the guide catheter. So you can use heparinase saline while observing the ECG. If it is engaged, you can see some changes. So you can reduce the number of injections. So you can use the wires, 2-3 wires. You can place the wire proximal and distal to the lesion, and you can use the radiopaque portion as the length, and obviously IVS imaging the best. Or you can use OCT, but with saline, not with contrast. Don't oversize. Use NC balloons and IVS post and anaphylaxis angiograms. So before this, you know the volume of contrast in your diagnostic catheters. Like diagnostic 5 French carries 1.3, with manifold 1.6, with Y connector it is 2.6. Similarly, for a 7 French, it is almost 5 ml of contrast. For a patient with CKD, eGFR of 30, even 5 ml is significant. So these are the intake, the help of imaging and physiology also you can reduce. So going forward, we'll show you some of the case examples. Is a 51-year-old male, diabetic, hypertension, CKD, under nephro follow-up. His baseline creatinine is 1.9. After angiogram, it went up to 2.2. So waited for 1 week, and we took for him for ultra low contrast CHE. So you can see the distal RCA. So this is the angiogram which was done outside. So you can see mid LED. So you can use the help of the branches. So we wired the proximal, one wire in the proximal branch, and this is IVS imaging. You can assess the lesion characteristic. It is predominantly the fibroplaty plaque. So you need not use the cutting balloons or all those things. You can use NC balloon and pre-dilate before, and then you can take the stent. So this is the stent one. Because his creatinine is okay, we can took 1 injection while stent deployment. So we completed the procedure less than 15 ml of contrast. So this is final IVS imaging, and one last shot for LED. That's enough. Again, without wire, one more shot you should not take. So this one is enough for us. So next is RCA. Place one wire in the proximal branch and dilate, then take the stent, little longer stents and optimal dilatation. Then I was good. The contrast volume is 10 to 15 ml. So patient discharge creatinine was 1.8 and follow up doing well. This is another 69-year-old male, diabetic hypertension, underwent PTCA to LAD RCA 2012, L6 2014, and again presented with function the exertional breathlessness. Baseline creatinine is 2.2. eGFR is IVUS helps in whether the stent is well opposed or not, and edge dissections we need not check. And one final shot, that's enough for us. So again, circumflex is wide, so we stented after balloon dilatation. One final shot, that's enough. With wire, again you need not take without wires. So follow-up creatinine is 2.2. No other total contrast is 20. Total contrast is 20 ml VC-pack. So this is another third case. It's a 64-year-old male, CAD, recent ACS, good LV function. Creatinine is 5.2. He was underwent angiogram outside, triple vessel disease, advised bypass, but not willing for bypass. So he came to us. So we didn't have angiogram on these things. So we placed one wire in the branch, nearby branch. We did IVUS imaging, then redilatation, and then stent, then post dilatation, optimization, then IVUS imaging. So we completed L6, then we took one shot, that is it. So this was the final. After both the stents, we took only one injection. Next RCA was stented in the same sitting. So total contrast volume is like less than 30 ml. So discharge creatinine is also more or less same. He is doing okay, still not on hemodialysis. So minimizing the contrast exposure, adequate hydration, and using least nephrotoxic contrast during angiogram, and PCI. Hydrate well before the procedure and stage the procedure, not do ad hocs. Using imaging during the procedure helps in optimization and reduce the number of injections to take. Thank you.
Thank you very much. So we're running quite behind, but maybe we have time for one comment. Any questions or comments?
Many people think that doing CABG may be preferred in patients of CKD. It's not true, especially when they're going on to pump. There's definitely more chance of they going into hemodialysis. So don't be of that impression. I think by this way, you can save more patients going on to dialysis.
But it takes sort of careful planning, commitment. The question of doing both vessels in one setting versus bringing them back, I guess is a question that always comes up. Like, when do you stage intervention in renal dysfunction? Maybe that's one quick comment for that before we move on.
So if you're not able to complete the procedure with minimal contrast as we planned, we hardly used any contrast there, only IVUS. That's why we did all together. But if you are by any reason we suspicion point of some perforation or something where you have to use contrast, that's where I think you can call them. Because here we hardly used any contrast. We could finish everything in one sitting.
Great. Thank you so much. I really appreciate it.
The next one is calcified left main bifurcation in left dominant frail octogenarian pink puffer. All very low risk, I guess, yeah.
So we're running behind as usual. We have a live case. So we're going to try to catch up a little bit of time with each case, maybe 1 minute with each case we can catch up.
Yeah, good evening, everyone. So this is 83-year-old gentleman presenting with the. Can I change the slide? So there is no conflict of interest. So coming to the case, it is 83-year-old man, chain smoker, known case of severe COPD, emphysema, and hypertensive, non-diabetic. Had PTCA done to a lady and diagnosed 2 years ago. Rest angina since last 4 to 5 hours, severe chest pain. Renal function was normal. So echocardiography revealed hypokinetic anti-wall, lateral wall, and septum with EF of 40. So I hydrated the patient and I diluted the contrast with the NS, keeping in mind the age of the patient. This is the EKG revealing ischemic changes in anterolateral lead. So this is the angiogram, left dominant circulation with significant stenosis in distal left main with ostial and osteoproximal LAD and L6 stenosis. Yeah, mid LED and distal LED stent is also have ISR, severe ISR, and diagonal, ostial diagonal is also having severe ISR. So this is the RCA, non-dominant RCA. So plan was to go with the miniculate, and so I did dealt with the diagonal with pre-dilatation and DCB2 diagonal, and this is pre-dilatation to LED, and I used IVL 3.3 into 12 in LED because this was severely calcified, and this is the main vessel. So while doing IVL at near the ostia of the LED, the patient just crashed. Presses fall down, and then I give intracoronary adrenaline, and then short CPR, and inotrops was started. So now the scenario has changed. I now plan to go with ostial LED and to go with stage LM to L6 PCI. So DS deployed in mid distal LED and in the ostial LED, and post dilatation done. But after post dilatation, the result was no good, and dominant LCX flow was TME2. So and the pressures were also not very good. Hemodynamics were not very good. So I have to go with the bifurcation now. And I kept a balloon in LCX, and I did undersized balloon kissing in LED in LCX, and patient tolerated. I think ischemic preconditioning helped me. At this time, the patient tolerated bifurcation intervention. So now I planned a bell out nanocrest from left main to LCX. So this pre-dilatation done in LCX with Wolverine balloon 3.5 into 10 at high pressures, and then a DS of 3.5 into 23 deployed in left main to LCX. And first port was done with 5.5 balloon, NC balloon. Kissing was done, pre-dilatation and kissing was done with 3.5 balloon in each LED and LCX. And final port was done 5.5 into 8 NC balloon at high pressure. This is the final angiogram, acceptable results. So I decided to stop here. I planned the patient because this is bifurcation. I planned the patient with IVAS, but my IVAS was not working at that time. PIMP was not working, and the patient was having chest pain. So I have to take the patient without IVAS, though this is the case where IVAS should be done from beginning. So this is the final picture in LED. So this was the left main bifurcation. So I planned IVAS after 7 days when my IVAS was okay. Then I planned IVAS. So we can see distal LED studs are still unopposed. The rest, everything is well opposed, and ostia of the LED is well covered. The main fear was whether we have covered the ostia of the LED or not. The ostia of the LED is covered, and this is the IVAS from LCX to left main. The distal LCX have a significant calcified stenosis and little under opposed stent in distal part. The rest stent is well opposed. This is left main stent is well opposed. So this was the issue. Distal LED stent studs were unopposed, and distal LCX significant stenosis, though left main have a good MSA with well opposed stent. So with IVAS information, I went ahead with post dilatation of both LED and LCX with 4O balloon. Previously it was 3.5. So this was the benefit of IVAS, and main issue was distal LED unopposed stent, because distal to this stent stud the LED size was around 2.5 and this is around 3.5 3.75. So this was the issue. Distal LCX lesion was prepared with cutting balloon and then stented, and post dilatation done. This time I used GL balloon, GL catheter. So there was issue of sport. So I used balloon anchoring, and post was done with 4 balloon and distal LED stents were not still opposed. So I used a high pressure 3.5 balloon post dilatation, and then final kissing with 4 balloon in each LED in LCX, and then final port with 5.5 balloon at high pressure. And this was the final result. This LED is looking good, and this is the LED in L6 final result. This is the final I was run. Yeah, now the stent studs are well opposed, and rest everything was okay. Well opposed stents. Well opposed stent. Now coming to left main. Well opposed stents, and this is from LCX to left main. Well opposed stents. No significant tissue protrusion, and left main is all right. So these are the final MSAs. Left main MSA was 21, and POC MSA was 16. Proximal LED was 9.5. Distal LED was 9. Proximal L6 was 8.8, and distal L6 was 7.4. So these are good MSAs we could achieve. So the key takeaway is left main bifurcation stenting in high surgical risk elderly patient is a viable and often preferred alternative to CABG. Left main bifurcation lesion requires a tailored approach based on lesion complexity, coronary dominance, and intraprocedural hemodynamics. Provisional approach is preferred, but it can sometimes necessitate a crossover to more complex strategy. Imaging is crucial for optimizing procedural outcome and improving long-term prognosis compared to angiography-guided intervention alone. Be flexible with the plan. You cannot plan everything prior. You have to change the plan according to patient hemodynamics and requirement of the. And all is well that ends well. Thank you.
Thank you.
Oh, very nice.
So I think we have to probably go, but one quick comment: role of hemodynamic support and when you place it in a patient. Obviously, this patient ended up with CPR and everything else. Balloon pump, Impella. I mean, depending on what's available, hemodynamic support and left main intervention.
My thought always is, as I mentioned before, doing a right heart cath in these patients, make sure the EDP is good. If the EDP is not good, then you have to put in a balloon pump if he had a reasonable access, or he had access to Impella, that's fine. And I assume probably Impella access may not be available, at least the balloon pump access will be. I think right heart catheterization is very crucial in these cases there. It gives us much more information in terms of their PA pressures and the EDP. If the EDP is good, you're good. You know what I mean? You can do that without any mechanical support. But if the EDP is higher there, and I think you'll be better off having a balloon pump or some other sort of MCS available.
Wonderful. So thank you so much. So we're going to go on to the next speaker. An unyielding in-stent restenosis, use of intravascular lithotripsy, non-compliant balloon, and DCB. Dr. Sahu?
As it comes up, I think another thing we need to understand is those complex procedures are equivalent to surgical revasculation. We need to take time, prepare the patient unless it's emergency. Proper decongestive therapy, stabilizing the patient also goes a long way in avoiding this high-risk support devices. If a patient is emergency, no choice. Okay, over
Thank
to
you so much. Can we get the slides, please?
Okay. Good afternoon, all. And thanks, ACVS, for giving me this opportunity. As you know, the calcium is Achilles tendon, okay, especially in ISR. So there is no definite strategy. During last session we are discussing, there is a lot of way to do this ISR. Okay. So my patient, 69-year-old, diabetes hypertensive, present with sudden onset of chest pain, breathlessness for 36 hours. Basically, patient PTCA to LCX and RCA done 2 years back. EC shows QFs and lead to 3 AVF and 2D echo is RCA territory hypokinetic, LV is around 45%. So serum creatinine is little too high and troponin is positive. So, but the problem is often in India we are coming with patients without having any reports. So this patient having no reports of PTCA, where it is done. Okay, so diagnosis of diabetes, hypertension, post PTCA to Alzheimer's, RCA, and with NST with mild LV dysfunction, patient taken for angiography. Okay, the angiography left main is normal, LAD proximal mild disease, L6 instant is patent, and RCA, the left system, the L6 stent is normal, LAD having mild disease, and the RCA is filling retrograde from left system. And the problem with this RCA is anomalous, and it is hooked with AL catheter. This is the thing. So our plan is, since creatinine is high, so you plan to use IVUS rather than OCT. Either you will come out with trachytic balloon or high pressure balloon, because you don't want to put extra layer of stent inside. So because it is anomalous high region, we hook with AL1 guiding catheter, and normally wire pass. And because of this guiding wire is not giving supports, we are not able to pass the balloon. We have taken body wire technique and pre-dilated with 2 to 10 mm balloon. Again, you will see distal there is a lesion is there also. So distal lesion is dilated. Then this is the angio after dilatation. I did IVUS from distal RCA to proximal RCA. This RCA distal to stent, you see some atheroscleral plaque and calcium is there around 11, 12 plus position. This distal stent looks well opposed, and if you are moving proximally, there is also intimal calcium is there, new atherosclerosis calcium is there. And if you see, if you are moving to proximally, it means stent, it is grossly underexpanded stent. Okay. If you move proximally, this stent, see, if you this stent, the titrate percent of stent, this is the lumen and this is a stent. And behind it looks, there is some calcium is sitting. So this helps, the imaging technique helps. You have to know whether it is neoanatomal atherosclerosis or new atherosclerosis or a stent under expansion. Exactly you know whether the calcium is, what is behind the stents, you can know. So in these cases, if you do scoring cutting balloon, mostly it is for luminal calciums. So behind the calcium, we can do, if you do IVL also, IVL will give some pulses, it break the calcium behind the stent so that you can use high pressure balloon or NC balloon. So you took shock of C2 coronally and 18 pulses, 8 cycle of 10 pulses given, you see. Then you did IVUS from distal RCA to proximal RCA. If the IVUS behind the stent, you can see some cracks of calcium behind the stents, but stent is still underexpanded. This is the tightest person. You see, distal stent is okay only, but if you are moving to mid to proximal stent, it is grossly expanded. After IVL, what will happen? Behind the calcium sitting behind the stent, also it can break, so that it will be easier for further procedures. This is the IVUS. Okay. So after that IVUS, this is the angio. Still a lot of under expansion is there, and when you dilated it to NC balloon, it was having a dog boning effect. Then options were, because it is calcium sitting behind the stent, so option were you can use laser or you can go for OPN NC balloons, high pressure balloon. In the balloon, you can go up to 40 millimeter, 35-40. Exactly we did. You dilated to OPN NC balloon, and Then put distal disease there. You put a DS 2.75 to 21. See, after OPNC, it looks okay. Then you did an IVAS after OPNC also to see that whether the dissection is there or not. Okay. This is the distal overlapping. If you will see in 3 o'clock position, PLV branch is coming. It is the distal most stent. And it looks well opposed. There is no dissection. Okay. And the MS around this, this is also the overlapping segment. MS is 6.7. Again, because there was doubt, again you have did with 3.5 and 20 protege balloon. The advantage of protege balloon is you can use it 3 times, so that it is having some technology, seal technology. Even with last dilatation also, it will deliver the drugs. And this is the final result. It is satisfactory result, although with some under expansion there, but MSA is around 6.7. So now, contrary to belief, the eyes are present with mostly ACS, because NSTEMI, unstable angina, and the most common cause of this ISR is underexpanded stent. And also, as I told you, treatment is always challenging, optional. There are multiple options. And now, contrary to this Meran classification, it's done for VMS. Now, Waxman classifies for ISR. You can see there are 4-5 types of classification. Depending on the imaging, you can know what to do. Whether it is a mechanical, it is underexpanded stent, or it is stent fracture, or eventually hyperplasia, atherosclerosis, calcium. You can identify accordingly, you will plan. There are options are there, and this is the, although there is no definite guidelines. If it is mechanical, stent under expansion, calcified vessels, so it is a cutting scoring value has no effect because it is behind the stents. So you can use a high pressure balloon or IVL or laser. If it is only intimal lesion, you can do a cutting balloon, scoring balloon. If it is stent fracture, you have to put a stent, or you can come out with draw coating balloon.
Thank you. Any quick comments?
This is a good case. You know, I can almost assure you that when the stent was put in the first stent, you know, there is an underlying eruptive calcific nodule that was not prepared well. I mean, there is absolutely no question in my mind about that. That's what has happened there, and that's what resulted the under expansion of the stents there. And you know, IVL and all these are very good. And I'm a big proponent for laser contrast, and I use it regularly when the stent is not expanding well. And I don't know whether I know you didn't mention that when he is using the OPN, there is double wire. You know, that's something that always you should keep in mind when you're using the OPN. Make sure the second wire is in place, so that because OPN you always undersize about 0.5 millimeter, 0.5 millimeters. I'm sorry, than the size you want to, because when you're deflating the balloon and take it out, the wire also sometimes comes out with it. So it's better to have a second wire as a safety net, so you don't lose the wire position. And I know you do have the second wire, and I saw that. I know you didn't mention it, but very nice.
Wonderful. Thank you so much. I think in the interest of time, we do have to move forward, but it's a great case presentation. Thank you. So our last speaker for this session is Dr. Manakandan on a challenging case of complex coronary intervention.
Good morning to all. My case is very simple only, like previous case, but how we manage it differently. This patient is 53 years old male. He had underwent PDCA to RC and L6 just 3 months before. He again presented with a complaint of unstable angina. His EC showing some ST depression in inferior leads, TRAP is up, echo is mild LV dysfunction around RCA territory. So with that, within 3 months, actually he underwent a different center, 2 stents in RCA. In RCA, we can see there is 2 stents, 3 into 28, and there is again another also 3 into 26. L6 also they put stent, it is 3 into 18. So within 3 months, all the 3 stents got plugged. So we don't know what we do because whether the patient having this recurrent ACS or anything, something abnormal. So we have to do imaging. So before imaging, it is very difficult because the wire initially this balloon is not crossed. So we put 2 balloon NC balloon, then we put 2.5 NC balloon. So we diffusely dilated from distal to proximal. After that, we just did OCT. In OCT, we can clearly see inside the stent there is diffuse neointimal hyperplasia, like this diffuse neointimal hyperplasia within 3 months after post PTCA. The stent is well expanded. There is no malabsorption also. There is no neoatherosclerosis, but it is diffuse neointimal hyperplasia only, not atherosclerosis. So we can clearly see this diffuse neointimal hyperplasia. So there is no significant malabsorption, only vessel is we can see clearly in OCT image. So then we did a scoring balloon with 3x15 scoring balloon. We did from distal to proximal. The scoring, how it cuttings we know. Then we put 2 drug-eluting balloon. From distal we put 3x36. From proximal we put 3.5x40. So post dub we didn't do OCT. It looks like good. So then we proceed to left side. Left side also we did similar. We did pre-dilatation. Then we did dub 3.5x18 dub. Then after that we got good result. So after the baseline workup, after 2 weeks we did is having pain high ESR, HSCRP is around 5, ANA negative. We got rheumatologist opinion. We did all the inflammatory markers. His LP is around 45 only. LDL also very less only. So he is having baseline inflammatory milieu. So diffuse heterogeneous ISR in both vessels within 3 months is a rare catastrophic phenomenon. After the detailed imaging, we found the mechanism is only neointimal hyperplasia. So we are working towards a diagnosis to rule significant vasculitis or drug resistance and hypersensitive causing malignant ISR. So it's a very rare phenomena. Even it can occur in non-diabetic male patient even after adequate LDL optimization. We did a drug-eluting balloon. It is class 1 indication in ISR. This imaging helped us to find the mechanism of ISR to optimize the result. So in the background of elevated inflammatory markers and vasculitis, workup of drug resistance and hypersensitivity markers are required to prevent recurrent events. We started the tablet colchicine 0.5 mg OD. We are hoping for the best. Till more than 3 months, patient is doing well. Thank you.
So two quick questions. One, do you change the pharmacology in this type of patient with a potential vasculitis? And two, what is the follow-up? Do you do a relook angio? How do you follow these patients given sort of the malignant nature?
Over, sir. Okay. Sir, patient already on prasugrel and ecosprin, sir.
So he's a prasugrel and ecosprin.
Oh, okay.
It's a good combination. It works good. My thought in this case is a little bit different, actually. I think it is a polymer allergy. That's what I think it is causing it. And actually, it is not the mechanism. I think the instant restenosis in this situation, in my opinion, even though very, very rare, there are a lot of case reports of that, is the metal allergy or the polymer allergy has to be considered. It is not the NIH. It doesn't happen that way. Even if it's under expanded stents, it's a little bit unusual. You know what I mean? And I think it's polymer allergy. And that's the reason why I think the HSCRP and the ESR is a little bit high. And I don't think you will find any reason, actually, even if you do extensive work up there.
Yes,
and if the restenosis comes back again, I think they have to go to surgery.
The colchicine, we start colchicine 0.5 mg, sir. It is okay. Colchicine 0.5 mg.
Yeah. I'm talking about polymer allergy, from the stent itself actually is causing the problem, I think there. It's a very, very rare condition, but that can happen there. Colchicine is good. That's a great idea. It's a great drug, yeah.
Thank you. Thank you.
Thank you very much. So thank you to all the speakers in this session. It was very educational for me. We're going to move on to the next session. We're going to go straight away. We're going to ask the panelists to join us and thank you. And you want to introduce the panelists or whoever?
Going down, we will be here at midnight.
I think
So if we can have all the panelists join us, we're going to get started with our first speaker, who's Dr. Michael Benz, who's going to present us a case of disaster in the cath lab during TAVI and lessons learned.
request Dr. Pramod, Dr. Rakesh Varma to join on the podium. And it's a great honor to have sitting beside Dr. Everett Grube. And we have Dr. Nirmal Kumar, Dr. Anup Agarwal, Dr. Rajshekhar, and along with our Russian colleagues, please join Dr. Balamurian. Whoever is there, please join onto the podium, please. Over to you, Michael.
Okay.
Distinguished cardiologists from India and abroad, it's a great honor for me. I thank my mentor, Dr. Srinivas, for inviting me. My topic today is disaster in the cath lab, annular rupture during TAVR, and lessons learned. Our patient is a young Hispanic male admitted to our hospital for the first time with acute systolic heart failure. The workup has revealed he has a critical bicuspid aortic stenosis with dilated cardiomyopathy with EF of 20% and severe pulmonary hypertension. His cath was normal with a low cardiac output and cardiac index. If you look at the echo, you can see the poor leaflet mobility, moderate MR. You can say it's a severe type 1 bicuspid aortic stenosis with a fusion of right and left coronary cusp. It's a low flow, low gradient critical AS with a velocity ratio of 0.14, valve area is less than 0.5. You can see it's an eccentric opening. And also you can see he has an ascending aortic aneurysm of 4.5 centimeters. So our diagnosis at that time was systolic CHF secondary to AS, and it's a delayed presentation. So we treated him for a week. He actually improved much better, but he was still dyspneic with minimal exertion. So we offered him the definitive therapy, that's valve replacement. Now we called a heart team meeting to decide whether the patient should go for SAVR or TAVR. So the factors favoring SAVR were patient was young, he has a bicuspid aortic valve, severe calcium burden, and his ascending aorta is 4.5 centimeters. He also had a good contractile reserve on, with the dobutamine, and also all of us know it's a good choice for lifetime management. But factors favoring TAVR were severe heart failure, very low ejection fraction, still symptomatic, severe pulmonary hypertension. Ultimately, the verdict was SAVR. So, as we discussed before, his coronaries were normal. One less thing to worry about. So now, the surgery was scheduled on the Monday the following week, but we know Monday always precedes the Friday. So we cannot get a Monday without a Friday. And that Friday night has arrived, and Devil's Night festivities began. Patient actually started crashing. He hemodynamically became unstable, anuric with multi-organ dysfunction. See, we had a shock team. It's a Friday night around 9 p.m. We called the shock team. Shock team came and evaluated the patient. They said, patient developed refractory cardiogenic shock. He needs an immediate valve replacement because he was not a candidate for BAV because of the valve. So, of course, obviously the surgeon was reluctant given situation, and entire focus came on me because I was the director for the structural heart program, to do a TAVR urgently that night. So luckily, we had a TAVR CTA. My plan was to do, because it's a bicuspid, to a self-expanding valve Medtronic. Unfortunately, we did not have that size. Its perimeter was very large. We needed a 34. It was not on the shelf. And I was calling the rep. Probably he was somewhere in New York enjoying, because we are next to New York City. I could not get in touch with him. So I thought I could get away with a Edward balloon expandable valve. So we called the team. And these were our TAVR measurements. His annulus area was 627. Coronary heights were excellent. We decided we are going to go with the 29 mm valve with 4% upsizing. So you can see that there's a lot of calcification. You can see that in the hockey puck view, and also the calcium is extending into annulus and LVOT. Access was excellent, no problems. And this was our valve deployment. Positioning was good. And before actually we deployed the valve, I did with 18 mm true balloon dilation, just so that the valve can pass easily, because it was very tight. So deployment looked good. LV actually started contracting better. EF improved. We were really very happy. The Friday night, it's like around probably 12:30 in the midnight. We're very happy that we can close our shop and go home and enjoy the weekend. Unfortunately, we got a shout from the cardiac anesthesiologist, patient is crashing. We immediately activated our TE probe. You could see there's a lot of blood extravasation from the right sinus of Valsalva. And also you can see significant PVL between 12 and 3 p.m., 3 o'clock. So you can also see a lot of diload in the RV. Now, the LV, which was contracting better, now going down. And this is our angio. You can see dye going everywhere. So obviously you can identify the patient went into cardiac arrest, requiring CPR, ACLS, and multiple shocks. So we immediately started him on VA ECMO. After the VA ECMO, the heart started contracting better. His hemodynamics improved with inotropes. And also his oxygen saturation was good. We had some room to breathe. And we took another picture. It looked actually looking worse. So now, what to do next? Our VA ECMO is working. Numbers look reasonably good. And patient is intubated, saturating well. So we just wanted to look at all the images, what's going on. We reviewed all the angio. We reviewed all the TE images. Then we came to a conclusion on the table. It's a contained rupture of the right sinus of Valsalva into RV. And of course, there is significant PVL. We thought, I think we can salvage this patient. Next is, I looked at the surgeon. So basically, it was already like probably 1 a.m. or 2 a.m. in the morning. Everybody's tired. We thought maybe we can get away doing any thoracotomy on the table. So all the team is there, everything is there to do the surgery, but we decided not to do any thoracotomy. Let's watch him what happens. So we moved him to CT ICU. Next day morning, like somewhere around 11, 12, we did another echo. This looked really worse. The valve has actually migrated down, probably with aggressive CPR. And now he developed a new membranous VSD. Now, we still have this rupture of the right sinus of the Valsalva, and PVL got worse. So now we know, we discussed, because we have no, the only way to save him is taking to the OR. Our surgeon did a fantastic job. He actually repaired the right sinus of Valsalva, repaired the membranous VSD, removed the TAVR valve, and he gave a new Inspirus 21 valve, which was also Edward. So now he had a rough post-op course, multi-organ failure, lactate is through the roof, LFTs are through the roof, acute renal failure. So we started him on CVVHD, and also we went into asystole, multiple VTs, we put a AICD. We wanted to do everything. When we looked at the family, he's the only son for her, for his mom, and no other family, and the mom is old, and he was taking care of the mom. So we wanted to do all the things we can do to save this patient. And we also added an intra-aortic balloon pump to support him. Now, did he survive? Yeah, actually, he survived. We were able to extubate him on day 14. On day 23, he actually walked to a rehab. And actually, the kidney got better. LFTs improved. Lactate came down. No more dialysis. This was our day 14 post-op echo. Looked good. EF improved to 40%. The valve was working well. Of course, there is some mild gradient, probably the patient prosthetic mismatch, because the acceleration time is 99 milliseconds. This was the EF. This was a picture we got from his referring cardiologist. This after 6 months. If for a new person, we don't know who is the patient, who is the doctor, right? He looks robust. He was actually, during our admission 6 months ago, he looked like a TB patient. He was like a very, very, like anasarca, very weak. Now he looked like a normal patient. Actually, he was walking. He was able to walk 1 to 2 miles without any symptoms. He's on good guideline-directed medical therapy. So now, this case taught me a lot of lessons. Because sometimes what happens is, when we are doing the cases, everything going well, suddenly, God gives you that break. Suddenly you get a complication, then you reset yourself and you become a better operator. So the take-home points from me is, self-expanding valves may be better in severely calcified bicuspid aortic valves.
Michael, I'm going to ask you to wrap up in just a few seconds, just because we're running behind. So we can have a couple discussion points.
Quick. And there are no studies to compare. On the other side, because of the self-expanding valve, we have to be careful because of the aneurysm. We don't know how the crown is going to react. It could develop dissections or a rupture in the future. Cracking the chest open should not always be the first option. And multimodality imaging is very, very important for complex cases. Preferably, we should do with general anesthesia and elective intubation. And LAVA ECMO, like the way we do complex cases with Impella, probably complex cases we should consider doing with a LAVA ECMO. And even patient is a high risk, patient can go for surgery with a LAVA ECMO. And teamwork, careful decision-making, and meticulous CT-ICU care is very, very important. If I have to do this case again, first I will send him to SAVR with LAVA ECMO support. But if I have to do myself, LAVA ECMO, self-expanding valve, very gentle balloon dilations. And finally, human life is resilient. Thank you.
Thank you very much. I think just we're a bit behind, but I think your comment about bicuspid anatomy and it being challenging, and especially in a younger patient, surgery potentially being the first choice is an important one. And sometimes it requires pushing the surgeons, but obviously when the patient came in shock, that's challenging. Any quick comments before we move on?
Human life is not so resilient. He was just very lucky, let's be honest, because this is a disastrous complication. And there's not much you can do except for saving a patient's life. If you have annular rupture with fistula, there's not much to be done sophistically to discuss which way to go. You have to rush and do the best you can to save a patient's life.
Yep, agreed. Thank you so much. I think we're going to move on to the next speaker. Thank you so much, Michael. Dr. Farokh, anatomic high-risk bicuspid aortic valve TAVR with I think a ventricular septal defect related complication.
Great save, Dr. Benz. But some percutaneous options of closing with a coil and some devices are described for that.
I think in this anatomy with that much calcium and where it is, I don't know that it's salvageable because he has a VSD and a root rupture. So I think that I would argue that it's probably a younger patient try surgical bailout.
Respected judges, faculties, and their delegates, I thank the ACVS, the organizer, for giving an excellent opportunity. It was a wonderful presentation from Michael Benz. But in Western country, they work in a Benz environment. In India, we work in an ambassador environment. So sometimes it became very difficult to manage. So this is a patient who had a symptomatic aortic stenosis for almost 6 years, never agreed for any intervention or surgery. A non-diabetic normostency, very difficult to make her to accept any type of procedure. A bicuspid aortic valve with moderate LV dysfunction, gradient of around 90 peak and 70 mean gradient. And she was very fragile Indian lady with arthritis and COAD, and with the heart team approach, with heavy heart, we could able to convince her for TAVR. That is the CT proclaul seems to be bicuspid aortic valve, severe aortic valve calcification. LVOT seems to be having a similar annulus, a narrow right sinus of valsalva diameter. Coronary height were very low actually. Annular calcification extending into LVOT from NCC with mild calcification observed in the ascending aorta with perimetry derived area of 24 and area derived was around 23.4. With this parameter, we preferred 23 valve. We had the economy which is available for balloon expandable my valve actually. So this is the annulus dimension, and there is an LVOT dimension, and this is the 4 mm above the annulus and 6 mm above the annulus. That is the sinus of valsalva area, and you can note this heavy calcification. This is the coronary height, left dominant system with 7.3 mm left coronary height, relatively a low coronary height with right is non-dominant with 15.7, high risk status actually. And this is the cuspal length, left cusp length, and that is the VTC left and right, 24. This is deployment angle, and that is the valve calcification, hockey puck showing an extensive calcium there actually. So this is the angle, clack angle. The femorals were relatively low risk. There was a mild tortuosity with size at the puncture site was around 6.2 or 6.9 mm. Not much calcification. There is mild tortuosity. We prefer to work on the right femoral and left femoral for the diagnostic and other pictiles. And so we had a ultrasound guided puncture, and that was the wire. And we had 2 proglide actually. Prior to the intervention, we had a 2 proglide deployed. And there is the angiogram. Relatively normal actually. So we had a AL1 with straight wire cross. We could able to cross the aortic valve, and we wanted to park JR first there actually, but we could not able to reach the apex. We could able to take a JR placed at the base, and we could able to take a thermo wire and could able to cross the pigtail and park it actually and wire it savvy. Safari wiring was done actually. Had a good position, and we had a balloon dilated. We wanted to have a balloon occlusion test with 23 mm balloon there actually, 23 plus 3 actually. We dilated actually. We could able to see these coronaries are flowing well and relatively safe. So with this pre-dilatation, we are very safe at present. And we had initially, for tracking the 23 mm valve, we had a resistance, and with some jerk we could able to cross this femoral. Mid-marketed pigtail, deployed with 23 plus 3. And that is the, after that we had a a mild paravalvular leak actually. So we have post-dilated that valve actually with the same balloon. There is the post-dilatation. After that, his gradient reasonably came down to below 20 actually. So we came off well. And final angio showed a good result. And final echo also was good. Had a mild diatopathy, but could able to safely deploy it. Then after that, what happened? One proglide was failed. It came out. We put in another proglide. And after that, we took a femoral angiogram. It showed the total occlusion of that femoral artery. So we activated the vascular surgeon. We were unable to cross with thermo wire. We took a coronary wire and crossed it with the coronary wire. We took a balloon. And with a serial balloon dilatation, we could not able to achieve. We took a peripheral balloon and dilated it actually. After that, actually, what happened? There is a severe hemodynamic drop, and there is probably the femoral artery rupture there, and patient crashed. You can look at it actually. And quickly we started the vasopressor and blood transfusion. The anesthetic team was very much on ready, and we could able to take on 6 into 18 mm cover stent and deployed it and post-dilated and came out with this result actually. Recently he came for a follow-up with significant reduction in the gradient, and also this vascular complication also is not there. That is the final femoral angiogram. And there was no indentation. Bladder sign also is absent. This is the TAVI bicuspid atrial data. We have a randomized trial for TAVR versus SAVR actually. And the problems here are the concomitant iotopathy, sizing technique, and procedural talent, and optimal implantation technique, the depth always being debated and remains controversial. We have, these are the complications we face with transcatheter atrial implantation. You can have a stroke, and that can be prevented by the embolic protection devices and having a good anticoagulation. And the conduction disturbances, the BE is preferred to prevent it actually, high valve deployment. And we need to wait for conduction recovery before permanent pacemaker implantation. Paravalvular regurgitation, again we can post-dilate, and sometimes may require a valve in valve or may surgery. The annular rupture, shown it actually, we may need a surgical intervention after stabilization and hemodynamic support. The coronary obstruction, of course, a lot of procedures are there for coronary obstruction like basilica. And you have to intervene emergently to tackle the coronary. He had a low coronary risk, low coronary height with high risk status actually, but came out. The vascular complication, what we have, we have a bleeding complication, but the occlusive complications are not very much reported. The prograde related actually. In this case, we had a occlusion of the femoral artery, which we could able to manage with the peripheral intervention actually. This is the balloon expandable versus self-expandable valve recent data. And the TAVR and bicuspid valve is standardized and feasible even in middle ages with high risk status. In our case, actually, we took her refusal to undergo surgery and also the comorbid status been a main reason to take up for this TAVI. And low coronary gate can be managed with proper pre-TAVR CT evaluation and planning, and pre-dilatation with balloon inflation test to find out coronary occlusion. And vascular closure devices make TAVR less invasive and reduces the hospital stay. The uncommon prograde-related complications to be anticipated, and in our case, we were not able to anticipate, and we successfully and came out, bailed out very successfully. High-risk TAVR with low coronary height and dominant left system has been done successfully, and prograde-related associated complication was managed with peripheral intervention with covered stent. So, thank you very much for a wonderful opportunity.
So maybe I want to try to maybe make a few comments, and maybe Eberhard or others can weigh in. The one thing I would say is, this can happen with the small vessels. In a younger patient, I would not forget about surgery. This is typically a very easy surgical repair. This is sort of a little bit of an undersized stent, a balloon expandable stent in the femoral. Even though it's okay now, they can lead to complications down the road. And so in an older patient, and we usually use, those look like big vessels, I would put, a self-expanding if I need, ideally like a Fluency we use in the US. But if you do balloon expandable, make them bigger. But in a young patient, I would just say sometimes surgery, like a cut down, can be done quickly. Any other comments regarding the case?
I think one point is about the low coronary height, which you are mentioning. If the sinuses are roomy and big enough, I think that should not be a problem with low coronaries. And anyway, you have also tested with the balloon and shown that left is flowing.
Thank you so much.
Thank you.
We're going to move on to the next case. Dr. Natua is going to talk about when every step matters, a challenging TAVR journey.
Respected chairpersons and dear audience, at the outset, I would like to thank ACVS for giving me the opportunity. I am Dr. Rajesh Natwa from Star Hospitals, Hyderabad. Today, I want to present an interesting case of TAVR. My patient is 78-year female, diabetic hypertension, presented with the dyspnea on exertion function class 2 since 1 year, progressed to function class 3 since 3 months, and she presented with the pre-synchronal episodes since 1 month. So ECG showing RBBB and 2D echo evaluated showing severe calcific aortic stenosis with critical stenosis of 0.6 centimeter square area, as well as the gradient was elevated. It's like 65 mean gradient. And CT-CAG was done. It's showing mild CAD. So then we have discussed with the heart team whether to go for TAVR or SAVR. So because she's 78 years, otherwise she's a low risk patient. So patient opted for TAVR. So we did CT analysis. It's showing bicuspid aortic valve, type 1, Sievert's type 1 bicuspid RL fused, where here you can see there's a calcified raphe in the diagram, as well as it is a flare type or reverse conical type, where you can see in the bottom annulus and LVOT are 22.5 mm. Whereas at 4 mm intercommissural distance, especially in bicuspid aortic valves, it is important to measure the intercommissural distance at different levels. So here at 4 mm it is 26.7, at 8 mm it is 26.9. And then signs of Valsalva are roomy, so more than 30 almost. And then the signs of STJ height is good. Another problem here is horizontal aorta, extremely horizontal, it is 70 degrees. And another problem is short membranous septum 3 mm. So the VTC, we have calculated VTC by keeping the virtual wall. It is 5 mm on the right side and 5.7 mm on the left side. So the STJ diameters as well as the ascending diameters are good. There is not much of calcium, mild calcification except the raphe calcification. So the coronary heights are good, 12.5, 12.8. The leaflets are almost similar, but because the sinuses are roomy, nothing to worry about the coronaries. And the femorals are good. Right side, the bifurcation is lower at the lower end of femur, as well as the left side is slightly higher. So we have taken right femoral as a primary axis. So then the question, this is the summary of the Trident analysis. So in the challenges in this case is bicuspid aortic valve with calcified raphe and short membranous septum with the baseline RBBB because they are more prone for conduction disturbances and pacemaker. Because this is a bicuspid aortic valve with calcified raphe, there is a risk of PVL and extremely horizontal aorta of 70 degrees. So the question is which valve to choose. So we have considered all the factors. So then we opted for 23 mm my valve in this patient, comparing to with the area 23 mm. So it is coming to 6% oversize. We added another 1 cc. So we have taken right femoral axis as the primary axis, and this is the aortogram, and we have kept the TPI, and this is the Python Neo sheath. So compared to previous sheath, it is more tapered, and the bleeding is comparatively less compared to the previous sheath. And this is the wire crossing. You can see the extreme and the opening of the aortic valve, and there is a lot of stress on the AL1 catheter. So you can see the buckling when you're sending the wire. It's not crossing easily. Unfortunately, at that time, Merrill people got some Teflon wire, but it is very thin. And so this with the thermo only, we have to manage that. Again, the wire came out. And another problem, what happened is whatever the manipulations we are doing, it is going into the lateral wall. It is not reaching the apex. So then we thought we'll keep the pigtail and we'll try to negotiate, but we couldn't reach the apex. So then we thought we'll keep the extra small safari wire and try to negotiate. Even then, it is not reached the apex. So then we simultaneously were watching the echo. In the echo, it is not interacting with the cardiac. So then we did the pre-dilatation. You see the extreme horizontality, whatever you see in 3-dimension, it is 70, but it's almost 90 degrees here. We did the pre-dilatation with 18 mm mammoth balloon. And so here the question is horizontal aorta. All horizontal aortas are same or different? So if you see on the left side, the horizontal aorta has long runway. On the right side, it is only short runway like hockey stick. So the long runway is okay, but short run hockey stick will cause you problem. So here also this is one of the case like hockey stick horizontal aorta. So here you see almost the valve is lying horizontally 90 degrees. So with the marker, we know here because short membranous septum, we have to like generally we'll target for 80-20 or 90-10. But here because it's very short, we're aimed for 100%, 100% wall placement. So this is the wall deployment. And after that, there is a mild parallelly. We did post-dilatation with adding another 1 cc. And this is the final injection. You can see very trivial AR. So this is the final femoral injection. So it's good. So you can see horizontally oriented, almost perpendicular oriented wall. So the patient is excellent wall position, no parallel leak. And ECG, there are no conduction abnormalities, stable hemodynamics. But there is unexpected peri-procedural event. So it's not related to the TAVR. So while posting the case, patient developed the symptoms of heart failure. She is unable to lie down flat. That's why we have to do under intubation. So, but immediately after the procedure, we couldn't retrieve the ET tube. It caused severe laryngospasm and laryngeal edema. So it done in the late in the night. So we thought we'll keep it the tube, and next day were taken into video laryngoscope, and we are given steroids in the night and the morning, and we are given choline for releasing that spasm. You can see with very much difficulty the tube came, and you can see the laryngeal edema. So this is the catheter tube. Then the below one we have used. This has additional aspiration mechanism. That is the first time we have used. Hopefully we will not use further. So the take home message is CT analysis is crucial. Bicuspid valves, always you should be careful in choosing the valve. And choosing the valve depends on the individual patient. So there is no hard and fast rule that you have to choose self-expanding or balloon expand. Thank you.
Thank you very much. So we have some time for some questions. I mean, when I looked at this bicuspid valve anatomy, the question always comes up: what valve choice? Maybe some comments. Balloon expandable, self-expanding. Were you worried about this bicuspid anatomy at all? What were the thoughts when you look at the CT? Eberhard?
Well, I mean, you can use whatever you're familiar with. I don't think there's any advantages for one or the other. It really depends on your philosophy, because you want to have it more circular. Balloon expandable valves and bicuspid. Bicuspid is not bicuspid, as we all know. Zero is not type 1. And if you have a zero, then you have to be more careful because you have the lemon shape. In general, I think you shouldn't be too aggressive. I think you should try the maximum as far as circularity is concerned. Obviously, coronary access plays a role. I personally have to say I don't have any preference. I think we can say you can do it with either one valve. There are some limiting factors. coronary access, a lot of calcium. Where's the calcium? Does it extend into the LVOT? So there are a lot of issues around simply bicuspid, but depending on the aggravating factors, I would choose a balloon versus self-expanding valves. Most importantly, don't crack the annulus, as we've seen before.
Yeah, and I think that's important. There's a lot of variability. This anatomy seemed pretty reasonable. I think the wire position issues you mentioned are not trivial. I've seen cases where you create LV injury, you create chordal rupture, and when you have a horizontal aorta and then the LV comes at a different angle, it's worth taking the time trying to get the wire as much as you can to the LV apex. So you don't have some of those injuries. And especially in a horizontal aorta, aggressive sort of, semi-aggressive balloon dilatation, I think is important, because one of the challenges, and especially with some, like my valve, there's not a pusher. You saw the valve was completely on the outer curve, and you store tensions when you do that. And so as you start to go up, you can release those tensions. The valve can move in, out. And so when a scenario like this, you want to be very slow and cautious with your inflation. As you slowly inflate, you may need to adjust the valve position, because those angles and everything put a lot of tension on the system. So that was a great example, nice case. So congratulations. Thank you. So we'll move on to our next speaker, talking about delayed coronary obstruction post-TAVR, Dr. Sujit Mando. Yeah, thank you.
Good afternoon, everyone. First of all, I would like to thank the organizer for giving me this opportunity to present this case. It's a delayed coronary obstruction after TAVR. The delayed coronary obstruction is a rare but a life-threatening complication of a TAVR. Okay. This is a 70-year-old female having complaints of recurrent dyspnea and dizziness for the past 4 months, with a past medical history of hypertension and a lacunar infarction. On examination, her vitals were normal. There was a decrescendo systolic ejection murmur. On transthoracic echocardiography, the diagnosis of the severe aortic regurgitation with a moderate severe aortic stenosis with a moderate regurgitation, with a good ejection fraction. The LV was mildly enlarged with a 51 millimeter. The diagnosis of the severe aortic stenosis with a moderate regurgitation has been established with the effective valve area of around 0.9 centimeter square. Her baseline ECG was the patient is in sinus rhythm with a strain pattern. Walking through the CT annular study, the area derived at the annulus level, it was 20.9 with an annulus area of 344 square millimeter. The LVOT area was 307 millimeter square, which is less than the annulus area. Keeping a smaller LVOT area, LVOT than the annulus area is a key consideration, which pushes us to a higher implant to avoid the under expansion in the LVOT tract. Other aortic CT parameters were sinotubular junction diameter was 26.8, ascending aorta is 34.2. The mean sinus of Valsalva diameter is 28.3, which is less roomy. There was a severe aortic wall calcification, we can see. This is an important slide. As you can see, in the towards the right coronary artery, the leaflet length was 11.4 millimeter, and the ostia of the right coronary artery was 13.7 millimeter. So the RC was not at risk. But towards the LCA, left coronary artery, the ostia of the left coronary artery is 8.5 millimeter. The leaflet length was 15.6. As you can see, the leaflet length is more than the left coronary height ostia. Also, the wall to STJ junction is less than 3 mm. Also, there is a thickening of the right coronary cusp and non-coronary cusp commissure. There is a partial functional bicuspid aortic valve. Summarizing the aortic CT, it was the LVOT area was less than the annular area. There was a low coronary height. Wall to STJ distance was less than 3 millimeter. There was severe aortic calcification and a functional bicuspid aortic valve. The severe heavy calcification of the is also putting the coronary at coronary obstruction risk. Together, there is a high chances that the leaflet might come into the way of the ostia of the left coronary artery and cause obstruction. The angle to in the coplanar view, the angle which the valve will deploy is 66 degree. The peripheral angiogram was, appears to be adequate. Based on the parameters, it has been selected. We will proceed with the balloon expandable valve with the Merrill valve, which has been developed by the Merrill. My valve, which has been developed by the Merrill. The strategy in this case, since it's a tricuspid valve with a partial fusion with a mild calcified leaflet, the area was 344 millimeters square. We will upsize by a 10 to 15 degree, 10 to 15%. We'll take the valve as a 23 mm with a we'll dilate with the nominal volume minus 1 ml. The length of the leaflet is more than the height of the LCA ostium and the small left coronary cusp, so coronary protection is required. The left LVOT area is less than the annulus area, so there will be high position, and will the axis is right femoral artery. As you can see, we have taken a coronary protection with the help of EBU catheter with the help of guidezilla wire. We have pre-positioned the NC balloon for any delayed obstruction. And in the second image, you can see our valve has been advanced. After achieving an optimal position, we have finally deployed the valve at a pre-desired volume. After deployment of the valve, we have taken a check shoot, and it is showing the left coronary artery showing its TME grade through. There is no sign of any obstruction. So we have decided to remove the coronary protection, and post that we have taken a good angiographic shot, which is showing a good TME3 flow and no sign of obstruction. The patient is not complaining anything, and we have shifted this patient to our ICU for further observation. Post-op ECG is this. There's no significant STT changes. The gradient came down to 20. Patient has been discharged after 48 hours, and he went home. She went home. We got a call on the next day, saying the patient is having severe chest pain. She was brought to an emergency, and to our surprise, this is the first ECG we got in the emergency department on day 3. It is showing the LBB pattern with the dynamic STT changes. The troponin was significantly raised, so we have activated our cath lab to directly proceed with the angiography. So with the help of JL catheter, we have hooked the left coronary system, and we can see it's a good TME3 flow with does not show any obstruction, but still we have wired the left system through the open cells of to the left coronary artery. We did an IVS run. Unfortunately, I cannot show the IVS run. It's not playing. But on the IVS pullback, we have seen there's no new significant, no new lesion in the cleft coronary artery, but the leaflet is coming in the way of the ostium of the left coronary artery. We did an FFR in this patient of the LM, and it is significantly showing functional it is showing functional significance of obstruction, which before the stenting. So we proceeded with the LM stenting. We've opened pre-dilated the LM with a Maverick 2.5 into 20 millimeter balloon, followed by we have the check shoot for any lesion. We further dilated with quantum balloon 4 into 15 mm, followed by we stented the left main with a resolute 5 into 12 millimeter balloon, stent. Final angiography result, it is showing good TME3 flow, well expanded stent. Post, we have done an IVS run, which is showing a good expansion of the stent, and we did an FFR, which came down to 0.9, which shows that we have rescued this patient. Final angiography is showing everything looks good. The patient has been discharged after 48 hours with no signs of any LBBB in the ECG, with no regional wall motion abnormality and a good left ventricular ejection fraction. So the discussion is the delayed coronary obstruction. It is a very uncommon phenomena, though its incidence is only 0.22%. It's more in the balloon self-expandable wall than the balloon expandable wall. It is in this registry, it is showing only 0.11%. And it is having very high in-hospital mortality, around 50% of the patient. These are a few common reasons why the delayed coronary obstruction occurs. This is a proposed risk factor for acute coronary occlusion after the TAVI. There's short distance between the aortic annulus and coronary ostia, a narrow aortic root, a bulky calcification, and the leaflet to coronary height ratio greater than 1, and a high implantation depth. Most of the things which was present in our cases, in this case. The risk factor of delayed coronary obstruction in this case is unfavorable height of left coronary ostia, which is less than the leaflet length. The wall to coronary ostium is less than 4 mm. Relatively smaller left coronary cusp, and a thick raphe with calcification at the lesson learned in this case, like angiography may not always be a good sign to say everything is okay. In suspected cases of high risk patient, we could do a FFR to avoid this kind of thing. And so FFR in a patient with a high risk or suspected coronary obstruction must be done. And the close monitoring with a timely PCI after TAVI is essential because it is having a very high mortality.
So maybe we take a few minutes for discussion here. Okay. So the role of FFR in this scenario, it's interesting. I mean, it's quite surprising. And I like the fact that you did it after because you saw a difference. So is this intermittent occlusion? Any thoughts from the panelists? Is this intermittent occlusion? Is this just effaced sinuses and slow flow? Because clearly the FFR is positive. What is the mechanism here? It's not complete obstruction. It's ischemia. Right?
Probably a spasm occurring there.
No,
Yeah, I think so. Because there is no fixed obstruction, and the angiography shows a clean result of the left main.
Yeah, and so it's a little bit rare with balloon expandable, and I wonder if you had taken a 21.5, would this have been less likely in a scenario? Because it's a high-risk scenario with effaced sinuses, and I think that's something to keep in mind. Does the 344, could you have done 5% oversizing with the 21.5? I don't know that it would have changed anything, but I think it's important to evaluate. I think just having flow alone is not important. Yeah.
I think, Sushila, I agree with you. I don't know the exact role of FFR in this situation. I think if you have a delayed obstruction, then it is clear and it's obvious what you have to do. But with no obstruction, I think FFR makes sense, but the most likely, we know the risk factors for that, but I think the most likely reason really is a spasm or, because, and I don't know whether FFR really helps in this situation, even though it's a different case, it's a nice case to show, but I don't really know what the role of FFR in a delayed obstruction is and what tells you. Basically, you have to deal with it and you have to do what you have to do, regardless of the result of FFR. I'm not sure.
Yeah, I mean, I think, that's an interesting point, and we probably have to move on, but, there was clearly she was presenting with ischemia. The right is irrelevant because it's such a left-dominant system. And if you don't see anything else, to Eberhard, Dr. Grube's point, you probably have to stent either way, but that was a nice save, nice example. I'm glad the patient did well. So thank you so much. We're going to move on to the next speaker.
So, one question. Any role for leaflet modification before?
I mean, it's sort of anticipation. I mean, it was sort of borderline. It looked like it could be okay. People, I think I'm pretty aggressive about it, and but it's the cumbersome nature. We don't have a great device yet for it. And so if we had a better device and that was easy, I think in all these cases, better for flow and everything, we do leaflet modification. I agree with you. Next case is valve-in-valve TAVI in a patient of multi-organ failure. Dr. Shom, yeah, thank you.
Thank you very much to Dr. Srinivas, the organizers, and esteemed participants and faculty. It's a pleasure to present here. I come from Kolkata. I'd like to present this case, which is titled Valve and Valve TAVI in Cardiogenic Shock and Multi-Organ Failure. Not sure if I was doing the right thing, but let's see what happened. So this lady is 79 years old. She's been independent till 3 years prior to her hospital admission, living a good active life with a history of 19 millimeter BioCore bioprosthetic surgical valve done about 12, 13 years prior. And her coronaries were fine prior to the SAVA. She basically, I didn't meet her initially. I met her son and her brother, younger brother, and they said she's in an ICU about 3 hours away from Kolkata and she's not very well. And the echo there showed that she was basically having severe regurgitation with poor LV dysfunction, with poor LV systolic function. By the time she was transferred to us, she was in pretty severe acute decomp heart failure with very high BNP, respiratory failure needing NIV. We tried to stabilize her as much as we could, but kidneys started packing up, so she went on dialysis, and her liver was a mess as well. So after much deliberation and discussion, and I know the technical facets of this case are probably something that all of you must be doing on a routine basis, but I think the clinical decision making was primary here as to whether to do or not. When the surgical adage, when not to operate, and this was like clearly going through my mind that should we even be taking up this lady for TAVI? And but the thing that influenced my decision and my colleagues, and we had a hard team discussion, was the fact that A, she's not a surgical candidate, so that's completely out of question, and B, that she was well till pretty recently, so whatever happened was rather acute, and therefore probably she deserved the benefit of the doubt. So we did her CT, and this showed a small valve, 19 millimeters internal diameter, and if you see the VTC there, it's about on the virtual valve to the left main 3.5, and also to the RC about 3.7. The STJ is fairly roomy, as so are the sinuses. She'd had an aortic root enlargement as well. And this is predominantly regurgitation. There's hardly any calcium in that valve. And you can see that the ascending aorta isn't that big. And her legs weren't very happy either. There's severe calcification in both sides. The femorals, not as much, but the iliacs, especially the common iliac, was quite hostile. And we were getting an average diameter of roughly 4 on the right side and slightly bigger on the left. And this is the snapshot picture. So heavily calcified iliofemoral system extending all the way up to the abdominal aorta. So this was our plan, that we would do bifemoral access, and we'd have a radial access for the pigtail, left for the primary access for the valve, protect the coronaries with the right, because we thought that there's a very high chance we'd need to fracture this valve. We would deploy the valve, fracture it, deploy the chimney stent if it was needed. And we also had a firm escalation plan at that age that she would not be for bailout SCVR, but if there was any sort of minimalist, like for example, tamponade or something for which she needed a small sternotomy, then we would go for it. As it so happens, somebody just click that slide for me, just to play the picture. It's not on automatic, sorry about that. Can you just play that picture? Thank you. So there's a standard micropuncture sheath injections on both sides. And so our plan was to protect you have a safety wire up and over from the right to the left, and then also use that for coronary access, for coronary protection with an 8 French sheath, but it all went to pot. We couldn't even get a guiding catheter past the right common iliac. So with a diagnostic catheter, I managed to pass an exchange length Terumo wire across to the left side, for whatever it was worth later on if we needed, and that's a 14 French sheath going in, a centrin sheath. And so we then resorted to using the right radial. So we punctured the right radial and we used that for the coronary protection and the left radial for the pigtail. So this is the aortogram, and you can see free-flowing aortic regurgitation there. And across the valve, which was not very difficult. And so we then did the next step after placing the Safari wire. We put the coronary protection kit in, it's the JL35 with a guide liner and a stent prophylactically placed in the left main to LED. We then pulled the guiding catheter back. Excuse me, sorry. So I'll go to the next slide. Yes. So this is an Evolute Pro Plus 23 millimeter negotiating the left iliac. You can see it's a very heavily calcified iliofemoral system, and with some gentle torquing and pulling and pushing on the wire, we eventually did manage to get through it. I know you could argue that we should have used shockwave, etc. up front, but finances were a big concern as well. This lady had been in ICU for almost 3 months, so the family were incurring a severe financial hardship because of all of this hospitalization. So eventually we managed to get this across with some persuasion across the bioprosthetic aortic valve. Despite there not being much stenosis, you can see that sometimes these valves can pose a challenge for the transcatheter valve to cross. So again, with some gentle pulling and pushing, and I think we were cognizant that we wouldn't push too hard because with an aortic root repair, enlargement, etc., you want to be firm but not excessive with these old frail patients. So we got that in, and this is the starting position. We deployed at 80%, which we felt was a bit on the lower side. So we took a picture and then we repositioned it once. This is a slightly longer run, but I think we'll have enough time, so I won't overshoot my allocated time. So one partial resheath, and we lifted it up a bit. And this was the position we thought was acceptable. And we released the valve at that position, pulled on the wire, the usual standard steps. And with a fairly slow release, but not too slow, given that she wasn't very stable anyway. And so we deployed that, and then we decided to just fracture the valve. It was a very, very small valve, and to give this lady her best chance of recovery after investing all of this, we thought that we would fracture it, and we used a 20 millimeter Atlas Gold balloon. Remember, it was a 19 Biocore with the internal diameter. And there was another reason to protect here as well, because we were going to fracture the valve with a 20 millimeter. I mean, she doesn't have much reserve. She's not going to tolerate too many mishaps, this lady. So, and that was the other reason to protect her coronaries, despite having a wide-ish STJ and a sinus of Valsalva. You can see right at the very end there that the two lines of the Evolute straighten out. So that was a fracture there. And this is the final aortogram. And we were fairly happy with that. There's no regurgitation. That's been taken care of. The valve looks nicely symmetrical, and we felt that we'd be happy to take this coronary protection kit out at this point in time. So we removed the stent. I just took a little shot from the guide, left the wire still in, because as we saw from the last case, you never know where the leaflet is in front of the ostium. But we are happy here, and we closed the left side with a single ProGlide and an angioseal, which is what I do as standard now, rather than use two. And a bit of pinching again with peripheral vascular disease. You don't want to be too aggressive with your ProGlides because you might constrict the vessel. And this I've not seen her yet actually since this happened, since this case, but a colleague, a local cardiologist nearer to where she lives, sent us this report. She's got a mean gradient across the valve of 13 and no regurgitation, and she's had improvement, near normalization of her left ventricular function. And I'm hoping to see her sometime soon. So these were the learning points that I took home myself, and after discussion with my colleagues, that we need to meticulously plan these cases, discuss with an experienced colleague or center if needed, reach out, address all Achilles heels. It's a small prosthesis, it's possible coronary occlusion, peripheral vascular disease, etc. Have a plan for each of these scenarios. Do not accept a suboptimal result. For example, do not leave her without a bioprosthetic valve fracture. Of course, that's got to be within reason. And be brave, offer therapy if clinically justified. And if you think that the benefit is greater than the risk, that is where, should I intervene or not? Set clear expectations with the patient and family, because the stakes are high. And sometimes these patients, it's a risk paradox. They're high or extreme risk, but often they often, benefit the most. So regurgitant salvo with cardiogenic shock, I think in this particular case, TAVI was our best bet. And this is her 3 months down the line. The picture on the left is when just before she left hospital. The picture on the right is very kindly, her son shared that picture. He in fact sent it to me. And this is after 3 months. She's doing very well. She lives in a 3-storied house. She's prancing up and down onto a rooftop garden, and I can't wait to see her. Thank you very much for your attention. Thanks.
Thank you. Any comments?
I think this is a very, very interesting case, and there's a lot of learnings here. And so, Shia, maybe you and I are a little bit different on cracking the valve. Whether you do it, I personally believe you have to have a reason to do it. And I'm not sure whether, and I know you are in favor of cracking before instead of afterwards. Cracking is just not simply cracking and then, it's just something that we can do. I think, as I said, we have to have a reason for it. And if there's the reason for me, if there's an elevated gradient, and that in itself is for me not enough. It depends a little bit on the age. The age meaning activity. If you have an active person, then obviously a gradient, a post-implant gradient is important. And then you should try to reduce it by cracking or by vigorous post-dilatation. The I'm not quite sure whether or not I follow the reasoning, but the protection I think was very well done, and I think it tells you if you trail behind and you have an obstruction of the coronary, then it becomes very difficult to re-enter to do what you have to do. I think prevention here and planning, as you mentioned, is fundamentally important.
I agree, and I think it's a nice example. But I just worry about high pressure inflations after the valve. But there's no right answer there. I think the coronaries are likely okay here because it's a porcine valve, and the porcine leaflets are shorter. But I think this lady can't tolerate anything, so I think protecting is the right approach. So. But I agree, the acute AR is a lesion that once you fix, patients rebound quickly. So I would be aggressive about doing it. Thank you very much. A great case. And so we'll move on to the next presenter, Dr. Honda, talking about rescue, right endocardial scoring, cutting using electrosurgery to relieve an RVOT gradient.
Good afternoon, senior faculty and my dear colleagues. First of all, I would like to thank the whole team of ACVS for giving me this opportunity. I am presenting this case on the behalf of our team, and special thanks to Dr. Arun Gopala sir for helping us this case. I will describe a challenging case of severe right ventricular outflow tract obstruction, where we tried to replicate the success of CSM procedure for obstructive left HOCM. My patient was a 32-year female with the underlying diagnosis of tetralogy of Fallot who has undergone intracardiac repair at 1 year of age. Several years later, she presented with severe residual RVOTO, for which a redo open heart surgery was done, which included an infundibular muscle resection and quantagram patch augmentation. 3 years later, she presented again with a residual right ventricular outflow tract obstruction with a peak gradient of 70 mm of mercury, and there was a focal area of infundibular narrowing. On cardiac MRI, RV ejection fraction was 40%. We had attempted alcohol ablation of the coronal artery in this patient, but that was unsuccessful. This is the 2D echo and the CT angiogram, which is showing a focal area of infundibular narrowing just below the pulmonary wall. Now, what were our options? First option was obviously a redo surgery. Our surgical team was not keen on operating on this patient because this would have been a fourth surgery for her, and because of the risk of adhesions also. Even the patient was also not willing to undergo open heart surgery. Our second option was alcohol ablation that we have done, and we were unsuccessful in that. Third option that we thought of was RFA ablation of the right ventricular outflow tract obstruction. But since this was very close to the pulmonary wall, then it also looked very challenging. So we thought, since CSEM procedure has shown excellent results for obstructive HOCM, so why we could not use in this patient? Now coming to the challenges that we anticipated during the procedure, it is a complex post-surgical RVOT anatomy as compared to the HOCM patient. We have to be very accurate in a target localization because it was a focal area of narrowing. Crossing the fibrotic muscle bundle would be a challenge. We need to maintain the wire trajectory and need to control the electrosurgical myotomy because it was too close to the pulmonary wall. And moreover, the RVOT is thin-walled as compared to the interventricular septum, which is thick-walled, so there was a risk of RV perforation. After a detailed discussion with our heart team approach and with the patient, and we explained to the patient about this novel procedure and the risk associated with it, we proceed towards the procedure. The procedure was done under general anesthesia. We took a right internal jugular vein access, 6 French right femoral venous access, and a 5 French right femoral artery access for monitoring. This is a RV angiogram, which is also showing a tight RV muscle bundle below the pulmonary wall. So we took the right internal jugular vein approach in this patient because it would be more easily to reach the RVOT and it will be more coaxial. Then we took a 8.5 French Agilis sheath and placed it in the right ventricle. Inside it, we put a multi-purpose catheter and a fine cross micro catheter and is a mother-in-child approach and reach the desired area. Then we put the stato wire 30 at 300 centimeter and we localize the area and maneuver that wire across that area, and this is confirming the position of that wire. With the stato wire in position, we did the diathermy 80 volt and the stato wire pierced the RV muscle bundle, and the wire position was confirmed as it is in the pulmonary artery. This process took quite a long time because since we were not able to accurately pierce the RV muscle bundle. Then we snared the wire from the second jugular access. Then we created the flying V laceration in the stato wire and tried to place it across the RV muscle bundle. Then the flying V surface in the muscle bundle was placed across the RV muscle bundle, and the position was confirmed on the RV angio. This step was very crucial because we want to prevent any injury to the pulmonary wall. Then a 80 volt energy during traction was given to create the myotomy, and a continuous 5% dextrose infusion was given through this procedure. This is the post right ventricular angiogram which shows we have been successfully able to create the myotomy, and there is a puff of contrast is going through it. This whole procedure takes around 2.5 hours. Then since we have created some myotomy, we thought why not to balloon dilate this procedure so that we can able to create a good passage of flow through it. Then we balloon dilated it with Tyshek 2 23x5 balloon, and as we can see there is minimal waste on the balloon. Now coming to the hemodynamics, pre-RV systolic pressure was 73 and the post was 59 with a residual gradient of 40. There was no peri-procedure complication. Patient was extubated after 2 hours. The follow-up at 3 months showed the patient had improvement in symptoms. She is functional class 1. There is no rhythm abnormality. On echo, there was a normal RV function with the RVOT peak gradient of 40 mm of mercury. So our now further plan is to do a cardiac catheterization and cardiac MRI at 1 year. To conclude my presentation, transcatheter RVOT relief by electrosurgery is feasible. This is the first report of this procedure for the right ventricular RVOT relief. This is technically more challenging than the CSUM procedure because there was only a focal area of narrowing. This is a post-surgical patient. RV is thin-walled as compared to the thick IVS, and because of close proximity to the pulmonary wall. And long-term results and safety yet to be seen. Thank you.
It's a fascinating case. So with Sesame, we talk about 6 to 8 weeks and further dilation. Do you think there'll be further improvement over time, or because it's a thin muscle band, do you think this is the result that you'll get?
Sir, at 3 months we did the echocardiography. Now we showing only 40 gradient. So we have at 6 months follow-up we will again see if. Then at 1 year we are electively planning cardiac catheterization and repeat balloon dilatation if it is indicated.
But so 3 months it's down to 40 from 70.
Yes.
I see. Okay.
Any role for coils if you're unable to do with the alcohol?
So we have tried alcohol in this patient, sir.
No, but coil closure. Because for left-sided hook'em, sometimes we do coil occlusion of the septal artery. Is it possible here?
We have not thought about it, sir. We can think about this.
What about stenting? So, the stenting the RV outflow tract. I know you were concerned about it close to the pulmonic and the risk of injury to the pulmonic, but stenting and then potentially a transcatheter pulmonary valve later is something that we would consider. Is that something that was entertained?
Yes, sir. Sir, because only stenting would not help the patient because that would lead to severe PR.
Mm-hmm.
So in the follow-up, we are thinking if we stent this and do the transcutaneous pulmonary wall implantation in this patient.
Okay. Great. Thank you so much. Wonderful case. So we're going to move on to our next speaker, which is Dr. Ahmed, an unusual case of coronary cameral fistula presenting with infective endocarditis, which was closed percutaneously.
So very good afternoon to you all. So this patient is a 40-year-old male with no prior comorbidities, had presented with a history of fever for 40 days duration. And he was seen in multiple centers previously, recurring hospitalizations and received antibiotics. So finally he was admitted into internal medicine department of our institute. At presentation, he had fever with pulse rate of 130. He had a BP, a normal BP, and a faint systolic murmur heard in the left second intercostal space. So this was his blood investigations. He had a neutrophilic leukocytosis. ESR was elevated. CRP was positive. Procal was elevated. He had a blood culture done. All 3 sets showed methicillin sensitive staph aureus, but they could not find any source of other infection. Chest CT was done, which didn't show any lung pathologies, and USG abdomen was normal. So he was sent for an echocardiography to rule out infected endocarditis as a source of sepsis. So echo per se didn't show any abnormalities. Valves are normal. There was no vegetation. But however, we can see there was a dilated left coronary sinus with some minimal turbulence seen across the left main coronary. So we thought probably maybe it was RSOE arising from LCC, but vegetation was not seen. So we decided to do a transesophageal echocardiography. So here we can see the TE that there is a vegetation which is seen in the right atrial surface. And we can see a communication, dilated communication, probably from the left coronary sinus coming into the right atrium. And there is turbulence at the entrance of the RA. Probably it's a restrictive opening, which might have led to turbulence, endothelial injury, and might have caused endocarditis. So we can see vegetation measuring around 9 mm. So since he was having active sepsis, we thought of completing the 6-month course of antibiotics and then evaluate for the etiology. So this is a cardiac CT. Here we can see a fistulous communication arising right from the left main coronary artery, transversing between the aorta and the LA, and ultimately draining into the SVC, just some 2 to 3 mm proximal to the SVC RA junction. So it was basically a fistula arising from left main coronary draining into the SVC with a restrictive opening at the orifice. So we decided to complete the antibiotic course before doing an angiogram and further procedure. So this is an angiogram. We can see a huge sinus which is draining into the SVC RA junction with a small tiny opening at the SVC at the RA side. So we decided, so surgical option was given, patient was not willing for surgery, so we decided to close it percutaneously. So we thought of taking a dual access, one venous and one arterial access, do a AVRL formation and probably close with the vascular plug. So we thought of using a multipurpose guiding catheter or a RDC guiding catheter instead of taking a delivery sheath, because there was a 90-degree turn at the insertion point in the RA, and the RA ostium was very smaller. So negotiating a delivery system might be difficult. We made a artery-venous loop. Then subsequently we advanced the 1210 device, which has a disc of 16 mm. And since the average diameter of the fistula was around 10 mm, we thought we'll close it. But however, the issue was the inner lumen of the RDC from Boston Scientific slightly smaller than the longer catheter, and we didn't have a longer catheter at that time. So that failed. So ultimately, we had a LifeTech Sarah plug 12 mm, which could easily pass through the guiding catheter. But the issue was it was grossly smaller for the size of the fistula. So this couldn't work. So ultimately, we thought of taking a larger vascular plug. We had a 18 mm Amblax vascular plug 2, which required 8 of delivery sheath. So we took an Amblax Torque delivery sheath. We packed the exchange length 035 extra foyer into the aorta and then took the delivery sheet inside. And with the contralateral injection, we deployed the vascular plug here. So post-vascular plug, there was residual flow through the device, but it was a perfect fit. It was monitored. The only major concern here was having a thrombus in the left main, because we are occluding a very lost communication, and potentially leaving a cul-de-sac at the LM ostium. So we were started on oral anticoagulation and a single antiplatelet. This is at 6 months follow-up. We can see the communication is totally occluded. But however, you can see that the small cul-de-sac at the left main ostium, with some stasis in the blood flow also there. So the plan was to actually continue oral anticoagulation and review after a year to see how it is. So coronary fistulas are rare and can have present with various clinical presentations ranging from heart failure, angina due to coronary steal, and rarely infected endocarditis. It is better closed if it is symptomatic, and based on the anatomy of the fistula, the therapeutic approaches can be taken. Vascular plugs are usually used to close such large devices which are sized at least 50% more than the vessel diameter. And an important thing is to continue anticoagulation and regular follow-up, because there is a potential for thrombus formation in the cul-de-sac. Thank you.
Any comments from?
Actually, wonderful presentation. So, I mean, I had a couple of experiences in these. Whenever it is infected, even though I closed it effectively, that the patient's infection did not resolve, and obviously that it can get enlarged later on. So, what's the long-term follow-up that you have in this gentleman?
This is around 9 months. So we did the procedure after we completed 6 weeks of antibiotics. It was totally afebrile and ESR was normalized. So currently 9 months. Till now is fine.
So my question to you is, I mean, and that's what I'm saying, that in my experience that those patients still had to go for surgery, even though surgeons turned down in the beginning, and then I had to push them to take the patient back to surgery. Why not surgery in your patient?
He was really adamant to undergo any procedure. Even for this, he was not ready. So ultimately, he had to convince for this procedure rather than surgery.
Right.
So it is basically patient will. First option was surgery, not intervention, but since the patient had refused totally. So
right. That's very good. Actually, I mean, obviously, surgery has to be pushed in these people as much as possible. Number two is that AVPs, all these plugs are quite expensive, and you could also think about using even just a VSD or a ASD type of device in these patients as well. One such patient that I closed is a huge venous graft from the aorta. And so there was enough neck that actually the device would go and close it. And it was a giant aneurysm of the vein graft, and it was compressing a very big, 8 centimeters almost, and it's compressing the left atrium. And so we closed that with just a PFO or ASD device, actually. So I think that's the other ones. Any comments?
I think it's good. I think your point about left main, I think in general, it's going to be okay. You have good flow in the coronaries. The question about what is the long term is what remains to be seen. And that if that proximal sac gets larger or it's infected, then it obviously becomes an issue. But it's a very nice case. So thank you for sharing it with us. And so the last speaker of this session is Dr. Swami talking about the wandering occluder, retrieval and redemption in ASD closure.
A very good afternoon, everyone. I would like to thank the ACVS team for giving me opportunity to present this case in the forum. Myself, Dr. Periyasamy from Madurai Medical College. I'm a final year postgraduate. And I would like to thank my department faculties, my HOD and assistant professors for giving me the opportunity in this juncture. So my patient is a 25-year-old female. She was asymptomatic at presentation. And she was diagnosed to have a ASD during her routine antenatal echo screening. And 1 year back, her RA-RV was volume overload at present on evaluation. So she was planned for a transcatheter device closure. So routine echo assessment done, both transthoracic and transesophageal echo confirmed sufficient rims at 0, 45, 90 degree. She was found to have a malaligned ASD measuring the maximum diameter is measured around 10 millimeter. So we planned for a 14 millimeter ASD device closure and upsizing of device planned on table if required. So the maximum measured diameter is 10 mm and we chose a 14 mm ASD device and upsize based on the need on table. So this is the transesophageal echo showing the ostium secundum ASD with adequate AV rim and posterior rim. And we're able to see the malaligned ASD in the short axis view and the maximum measured diameter is around 10 mm. So we proceeded with transcatheter closure and we take the hardwares or 6 French venous sheath and 6 French multipurpose catheter and 035 amplitude stiff wire and a 14 mm ASD occluder and 10 French cook seat. So as with the regular ASD device closure, we first cross the multipurpose catheter through the ASD into the LA and into the left pulmonary vein, and we exchange with the 035 amplitude stiff wire. Then we load the device 14 mm device along with the 10 French hook sheath, and we initially deployed the left atrial disc followed by the right atrial disc. After the push-pull technique, we release the right atrial disc, and the final clip shows relatively a decent result, and the echocardiogram on table also shows there is a adequate seal and there is no residual scent. This is a post-procedure routine echo on the same day during the evening around 6 p.m. and we found the device embolized and it's not seen in the LA, RV, LV anywhere and not in the pulmonary artery, and we are able to see the residual sun. So we proceeded to shift the patient to cath lab and retrieve the device, and the hardwares we taken for this is 6 French venous sheath and 10 French arterial sheath, 6 French multipurpose catheter, 5 French vestibular artery catheter, and the snares of 10 millimeter, 15 and 25 millimeter, and upsized 14 millimeter Mullin sheath and amplitude stiff wire and 20 millimeter AS septal occluder. So this is the embolized device. So we thought the device in the pulmonary artery. So with multipurpose catheter, we enter the RV and we try to reach the embolized device. So after even multiple attempts, even after using snare, we couldn't catch hold the ASD device. So after a long time, we did a angiogram. We found that the device is not in the pulmonary artery; it's in the descending aorta. So after that, we are able to catch hold the device and we retrieve the device. On the same sitting, we again reassess the rim, and we found to have, we reassess the defect. We found to have the defect size is 16 millimeter, and we upsized the device, and we deployed the 20 millimeter upsized AST occluder on the same sitting. So in this clip, it shows a deployment of the left atrial disc, and followed by right atrial disc, and it shows a relatively far result. So this post-procedure echo showing the AST occluder in the position, and there is no residual shunt. So the key points after reassessment, a 20 millimeter AST device was successfully placed in the same sitting, and the patient was discharged with antiplatelets in stable status. Patient on follow-up and doing well. In this case, if we thought the device is in the pulmonary artery, so if we earlier do a lateral projection, we could identify the device in the aorta at an earlier stage, and we avoid longer fluoro time. So the take-home message: early recognition and prompt percutaneous retrieval of embolized AST devices can avoid surgical intervention and enable successful redo transcatheter closure. Successful management of AST device embolization highlights the importance of operator experience, procedure planning, and endovascular rescue techniques. Careful assessment of septal rims and device sizing is crucial to prevent embolization and ensure durable ASD closure outcomes. A procedural complication can still culminate in procedural success when recognized early and managed systematically. Thank you.
Thank you, doctor. I think we're all running slightly behind schedule, and we need to break here for lunch. And the lunch will be in Kanak restaurant to the left for the faculty, and Tuscany restaurant on the one floor above, the 6th floor for all the delegates. Request all of you to join back here by 2:30 p.m. sharp. We have interesting talks coming up on complication management. We have experts talking to us how to avoid complications, and that is a good thing. And later we have a congenital intervention session. Again, it's interesting things coming up. And finally, before we break in the lunch, we have another set of interesting things.
No. Let the people stay. 1 minute. Dr. Periyaswamy, I mean, a fantastic presentation. Just with, sorry, Dr. Srinivas. So if the patient's device has embolized, I think the first thing that everybody should do is just to get a chest X-ray or a CT scan. And a CT scan would have given you, I know you were poking in the left atrium wherein the appendage is there, and you probably would have caused some trauma, and luckily nothing has happened. But why not a CT scan? I mean, I'm ashamed to say that I had probably majority of these complications as well. So my 30-day patient came back after and can't see the device. I said, what happened? He had chest pain the day after the device was implanted, or the same day at night. So it went and sat in the pulmonary artery, and I could not pull it because it was more than 4 weeks now. And so that patient, unfortunately, the way it was sitting, I can't even get hold of it. So why not CT in your patient? That's what my question is.
Yeah, on table only if we detect, no need to CT, no?
It was later on.
No, it was later on.
But
But in general, very unlikely that such a small device gets embolized. Always head towards using little bigger size device. Bernie Meyer says very clearly, because especially the patient is total IAS length is good. There's no harm in taking little 4 mm, little bigger device. That always helps to prevent such embolizations. And I think your points are well taken. We'll break because we're running behind. We'll join back here at 2:30. Thank you. I request all of you to be in the hall by 2:30. Tuscany restaurant for delegates on 6th floor, and the Kanak restaurant to the left for the faculty. Thank you.
Pneumonia, uncrossable lesion, wire cross and balloon uncrossable. What to do? What is additional strategy? Welcome.
Oh, you. Can those lights go on? Yes, thank you.
Hello. Hi. Sorry about this delay, but first of all, let me thank Srinivas Kumar for inviting me and giving me the podium to speak on a topic dear to my heart. I'm going to take the next 10 or 12 minutes to talk about the uncrossable lesion which we all face. My story with the excimer laser in its use was started in 2021 February with this case, which was a proximal LAD, which was totally occluded over a 10 millimeter segment, calcified, and we crossed with a UV3 wire, but the microcatheter wouldn't budge. And this is when we used our first excimer laser. We started off our experience with low energies, and then nothing happened with the low energies, so we moved on to 80 fluents, 80 reps. With that, the catheter just walked past the CTO, and you can see the calcium all around it, which explains why this was a problem. It turned into a regulation angioplasty based on the IVUS. We completed the case, and it wasn't much to talk about after that. So started our experience, and the uncrossable lesion where we cross with the wire, we struggle with the wire, and then the microcatheter or the balloon, the smallest balloon doesn't cross. There are various definitions of the uncrossable lesion, but what I like to believe is an truly uncrossable lesion is a lesion where you're unable to deliver a specialty wire downstream and where the choices of devices are narrowed to very few. And in those situations, it's either microcatheter which doesn't cross, or you could use a small little balloon and that doesn't cross. If you look at the data is scanty, and just picking up a couple of them from Ojeda's lab in 2020, they presented this 126 cases, out of which only a few were uncrossable, and their success rate with using the ELCA and that was around 82%. Our own data, which we presented, the first 2-year data, which is 77 lesions, was 26 were uncrossable in that, and we had a 96% success with a technical success of almost 100% in this using the excimer laser. Around 9 to 15% of these cases of CTOs are going to be uncrossable by microcatheters and small balloons. And they represent the calcified segment of the CTOs, and they represent proximal tortuosities which lend to the complexity of these patients. And it is the second most common reason for failure of a CTO PCI. In the pre-ELCA era, before 2021, we often crossed and struggled, and 30 minutes, between 30 and 51 minutes, or maybe 60 minutes, we would cross with a wire in most of our cases. But to complete the case from the first time when we crossed successfully to completion of the case, like in these examples, took us 70 minutes and 82 minutes therein. This is because we then start with small balloons, go to bigger balloons. We use guide extension catheters. We use various devices. Sometimes we have to use a rotoblader, sometimes, and so many other things. And there's a lot of exchange of material that happened in these cases. ELCA has reduced this time to around 30 minutes. Whatever the scenario, whatever the complexity of the cases, if you are able to pass an ELCA through and get a successful navigation through it, then it reduces the end procedure time. Post-ELCA, we have this mid-LED CTO, which was uncrossable. We passed with a UV3 wire, and post-UV3 wire, a fine cross microcatheter or any other balloon would not cross. 6 minutes later, an ELCA has kind of crossed it.
I'm sorry, we don't have slides.
Oops.
Can technical support help us? There was probably connection problem.
That's better.
Kitty, if there is still a big problem, then maybe we go ahead with different presentation.
Would you like me to stop and let somebody else speak and come back if it gets resolved?
Initially, everything was fine.
Too big a file to transfer. It's all in keynotes. This is the only way. I think this is the best way to do it. Yeah, this would be. Perfect. Yeah, sure. I have no idea. It was out there. I think connected here. That's the best option. It's confusing. Absolutely. I can just come back and not waste time, really. Yeah. I don't have a pen drive big enough to kind of copy all this data. I didn't carry
Okay,
Get somebody else.
so we go probably.
Might be better.
Okay, so we go ahead with the next presenter.
Can you put it over there?
Vijay Trehan, embolized stents or embolized material prevention and management.
This one work. Oh. I don't know why it stopped. Ask them at the lunchtime. Check. Try this connector. You want to put this connector? Yeah. Yeah. Let somebody else speak. Maybe we can take 2 minutes and. That's okay. Let me not waste other people's time.
Sorry for this confusion, but I request all the speakers if you can present through the same laptop which is there here, and then these problems won't be there. If you're trying to change into Keynote and different laptops, there's some compatibility issue. I think. Anyway, we'll go to the next speaker. Then Kirti will come back later.
So good afternoon, everybody, and thanks, Dr. Srinivas. Thanks, Dr. Kirti, also for letting me speak ahead of him. So my task is to talk about something which still occurs. A lot of us have faced all these things in the past. I'll just give you a tale of one of stent embolization recently in the last week. One of my juniors in different hospital was addressing this LED, probably did not realize the magnitude of the length of the lesion as well as the tortuosity and some calcium. And during his struggle to deliver a stent, there he find neither he can push the stent nor he can pull the stent back. And there goes the stent off the balloon lying in the proximal LED. Now this could have been very easily preempted. And also at this point in time, he could have very easily handled this problem, but he did not realize it. And during the struggle, his LED slowed down, his wire came out. Now if you look at it, the wire is outside. Then he tried to wire the stent. He was not able to wire the stent. Finally, he was able to have a wire alongside. And then he thought he'll take another stent and crush this stent with the next stent. Only to find that he made a first mistake of not preparing the bed. This time he should have prepared a bed, at least crushed this stent with the balloon first. And what he finds is this second stent also finds it difficult, and he loses both of them. So you see them there. Might look very exciting, funny to some people, but it's not very surprising for me. Have a close look. So these are the two stents. Now his guiding is down. Patient fortunately is okay at this point in time. Another look, you see the proximal stent is part into the left main, part into the diagonal, part into the LED, and the distal stent is in the LED itself. Well, he was lucky enough to utilize that part, took a snare in, he was able to catch the proximal stent, which was part of it was in the left main, which was roomy, and his guide was able to go there, so he was able to catch and take it out. The distal stent had moved a little further, and he tried all his tricks. He had learned a lot of tricks. He tried all of them, and finally he managed to wire the stent abluminal first, then luminal, and then today's balloons are very good, so they are able to pass from outside the stent into the stent and then through the true lumen out, and then he was able to inflate a balloon and pull it out, but only to realize that he's not able to really know as to where the stent has gone. So search was on, but he did not realize. Now this might look funny, but any of us can get into this trouble. I was trained and I started to do stenting when I used to have stent just like this, put them on a balloon, hand crimp it, and even today you do with the CP aortic stent, but they used to dislodge very frequently. Then came crimping tools for the coronary stents like Today I have further TAVR. But the dislodgement became rare, but it was very difficult to crimp them. You cannot do that in the cath lab, just straight off. We used to have a B2 stent from Medtronic, which we used to have a crimper on and crimp it and then deliver. So then came the factory made stents, and then this thing almost disappeared. If you review one of the JACC articles, 1999, nearly 10% of the stents were not delivered. Some of them are lost, some of them just strip off the balloon. Now, if you talk to some of your colleagues, they will say, "Mere saath to kabhi nahi hua, never happened with me." But, well, someday it could be your day to get into trouble. Now, the stent can meet a hostile environment right before it enters the guiding. If you're using a reused TUI valve, especially if it is tight and you are in rush, it is possible you kind of compromise the integrity of crimping. Especially so if the TUI boss is also having a crowded environment in the form of a microcatheter, an IVUS catheter, or a balloon there, then if you try to rush in, it is possible your stent doesn't get off, but your crimp is compromised. Now, if you're walking through a big guiding, straight guiding, probably not a problem. But if the guiding is smaller, especially if it is kinked somewhere, sometimes it is at the groin and you don't realize. And also, if you're walking through a marked tortuosity, the dia of the guiding is decreased. A 6 French guiding will decrease to, let's say, 5.5. So the environment will become constrained, and there are chances that you have a hostile environment that stent gets stripped off. Company-made holes are very good. They usually don't offer any kind of a resistance, but many of us are in the habit of making holes by using needles. And if you use a needle, see what is happening. Your stent might just be stopped by the invaginated plastic of the guiding catheter. And sometimes you are able to force it, only to realize that if you look at it, your balloon has gone past the stent and the stent was caught by the plastic inside. So if the track is treacherous, like tortuous, and that too circumflex, and especially if you're taking a long stent in a calcified environment and you don't have a good guide support, you don't have a guide extension there, well, this is a good recipe to get into a trouble like this. Especially so if there is a recently deployed fresh stent which is not endothelized. It has a tendency to catch these struts. So I think what is very important is look for these two balloon markers and look for the ends of the stent and look for the distance. If you see this distance is bigger or longer than this distance, this is done by the company. You may not have a stent which is exactly centered, but even if the distance is asymmetrical, like proximally it is more, distally it is less, but if you are moving a stent, you must watch this distance should remain constant. If you find this distance is either increasing or decreasing, that means you are in for a trouble. Just watch here. Watch the distal end. See that the balloon has gone past, that means the stent was constrained. Similarly, watch the proximal end. The balloon has been pulled and the stent stays there. So it is possible you dislodge the stent while pushing or pulling. But if you watch it and if you are carefully observing it, it is possible that you can solve the issue by just stopping there and deploying the stent there only. Except if, let's say, it's a 2.5 millimeter stent and you are in a problem like this in the left main, which is 5, where you cannot deploy the stent. But for most situations, you can deploy the same stent there and then. So while you're trying to withdraw the stent, you must watch that it is well aligned or not. If it is not aligned, if it is aligned, it's possible you can swallow it into the guiding catheter. But if it is not aligned, you will have a coupling at the proximal end. And the moment you realize there is a coupling, I don't think you should make any effort to take it into the guiding. Just try that you take the assembly out as a whole, both the stent as well as balloon. However, if you ask me, is that the best method? I will say probably not. If, let us say, you realize that there is proximal end of the stent is got everted. If your guiding is in line, it is possible that you get into the guiding. If your guiding is not in line, then you try to align it. Otherwise, your stent will not get inside the guiding catheter. So best way in this situation is, rather than pulling the assembly as a whole, is you take a snare, advance a snare over it, and then pull it, because this gives you double security. If you pull it down like this, that means you're held the stent. If you don't pull it down, let's say you're without a snare, and let's say you're walking through an aorta which is tortuous, which also, let's say, has atheroma there, which is calcified, then there is a good chance that you let the stent be stripped off in the abdominal aorta. So if the stent is still on the wire, then general recommendation is that you pass a small balloon. Now remember, small balloon. This balloon should be small enough. Sometime it is just 125 balloon. Sometime it is just 1 millimeter balloon for a very small stent. Because if you inflate this balloon a little bigger, it will be difficult for you to pull the stent out. Small balloon. Second thing is very low pressures. Just enough to grip the stent. You don't have to deploy the stent there. So if you inflate it, which is not touching the vessel wall, small balloon, and that to proximal area, part of the balloon proximal to the stent, so that the proximal end is relatively smooth. And then if you pull it, mostly you will get it in. But if you're not able to get it in, all what is required is just align your guiding catheter and you'll be able to swallow it. Sometimes this doesn't work and you might have to take the balloon distal to the stent, inflate the balloon and then pull the assembly. Sometimes you're not able to pass a balloon. Then if you're not able to pass a balloon, then you intertwine the wires. If you intertwine the wires, you pass one wire down and then you pass the second wire, which preferably should be in a different branch, and then try to twirl them, and you twirl it either using a single torquer in one direction or two different torquers in two different directions. And as you are twirling with two wires in two different branches, twirling, this stent will start automatically get pushed up. Now again, same thing, if it is not getting in, you have to just do an alignment, and once you align, and you will find that the stent will enter during twirling itself. Well, if the twirling doesn't work, then snare it out. Micro snare, remember, this micro snare should go in a nearly closed position. It should be just open to walk over the vessel. If the micro snare is open, bigger, then it might catch something different, something which you don't want. Sometimes a calcified spur is caught and then you start pulling on the vessel. So just enough, reach the proximal end of the stent, open the snare loop and try to catch it from near the proximal end. Don't advance it too far onto the stent. And try to pull it, same story. If it is not aligned well, align it, this will get in. If the snare is not passing over it, then sometime what you can do is you can take another wire and then pass the snare over both the wires. This will make this loop get on the other side of it and may be able to pass over it. And if you're not able to pass, take a closed loop, go distally, open this, come back. It might just slip over the stand. And if it doesn't slip over the stand, it stops there, tighten the noose here. And if you tighten the noose, you can pull down, pull back, everything. Now, if the vessel is roomy, straight, non-calcific, and then you are able to kind of snare, balloon or twirl, they will work. But if the vessel is smaller, tortuous, calcific, and stent is long, then probably none of these will work. In this situation, either your snare, if you snare it from the proximally, may work, but the best in this situation is have a balloon inside and try and deploy the stent there. Now, if the stent is lying in a distal vessel and still on a wire, then try to wire the stent like the first case which I showed you. If you're not able to wire, then sometime you can take second wire, pass it alongside the stent, block that space, then you try to wire it. For most of the time, CT operators will be able to pass a wire through it. If you're not, then I think on the second wire, you take a smaller balloon, bigger balloon, and then you try to crush and put a stent there. If this stent is, so I think this I've told you, if the stent is not distally but is proximally, well, you can most of the time catch it with a snare, but sometimes you can catch it with forceps also. And if the stent is small, lying proximally in a large vessel, you cannot, let's say, get it back with the help of a balloon. Try to push it. Let it go to a distal vessel where this stent size can match with the distal vessel, where you can possibly deploy it there. Now, one very important thing. You must have seen it, but I have seen it very commonly. That you have caught it, but now it is very difficult for you to get into the sheath. This is because your proximal end is everted and flared up. And sometimes you try to apply brute force, you lose the stent in the groin. And the worst thing is to call your surgeon for giving a small nick and taking out a stent from there. That probably is the worst thing. Because surgeon to bulana nahi chahiye kabhi. So if you have to call your surgeon for this small little thing, I think it is very important. You should kind of preempt. And the best preempting is use a bigger sheath. Now let me ask the experienced people here. Your stent is on a 1/4 wire. If your stent is on a 1/4 wire and you want to upsize the sheath, if your groin is not thick, it is not fibrous, you can maybe take 8 or 9 or 10 French sheath over it. But let us say your groin, some of the patients have undergone second, third, fourth procedure and the groin is fibrosed. So can you take a 10 French sheath over a 1/4 wire?
I think you put a dilator, first put a small dilator, then a little bigger.
So dilator will only dilate the skin hole and the vessel hole.
So once the
And once you
bigger
take out the dilator, you
is
bleed
there,
more.
well, I don't know. I have not put a 10
Anybody in
French,
the house?
but I think.
Well, that's not the answer. Anybody in the house?
I would put a Grand Slam alongside and put your sheath over both 014 wires, or you can put 3 014 wires and go over a dilator.
So you put one 3/5 wire or
no. I put because you can't take the 014 out.
So
put,
one
multiple
trick.
014 wires.
So that's what I'm saying. One trick is that you keep sizing up or you put more wires. That is one way which works. But very often, a lot of people do not either have an access to these stiff wires, and especially these wires 182, 125, and 32. Most of us do not have it in the lab. And in the lab, most of the time, what you have is a 3/5 wire. And if you put a 3/5 wire alongside a 1/4 wire, then you cannot advance any sheath over it. So the simple trick which works in most of my cases is, you see, if this is like this, you passed a 3/5 wire alongside this. Now you try to pass it. This will not go because the tip of a dilator will take only 3/5 wire. But all of us know that if you look at the dilator, you cut it here, that is the lumen. If you go proximally, the ID enlarges. So if you cut the dilator tip there, you let's say shave off or sacrifice last terminal about 1.5 inches, then what you realize is your lumen is big. This bigger lumen is able to adjust both a 3/5 and 1/4 wire. Like happened in this case, you see the dilator is cut, you have a 1/3/5 wire, 1/14 wire, both of them are able to get into it and you're able to take a sheath down, and then, well, it may be somewhat easier for you to catch back. Well, in the interest of time, I'm not showing you how to make a snare in the cath lab itself. What is very important is try and maintain a guide wire position. Very, very important is ensure good anticoagulation, because in the crowded environment where the stent is crumpled, there is always a bigger chance of a thrombus formation. And if things have gone below knee, just be conservative. If you are beyond pudendal artery, I think you can be conservative. If you are in the pudendal artery, then I think might have to call somebody for your help. Thank you very much.
Thank you for your very interesting presentation. Maybe some questions or remarks?
So the question is that nowadays we are doing a lot of intervention through radials, and just in case you get into trouble, then what should you do? You always have a femoral with you. So if you have a femoral with you and the proximal end is everted, it cannot get back into a 6 French radial sheath. So you go from the femoral, catch the distal end of the stent or a balloon or a wire, whatever it is, you can bring it down and take it out from the femoral, and all what you have to do is just cut the or transect the balloon catheter. Yeah. Periphery means you want to pull it out. Well, if you want to sacrifice your radial, then generally then you can even leave it there. But I think you generally lose a radial in about 2%.
Actually, I don't know. I have had an experience with the radial. So I think you showed that if you catch it proximally, you will be able to pull it out.
You can get it.
The problem is people sometimes catch it halfway through or on the top part, then the whole stent gets everted. And then there is a problem.
Yeah.
It bends on itself.
But 6 French, sometimes it is difficult to get it. And if it is difficult to get it, go femoral with a bigger sheath, catch from the other side. And as you're pulling it, cut the shaft of the balloon.
I think to have more discussion and avoid wastage time, morning it worked very well. You just scan this batch with your phone, and once the agenda comes and ask your question comes, if you ask and type your name and question, it gets displayed. So a lot of people, more discussion can happen without a questioner asking, wasting time. So chairperson here will see it and will answer the questions. Please use that format.
Okay, thank you so much. Maybe could you make some remark? When would you use a guiding extension if you have troubles with the stent treatment? So you feel stent is not really going back. So when do you think about?
So nowadays, I think guide extensions are boon, and if you have to use guide extension, I usually use a guide plus 2, which is the most flexible of the guide extension, which I can take into. I even able to go into the distal. Most LAD go into the PLB and PD with a 5 ES guide plus 2 from Nipro. And the special use of guide extension is if you, let's say, do not have a micro snare with you, and there is something, some foreign body, some balloon or a wire or a stand, whatever, it's lying distally, and you find your micro snare is not able to go, then what you do is advance your guide extension as far as possible, as close to the dislodged stent or anything, and then you take a handmade snare, which you just do it by rolling up a wire, the radiopaque part of the or soft part of the wire, and trapping it with the inside of a balloon, and then you can take it out. It, in fact, guide extension gives you or permits you to be selective, working in that area.
Yep.
Very
Perfect.
good.
Perfect. Thank you, Katie. You are ready, hopefully now. So second attempt. Laser use for uncrossed lesions.
Hopefully it will work this time. Let me just run through all the slides that I've already shown you. Can we? Yeah.
Can you go ahead by manual?
So we had even seen the LED fully crossed. I think you have stored the rehearsed timing. Kirti? I think you have stored the rehearsed timing on your PPT. That's why it's not getting forward.
It's not a PPT, it's a keynote. But
even keynote, rehearsed. He's not able to jump because...
No, I'm not able to trigger the next slide on this.
This is... Yeah, this is stored.
Can you change it for me? Okay, go next. Go next, go next, 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 next.
Yeah.
Just go to slide 8, I think. Go to slide number 8. We've talked about all this, yeah. Go ahead, go ahead, go ahead. I think we were here, and okay.
Yeah, we were here. Yeah.
When we talk about CTOs now, and in the current practice, we pass the UB3 wire as against taking a longer time. In 6 minutes, we can get the ELCA going past and turn it into a regulation angioplasty next, and we can conclude the case pretty quickly next. So in the CTO lesions, facilitation of the procedure after the initial wire crossing reduces the time of the procedure. And this is something that we have seen consistently. The wire crossing to the first balloon dilatation as well as completion of the stents. Next, the tips and tricks. Most of the times for these uncrossable lesions, don't waste your time with lower energies. Go to 80 fluents, 80 reps. Anything less just does not work. Get a guide extension catheter close to the proximal lesion and flush out the contrast before glazing, because otherwise you would laze in contrast. Slow advancement is the key. Next. Now, this in non-CTO cases which are calcified and uncrossable, I mean, we have a lot of those, and this one which shows the CT shows an eccentric calcium right there. Next, please. You can see that proximal lesion which is tight. Looks like a garden variety of lesion most of the times. Next, till you see that your IVUS catheter just does not cross, your microcatheter doesn't want to cross. So here, next, we use an excimer laser according to algorithm. Next. And this here, the 0.9 fiber at 80 fluents, 80 reps, you give around 5,000 pulses, and you see that the laser catheter does not seem to advance fluoroscopically at all. So most of the times people think this is a failure of laser. No, it's not. Next, because what happens after that is your IVUS catheter, which did not cross, just walks through. Once it walks through, next, you see the reason why this had not crossed is that chunk of eccentric protruding calcium. And because of a favorable wire choices, wire bias, I chose rotational atherectomy post this. Next, and post rota, cut, next, and complete the case. So the next, what happened is, next, in the previous case, the excimer laser converted an uncrossable lesion, modified the lesion even without crossing it to something that would allow microcatheters to cross, or made it crossable, thereby allowing new technology or other technologies to be set in. The same in this ramus, which is classically FFR positive, long and a large ramus. Next, a microcatheter, UB3 crosses, our microcatheter fails to cross. Next, and we put in an excimer laser 8080 again in saline itself, causes, makes that lesion vulnerable to having crossing with a Wolverine. In this particular case, we cut it, IVUS guided sizing with a long DEB. We conclude this case. 5 years down, this patient's doing well. Next. Sometimes we feel these stubborn, uncrossable lesions where we've used all technologies and nothing seems to work. And here's such a case. Next. This is a lady who had angina on effort. This is a calcified right coronary artery. It's not a CTO. It's a heavily calcified and tortuous artery. It was easy to get a wire in. Next. But the microcatheter just is stuck. It would not move. We used an ELCA with saline and with contrast, but both failed. Next. So we had failed. Next, we thought we'd get a microcatheter there and put a wire in. We were able to get a rota drive wire in. Rotablator, 300 seconds of rotablator with a 1.5, nothing budged. Next, both the technologies failed. Our small balloons, everything failed, till such time that we proximally dilated that lesion. And when we proximally dilated the Wolverine, created space for a guide extension catheter to go closer to that lesion, then we gave contrast. And in that contrast, we lased. And you can see those bubbles going down, and that is cavitation. So in these uncrossable lesions, for laser to be effective, you have to be able to get cavitations and good sonic forces there. That takes up the pressures to around 120 atmospheres. That's how these lesions break. And this became possible. A balloon, a Wolverine went in and crossed that lesion. Next, we concluded the case with this as a final result. The message I want to give is using a laser, the device is important, but the method of using it, the method is far more important than the device alone. And that's important. Next. When you get into CTO with ISR, there's a mix of tissue there. There's thrombus, neointimal hyperplasia, neoatheroma, and calcium. And ELCA is probably the unique device which kind of works in all these plethora of cases when you talk about the atherectomy tools that does and deals with all of them equally efficiently. Next. Here is a case we did a live CTO in the 2023 IJ CTO. It's a proximal LED, and we had we got a wire into this ISR, but the wire was subintimal, and with the subintimal wire, a microcatheter just could not be pushed into the CTO body. So essentially, next, what we had is we had a situation where the wire was subintimal. Next, a microcatheter stuck at the proximal cap. Now we are not able to manipulate our wire in the CTO body. So we have problems. So here we used an ELCA, next, just to go into the CTO, just across the proximal part, the proximal half of the CTO. And we used a little bit of contrast to disrupt tissue. Once we did that in photons, around 4,000 pulses, next, what happened is a dual lumen catheter was walked into the CTO body. We were able to do a parallel wire, get into the CTO segment, then we lased it again and completed the case. So even if your wire is not truly in the lumen, and if you find something obstructive, the laser can change that plaque for you to make it crossable. Next. But this has to be done with a lot of care. Next. This is an ISR CTO, 2 layers of stent, and of course, this is off-label, but contrast lasing done, you have to actually exert almost 5,000 pulses on these kind of cases, because unless you exert 5,000 pulses, you don't achieve enough of fulguration of tissue inside. Next. You can see that this is a severely underexpanded stent. This was a go back to the previous slide, please. Next. Yeah. Stop there. You can see that the vessel is around 7.1 millimeters distally in MSA, expected MSA, and 9.5 proximally. But what the operators previously achieved is just 3.6 and 3.7, grossly undersized. Next. So post-contrast lasing, we used a cutting balloon at 18, and most of the times once you use contrast lasing, you don't need other tools like IVL or things like that. A cutting balloon does it enough at 18 atmospheres. We were able to improve MSAs to 8.4 and 7.8 in those areas which were underexpanded, and all we did was 2 drug-eluting balloons, and this was our final result. Next. Next. I would like to just point out for a brief moment over here the role of photon CT in all these complex cases. Here, next. This is a CT, this is a PCI which was done when this patient was traveling. He was in Cambodia, had a PCI for an inferior STEMI, and a stent was placed in the distal RCA. We don't have any records of that stent. All we know is it is a 2.5 millimeter stent. Now our angiogram shows this, but our CT scan, it was so difficult from the angiogram to figure out the anatomy, but our CT scan said something very simple. And if I have to show you the point, the operator's last put in a stent, and here this frame actually shows that the stent was placed into a small PLV, jailing the large PLV to the side of the stent, and jailing the PDA as well. And the CTO stent, the CTO segment extends into proximal segment of that stent area into the mid RCA. Having said that, next, you can see how the stent has jailed that large PLV. Next. It took us a little over 2 hours to get a wire in place, but then the microcatheter would not budge. You can see the next frame, microcatheter would not advance. Next, we laced it with saline and contrast, and 20 minutes later, next, we had completed the case. Next. In the ISR CTO, what we've realized, and we're writing a paper, we're trying to put this together in a paper, reduces distal embolization, we believe. It reduces the incidence of slow flow, and it improves stent expansion better than most other comparative technologies. Next. Tips and tricks. I think the most important is that in ISR, you don't just do saline ELCA. Unless you do contrast ELCA, you're not going to get the desired effect. Because initially, when we started doing ELCA with just saline in these patients, the expansion was still stubborn and not complete. Next. We've got now around 60 cases of uncrossable lesions where ELCA was used. We've submitted 47 of that in a registry, which is 364. Alfonso, a friend of mine from Spain, is actually writing it up and send it to Euro Interventions. Hopefully it'll get published. Next. I think I want to leave with a small little algorithm. We have these conventional technologies that we use for uncrossable lesions, which is great. But I think what I propose, and I hope that people can accept this, is a contemporary alternative with using ELCA early on in the case, and this will save us a lot of trouble. Quick, predictable, and prevents multiple material uses. Thanks. Next, uncrossable lesions are a certain factor for PCI failure. ELCA is highly effective and a safe device in the subset. Success of the ELCA depends upon the technique, not just the device. Next, I think anyone claiming to perform chip PCI should have an access to ELCA as a tool in the cath lab to complete that one case which they can be stuck with. Thank you. And really sorry about wasting all the time.
Thank you so much. We have now complication session. How often did you observe perforation or something like this?
So in the uncrossable segment, we've just analyzed. I mean, it's sent for publication, but of the 364, we had 3 perforations, but only one was a contained perforation, Ellis class 1 to 2, but no pericardiocentesis required, which was related to ELCA. The other complication rates were related to either post-ELCA dilatation or post-ELCA rotational atherectomy, and those were the two. So really, ELCA-induced perforation in the entire series of 364 cases, we've seen only one.
Okay, slow flow, no flow, how often?
So slow flow happens in much less than what we do without in the stent failure. The stents which come in early, in the 6 months to 8 months, that's where we see most of our slow flows with our conventional technologies. But as against 6 or 7 on one end, 1 to the other. We've had one transient slow flow with a transient AV block in a right coronary artery with laser, but otherwise no.
Yeah, okay. I personally use only a few times per year laser, but I think we should change our thing.
I think we've highlighted
to save
this
time, as you mentioned.
We've highlighted this in a task force statement, consensus statement, which we've written along with Manet, Egret, and Peter O'Kane, myself, Alfonso, and Poitro Wazinski. And we've written this down. It's accepted in JACC intervention, should be published. And that'll be a great read article for you to set up and kind of the indications where I think ELCA is re-emerging.
If I can just ask you to summarize, what percentage of cases would be uncrossable lesions?
So I said that in my slide around.
What is the other sort of gamut of cases where you're using it?
So the uncrossable lesions in my practice were around 15% of our CTOs that we did, but that's probably because, I mean, someone who's a CTO operator like yourself, you will have more uncrossable lesions than most other people.
Yeah.
But if you look at the various studies of PCI and CTO PCI, if you look at the CTO registries, it varies from around 6% to around 9.5% is the incidence of uncrossable lesions.
Yes.
And most of them, around 70% of those patients, the uncrossability comes from calcium and proximal tortuosity. I think your second question was, what is the other indications?
You are using it in...
So for me, when do I pick up an ELCA? I pick up an ELCA when my wire crosses in a CTO. Now I just take an ELCA if my microcatheter does not cross. So if microcatheter struggles, ELCA
that is one
first device.
One type of case. You take it in calcified lesions?
In calcified lesions, that's a great question. So in calcified lesions, if I cannot deliver a rota drive wire distally, or if I cannot deliver a Viper wire distally, then that becomes my first choice. It becomes my second choice if after doing a rotablator, after doing a Wolverine, after doing an IVL, if I'm still not able to expand an important artery, then one can think of an excimer laser only if there is concentric calcium. If there is eccentric calcium with a normal segment on one side, contrast lasing in a proximal artery, I would be a little careful because of the risk of perforation of the soft area. That's my only issue. And you have to be focused in that area.
Okay, in view of time,
I think we should move forward in the interest of
How many of you have a laser? Can you raise your hands? So I think this is about 2 or 3%.
Yeah.
And what about those 97% people? I think all of you have a shockwave with you. System shockwave available. And well, a good news for all of you. Shockwave is coming with Javelin. This Javelin is without a balloon. This is just a catheter. Only the tip of the catheter will deliver the energy. And many of those cases which are uncrossable by rota, uncrossable or for which you have to resort to laser, Javelin is going to be a very simple answer for it. The cost of Javelin is also going to be less. So I think all of us stay tuned. Shockwave is coming with Javelin, and Javelin is already being used for peripheral. They're announcing it for the coronary. And I think as far as uncrossability is concerned, once you have a ELCA laser with you, then your threshold goes down to use it. And many of those cases which you showed, I think putting an anchor into the side branch, I think that is what Dr. Goyal was hinting at. Many of the cases.
I think we need to.
I mean, I understand the various things that you can.
So I think in the interest of time, we should discuss all these things. Thank you.
Thank you.
We go ahead with the next presentation, coronary perforations rupture management, Dr. Keshav Marty.
So while he's being set up, so somebody asked a question about ALCA is being superior. So what Dr. Keith Iponomia showed is cases that have been very successful, but still the body of evidence is not there to say it is superior. So I just don't want people to misunderstand that ALCA is a great tool. Yeah.
Actually, the thing is, in CTOs, when you do it, really uncrossable is about 3 to 5%,
Yeah,
not more than that.
2-3%.
Dr. Keshamurthy.
Good afternoon. I must thank Dr. Srinivas Kumar sir for giving me the opportunity. I'll be talking about coronary perforation, an innovative technique which can be used by very easily. Actually, in India, in February 14th, 2017, it's an unforgettable date. 10 prices are capped.
But this is 2017.
2017, yeah. Stent prices were capped, has changed practice in India. And 4 days later, 4 or 5 days later, during a high pressure dilatation, post dilatation, type 3 coronary perforation occurred in my case. We used to keep Graftmaster, but Graftmaster was 70,000. The stent prices were capped at 30,000. So they don't know how to bill it. So they have taken it to the office and they told me it's not available. They have taken, company has taken, and I was searching and it's not available. So we made a low profile handmade covered stent and using two regular stents and managed the situation successfully. This was presented in that time in many NIC, India Live and all that. But recently it got a prize, so thought we'll once again present for younger generation. This was a case and RCA. There was no calcium. At the time we had OCT, but we didn't use it because angiographically there was no calcium. And just post dilatation, there is a perforation. So we made a sandwich stent. This case, let us say, this case has got a 3 mm vessel, and you need a 3 into 15 covered stent, which is not available. Then you take a 3 into 18 and a 3 into 15 routine DES, regulating stent, whichever company you want, whichever make you want. And you inflate a smaller stent to 14 atmospheres, slightly higher pressure outside. Okay. At this pressure, what happens is the stent balloon sticks to the inner surface of the stent firmly because the polymer is there. So the stent balloon sticks to the inner surface of the stent. And you cut the edges of the inflated stent circularly, like that. So once you cut, the stent and the sticking balloon cover, you remove it from the tube, the balloon tube as a unit, and then insert it over the longer stent. Just put it over the longer stent and then hand crimp it. So it takes only 2 minutes to do that. Just inflate, cut, and take it and then put it and pour over the other stent. The resultant sandwich stent will have an uninflated longer stent. The inner stent is a longer one, over which there's a crimped 3 into 15 smaller stent holding its balloon. So the balloon is in between. So you have a covered stent now. So this is a picture. Now there is a perforation. So we just put the same balloon and occlude the proximal part, and we start making the covered sandwich stent. We inflate a smaller stent, high pressure, then you cut the both edges, then you take it out. Just put the other longer stent inside and hand crimp it. So your sandwich stent, covered stent is ready. Take out, you can put another wire and do it, or with the same wire if you have done it. Just cover it, put it, and then inflate it. So it is like positioning any other stent. Instead of one stent, you are putting two stents together. And this perforation is sealed. So comparison is covered stents, routine covered stents are bulky, and some of the newer stents with a single layer is costly. And we have only few sizes and length, but here you can't keep everything. It's available, but you can't keep everything. There's availability issues, and these are all bare metal stents. Our stent is a drug-eluting stent, so restenosis rate will be very less. Even though we don't have RCT or something. So yeah, these are the available covered stents. So most of them are the material. The last one is our stent. Okay, we are just comparing. The material is slightly different, and now the newer stent, Papyrus, is a single layer stent. The other two stents are sandwich stents only, Graftmaster and Direct, and Graftmaster. And all the stents are bare metal. Ours is drug-eluting. Almost crimp profile will be almost same. See, normal uncrimped stent designs is 1.10, over which just one cover and a metal, it will add only 0.26. So it's something like it will be much better than a Graftmaster. So these can be delivered through we are used to deliver all that, and 12 atmospheres, not at high pressure. 12 atmosphere, you can go high pressure also. And most important thing is the length you can choose, the size you can choose. You may have, your lab may have a 3 mm covered stent, your vessel would have been 4 mm perforation. So 4 mm vessel might have perforated. So you may not be able to use it. You stretch it, it will not work. So all these problems are solved. So this is what this case was just after 7-8 years. I sent it to TCT last year, and out of 972 cases, they were the judges, including Dr. Antonio Colombo, and it was only Asian entry finals, and we got the runners up. You can see the medal. Because of this, because there's been awarded all this, so I just thought I'd rekindle the idea, and I will present it. Thank you for the patience.
Thank you, Dr. Keshav. I think in the interest of time, we will move to the...
Yeah, but I think this was a very nice presentation, I would say. That's good technique.
Thanks.
So may I now request Dr. Ramesh? He'll be talking about what are the nuances of using impeller.
Thank you very much, ladies.
Especially vascular complications.
Can I have... Can you bring up my presentation? Can you bring up my presentation? So Dr. Keshamurthy is always very amazing. He gets a lot of excellent ideas, and which are probably just nobody has thought about them yet. So about large bore vascular complications, and I know it actually says impeller guided complications, but I'll be covering actually all large bore. So it is 2026. Are we doing better? Yes. I mean, obviously, significant improvements have been made in the reducing the complication rates, the patient vessel selection based on CT, ultrasound, operator experience, refined techniques. The closure devices have improved a lot. and we have learned how to use the closure devices properly, and downsizing of the sheath or the profile of the sheath is going on. So this is a large bore access. We started in 2009 doing TAVRs. In early days, the complication rates of 15%, and currently it is still about 9.3%, even though we think that the sheath size has come down to 14 French, which is the same size for impeller sheaths, 14 French. The current generation impeller sheaths are 14 French. The newer ones will be probably 9 French, and they're still under investigational experience in clinical trials at the US. So this is the iliac on stick. You do not want to see this. I mean, I have seen only once, and because those were 24 French sheath, the TAVR sheets. So just imagine 24 French sheets means when it is really outside is probably about 26 French. And what you think now that whether it is 14 French is not truly 14 French. It's an inner diameter that you're talking about. The outer diameter is equivalent to 16. And with the E sheath, both for whether it is Edwards or a Merrill, when they expand to 22 and 24 French. The vessel is being stretched to that size, especially when the valve goes through it. Okay, so please do not fool yourself that it is 14 French E sheath and it is smaller. So you have to understand very clearly. So this is a 49-year-old smoker, and that's why I'm standing here to see if I can fast forward it a little bit. Patient had a left main occlusion in an outlying hospital. One of our hospitals stented the left main, and diagonal and that also was stented. And so patient is in cardiogenic shock, and I don't know why it froze, but anyway, the vessel size is a very small vessel size. And what do you do here is a question. So you can't put an impeller because the sheath, 6 French sheath, did not have any flow to the distal vessels, both on the right and left femoral arteries. And what do you do in such patients is actually you can't put an impeller. You have to think about what you can do with the cardiac surgeons. And we did both an Ekpella in this patient with the central axis, and hopefully it will stop at a point where I can show that the vessel size for you to understand. But anyway, the Ekpella was placed centrally, and then this patient survived, went on to get LVAD, and made it easily. Okay, so it flew. So this is a diagram of the Ekpella that was placed. So majority of these patients who are 90-year-old Chinese patient who comes in with a end STEMI and went into nearly impending cardiogenic shock had to be treated with for left main bifurcation with a impeller 14 French sheath, and so we had to do a per close and had a complication of vascular closure rather than anything else. So what are the clinical trials in acute MI cardiogenic shock? Is a danger shock is the most important one, and the third, that early revascularization is better, culprit only PCI is better, and danger shock showed that mechanical circulatory support is actually beneficial, and the 6-month mortality is lower in these patients with mechanical circulatory support. But what is the drawback? Moderate to severe bleeding is 28% versus 13%, and peripheral ischemic complication 9.7% versus 2.3%. So yes, we did save lives, but it comes at a cost of bleeding. Protect 4 trial also is looking at impeller versus the control, whether balloon pump or no mechanical circulatory support, and this has been published. I mean, this is completed enrollment, and we'll wait for the results probably in a year. And even when we enrolled patients, we did encounter some complications of bleeding with the impeller as well. How to prevent these complications? I think step 1, locate. Don't forget your history. Palpate the iliac inguinal ligament, and look at the pubic symphysis and iliac crest ramus, and then palpate the inguinal ligament. Go about an inch below. Feel for the femoral artery, and then that's where you can put the ultrasound probe and looking at it more closely. So when you look at the ultrasound, you can see that the artery and vein are right next to each other. If you have to sometimes change it if you are not convinced. And compressible one is obviously the vein, and the artery is non-compressible, so you can think about that way. And there's also probably more plaque in the artery as well. and then look at longitudinal axis, and that way you can see the bifurcation. And so that's where you want to go in the common femoral artery above the bifurcation. So then under ultrasound guidance, give lidocaine. You can actually see the separation of subcutaneous tissue and everything in that. So 2% lidocaine is administered with ultrasound, and then use a micropuncture in a nice 40 to 60 degree trajectory and enter the femoral artery under ultrasound. So just don't use ultrasound and poke somewhere with a micropuncture needle. You need to visualize that you're entering from the skin all the way down to the artery, and you should say that I'm entering at 12 o'clock if you think that artery is a circle in short axis, and you should look at that and enter in this way as actually at 12 o'clock or 11 o'clock or 10 o'clock, and depending on. But don't try to see here we adjust and making sure that we are at 12 o'clock and or really slightly like 12:30 or 1 o'clock. And once you get pulsatile flow, you can actually go ahead and advance the micropuncture wire under fluoroscopic guidance. So you look at here, anterior stick, and making sure there's plaque free. And when the wire is advanced, sometimes complications happen because the wire goes into an inferior epigastric artery and you put a sheath into that, and that actually can cause complications as well. So make sure the trajectory of the wire is actually following what you would think should be the iliac artery and distal aorta. So please make sure that you look under fluoro and document that. And so then I think ipsilateral angiography has to be with a 5 French or micropuncture 4 French sheath. You perform the ipsilateral angiography and making sure your stick is above the bifurcation in the common femoral artery. Only then you can exchange it for either long wire, J wire, or a sheath J wire. And then now you're talking about pre-close using the ProStyle, the new generation ProGlide is called ProStyle, and you have to look at that and making sure that whether you want 1 or 2 ProGlides. I now stopped actually using 2 ProStyles anymore because it causes a vascular occlusion partially. So even if it is 18 French, I'm sticking to 1, and manual pressure is also good enough after that. So then under fluoroscopy, upsize the sheath after ProStyle is administered, take a larger wire and through the ProStyle and advance your 14 French sheath under fluoroscopic guidance. If your sheath, artery to sheath size has to be 1 and above. If the artery is smaller, and meaning if you put a 6 French sheath, you inject, it has to be two times the size of the 6 French sheath. If not, don't use any large bore access in those patients. So here is a patient with angina, and I'll show you quickly. The story is not coronaries here, but the peripheral angiogram looked actually, everything is very small and diseased. And whether looking at all the ones that you can see, even subclavian was not actually very good as well. Even though it appears there's a lima, so we don't want to touch that. And suture deployment of the ProGlides is actually you should practice, learn on normal 6 French sheets first. Don't go and say that I'm going to learn applying ProStyle. I know it is expensive, but you have to train in 6 or 8 French sheets before you do on a 14 French sheet. If it fails, you're really stuck. So here's a 8 French going through the right CFA after that. And then we took a picture, and then from the left side, we're trying to advance the 12 French dilator. It wouldn't go. And so it's sequentially dilated, and it still wouldn't go. So then used a PTA balloon and then a 14 French dilator, and then attempted to advance the 14 French sheath. Even then, it wouldn't go. So we used a shock wave after that, and we were able to deploy the impella after that. So, so impella went in, and the PCI was done. And the story is not over until you're coming out. So when you come out, then you can see this completed like extravasation and of the artery. So what you do is perforation before you take the large bore. Either go up and over, or you pull the sheath back until where you think there's maybe an injury. You can inject through the sheath or take a pigtail from the other side and make sure there's no injury. If there is an injury, immediately advance the 14 French sheath, which has been in place. So over a dilator, you can advance it so that it won't stop bleeding. Then you can think about getting a Viabahn stent. So prevention of vascular complication, how to do it: contralateral crossover with a 0.035 wire and a prolonged balloon inflation, 1-to-1 inflation, and meanwhile search for the covered stents, because as Dr. Keshamurthy said, you might have to prepare your own covered stent for the patient if you're not available, and avoid any distal bifurcation. Do not put the covered stent across the bifurcation, because profunda is a left equivalent to a left main of the thigh. So then you can create problems. So otherwise, call the surgeon. Always be friends with your surgeon. You never know when we need them. So the final angiogram with over-the-wire PTA balloon gives good images, and if there is no oozing, then you might have to say that it's okay to stop. But if the patient is going to be on dual antiplatelet therapy, there's still a risk of bleeding. So be careful. The bleeding can start much later. So incomplete sealing with the vascular closure devices, and extravasation at the puncture site is treated with low pressure balloon inflation. I usually, if it is a 6 millimeter vessel, I go like a 7 millimeter balloon, because I try to stretch it a little bit and occlude it better. Because we are going low pressure, so you're not going to nominal or raised burst pressures. So if all of this fail, an ultimate temporary bailout is having a Coda balloon. And in case if the bleeding continues, you might have to put a Coda balloon and call the surgeon, and a 12 French sheath for 32 millimeters and a 14 French sheath for 46 millimeters based on the distal aorta. But you have to have a CT scan to know what would be the size. If not, actually go for 14 French sheath and slowly increase the balloon size, and making sure there's no flow in the artery on either side, and meaning the pulse is completely absent on the non-injury side. And so you have to occlude the entire aorta. So in conclusion, I think ultrasound access is now widely available. It is easy to learn. And I don't think there's an excuse to say that you should not be using ultrasound, in my opinion. And there's no downside to the use of ultrasound image, and use micropuncture as well. And don't use ultrasound on an 18 gauge needle. People do that, and I don't think that's right. So definitely ultrasound reduces a number of attempts, risk of venipuncture, or when you're trying for the vein, some people actually put 18 French stick. They stick the artery with 18 French needles, and all that can be avoided. And time to sheath insertion is faster, and it facilitates anterior stick and avoidance of calcium. Therefore, it facilitates closure. It prevents vascular complication. The easiest way to prevent to avoid a complication is to prevent them. So get all the techniques that you want to learn to making sure there's no complication in the first place. Thank you.
So, thank you, Dr. Ramesh. I think excellent discussion. And for some of those who do not have an ultrasound in the cath lab, which I think, how many of you have ultrasound available in the cath lab at the site of puncture? So we have about 15-20% people. So rest who do not have, I think simple trick is like you are going with a large bore from the right, go for a smaller bore from the left, go up and over with a pigtail. You bring the pigtail against the femoral head, shoot it, and that will tell you where is the bifurcation. Keep it just above the bifurcation, and then you center or target the center of the pigtail, which gives you both anterior puncture, which is 12 o'clock, and it also stretches the vessel, which helps you in puncturing it. But I think it is better to have ultrasound on.
So one complication happened that somebody put a pigtail and put in a ProGlide and sutured the pigtail to the artery, and so that patient went to surgery because the pigtail now is stuck. So how many people have echo machines? That's it. Not 100%. None of you have echo. All of you have echo machines. If you have an echo machine, there's no excuse that you don't have an ultrasound.
Echo machine in cath lab.
Yeah.
See, echo machine everybody has.
Yeah.
But how many of you have it in cath lab?
Wow.
So quite a good number of them. So if you have it, all what is required, same probe can be used. But if you have a linear probe with higher frequency, you always see it better.
I think the same echo machine can be used. There is no problem. You can roll it over into the cath.
Yeah, same machine. The probe is different. If you use a different probe.
Well, if you don't have that linear probe, still you will see.
Yeah, you can see with that, but the linear probe shows you better.
The only thing about that pigtail is I don't know whether you. I have had that complication.
So that is only at the time of puncture.
But that was in the initial days, catching the pigtail with the ProGlide needle. So that is very important. So you have the thing for the puncture, but make sure that you pull
So
back.
immediately after the
pigtail.
puncture, you pull it. Like some other
Pull it
people will
back.
try to
That is
pull
very
a
important.
pigtail
That's very
at the
important.
time of TIVI deployment.
Right.
So if the sinuses are less, so at the time of TIVI deployment, you just pull it.
Yeah.
Same thing is
And
done.
one more point I just wanted to say, it's very important. It's best when you do the ProGlide, would you do it on a 6 French hole or a 8 French hole or a 10 French hole?
So I actually go to, for ProGlide not to get caught in the subcutaneous tissue, you have to create a tract. So I use a 6 French sheet. You can initially put it in, but a 8 French, I'd like to at least use an 8 French to create a tract, or actually use a hemostat or a mosquito to create a tract in the subcutaneous tissue separately.
Actually, the ProGlide is meant for pre-close. So if it is best in a 6 French hole, marginal on a 7 French hole, 8 French hole is the maximum that you can pre-close it. And if it is 9 French, you cannot catch because the needle has its own width.
The angles will miss
You
it.
cannot catch the two sides of that hole. So if you catch it on a smaller hole, you will have more tissue between the needle prick and the hole edge. And then you catch it better. You don't tear the hole. So that's just a point. So do it with a 6 French hole and then move forward, whatever you're going to do. Okay, I think we should move to the next presentation.
And to be overcritic, Ramesh,
Sorry.
It is not pubis symphysis. You feel pubis.
Yeah.
Good afternoon, everyone. So after seeing so many interesting cases, my talk would be more little, what are the management options which are available to us? So more about your data, what it tells us, and what all we can do in the cath lab. So let us see this case. 2 cases of infavolami, same anatomy, proximal total 100% occlusion. Put a stent, first case having a TIMI3 flow, we get to go TMP. And the second case having a slow flow, TIMI2 flow with a no TMP grade 0. So these 2 cases, how to manage and what different it was done, let us see. So we all know what is the definition of slow flow, no free flow. That means the artery epicardial is okay, but despite that, you are not able to see the distal flow. And this is usually seen in cases with ACS setting, SVG, PCI, and post-rotablation. Always, whenever you find the no reflow phenomena, rule out certain things because it is not always your microvascular obstruction. Rule out whether there is any distal edge dissection, guide-related dissection, wire-related dissection, or a vasospasm, air embolism, or wire pseudolesion, or it may be a thrombus. So before labeling as a no reflow or slow flow, always rule out these 2 things. We all know that primary PCI, how to diagnose these will be more of a coronary angiogram. We know TIMIC flow count, frame count, myocardial blush, and IMR, which can be assess the microvascular obstruction. And a non-invasive thing is a cardiac MRI, which can be done. Predisposing factors could be your patient-specific. Most important is the delayed presentation in our Indian setup when we find them after 12 hours of post-MI and having a high thrombus burden, having a decreased distal flow. Second is the ectatic artery, hyperglycemia, hyperlipidemia, female sex, hypertension, renal insufficiency. Lesion-specific are more if it is a high lipidic plaque or it is a highway thrombus. And treatment strategies are more of a pre-dilatation, post-dilatation, SVG, PCI. So let us come over the treatment strategies. How will you do it? Either it could be a pharmacological, interventional, or technical. So let us come first with the pharmacological. This is a table, I think everyone have read that there are different vasodilators intracoronary, there are different fibrinolytic agents or GP2B3, which has been shown that, which has been used by us in all the cath labs. But do we have any data in these cases? So we have all used intracoronary vasodilators and we say that basically is micro circulation vasodilatation. But if we see the data, these are the mostly small studies which has been done on the studies which never showed that there will be reduction in clinical outcome benefit. And the most important challenge is when they present with hypotension, then using these nitroprusside in the lab, it becomes a little challenging, or a nicardipine in these cases. So is there any other option? Nicorandil, which has been recently been evaluated in many studies, and this was a very good RCT which was present and meta-analysis and systematic review, which showed that when nicorandil being not just a vasodilator, but have an additional coronary microvascular obstruction opening, and they found when they found intracoronary plus intravenous, they have the maximum benefit in these cases. So using in the nicorandil, it significantly reduces the no reflow phenomena and MACE at the end of your 3 years, in the sense by improving the heart failure and ventricular arrhythmias, and when we use both, combination has the maximum effect. What about the patients who are presented in your shock? That is the most important when we see these patients. So epinephrine really helps us in these cases. This was a study which was, if you see that Restore observational study, only 30 patients, and they found a significant improvement in the no reflow phenomena. And if we see the core study, it also showed the randomized control trial when they compare with adenosine. Epinephrine had an upper hand. So we usually get scared that there can be a VT in these, we use epinephrine. So always, like in our cath lab, what we do is like always be ready with your DFib at the bedside. Start with a lower dose of epinephrine of 10 mics and then increase it depending on the patient's condition. So this was a study which was published in 2022. So they concluded that the patients with epinephrine, they have a better flow rate as compared to your adenosine. How to administer these vasodilators? It is always a confusion whether to get through the guide catheter or whether to go to the intracoronary, distal to the bed. So there have been studies which has been evaluated both, no head-to-head trial, but what we in general practice is better to always give intracoronary distal to the bed, because that will be help you, because in a no reflow phenomena you will be able to deliver the drug. So what are the different things which we can use to distal to the bed? A microcatheter can be tried, but the biggest challenge is that you have to take out the wire when you have to inject. Thrombus aspiration catheters can be done, but then it has to be little difficult to cross sometimes. In lab, we can do a balloon punctured balloon, like a normal balloon which we have. We can make a slits in that, and we can put give the vasodilator through this, or a OTW balloon, which is not very easily available in our setup. So if you see, this was the no reflow in a patient with an acute MI, did an aspiration and delivered the drug through the aspiration catheter. And this was the flow which was achieved. So it depends on the patient. You have to give different drugs and different vasodilators depending on the patient clinical status. What about the GP2B3A? Does the data suggest that we have to go routinely GP2B3A inhibitors? ACC guidelines say no, not as upfront, but as a large thrombus burden, which we can be given in these cases. And this was a study which was published recently in 24. They gave intracoronary GP2B3 inhibitors, but they found that at CMR, it didn't change the infarct size. The only thing it changed was microvascular obstruction, but there was increased bleeding. So routine in large thrombus burden, GP2B3A, we have to be rethink about it, because in the newer P2Y12 inhibitor of prasugrel and ticagrelor, should we really use it? We really don't have data at present. Intracoronary fibrinolytic, very small studies which have been done, maybe 50 to 100 patients, and they all showed that there is increased bleeding, and this was a systematic review which also showed that these patients in large thrombus burden you can give, but they increase bleeding. What are the interventional strategies which can be done in the cases if the patient is no reflow? The data which is not there, distal protection device, not supportive, not to be done, only considered in SVG PCI. ELCA, the only hypothesis is thrombus vaporization, but there is no RCTs with support, and the cost and availability issue as I recently discussed. Specific stents, I think during our residency, we remember you used to M-guard stents to prevent the no reflow, but it didn't show any benefit, but may harm also. And maybe sometimes supersaturated oxygen may be used. What about a thrombectomy? Should we use thrombectomy in irregular cases? We all know that it is a class 3 recommendation, no clear cut. So it's always to be done in a large thrombus burden. So how to define the large thrombus burden is whenever there is a grade 5 thrombus, and after putting the wire, if you are able to see the thrombus, which is more than twice of the vessel, it is defined as a large thrombus burden. Different thromboaspiration catheters have been used in our labs, we all know. And recently, the mechanical thrombectomy in the form of a penumbra has been tried in a setup. So this was a Cheetah study which showed, and this was a study which was done from India by Tanuj Bhatia in the center. And it was about 101 patients which was done, and they found that when we use Upfront in these cases with a grade 4 or grade 5 thrombus, there was definitely a increased TIMI flow and thrombus grade and MPG in the final result. So just to show a case example, a 45-year-old male, hyperacute, window period 2 hours, post-wiring, you can see there is flow which is having a large thrombus. Did a penumbra, thromboaspiration, post-thrombectomy, there is better visualization of the lesion and a TIMI2 flow is achieved. Put a stent and post-stent, we can clearly see it's a TIMI3 flow with a TMP grade of 3. So in a large thrombus burden, definitely if we can have a manual thrombectomy in these cases will be your pump related would be good. What about the stenting? Should we go for a direct stenting in these cases? It was always said a minimalistic approach should be done. Hypothesis like when you put a direct stent without prior balloon dilatation, it will decrease the distal embolization in the microvasculature. But is there any evidence to support this? This was a study which was published, which showed the systematic review of meta-analysis. And if you see the funny thing in this, there was about 12 studies they evaluated, 3 RCTs, rest of them all non-randomized trial. And when they evaluated, if you see the short-term mortality, in randomized trial, it didn't show any benefit of direct stenting, but in a non-randomized study, it showed a benefit of direct stenting in both the short-term and the long-term MACE events. So it was basically the selection bias in non-randomized. That means you will not put a direct stent in which you find a high likelihood of success. That means a non-calcified or non-critical lesion. Whereas in complex calcified lesion, you will reconsider whether to put a direct stenting because it will be a suboptimal results. So conclusion is basically not to put in when you think that you're not able to deploy the stent. Like suppose in this case, 45-year-old male, window period of 8 hours, proximal LAD 100%, did a thromboaspiration, flow restored, put a direct stent of 3.5 into 18 and TIMI3 flow, which was achieved with a TMP grade of 3. So this is the ideal case for going for direct stenting. But the same if you see this case, he's a 78-year-old gentleman having a proximal total occlusion, heavy calcium in the LAD, and plan is to put a wire and see whether it's a balloon crossable or not. Crossed with Sion wire, thrombosuction tried, semi-compliant balloon didn't respond. So there are options to do a high pressure NC, always the risk of embolization, or a cutting balloon and IVL. There are various case reports and case series which has been shown that the cutting balloon or IVL in these setups can be helpful because at a low pressure you are going to inflate. So this was done. A Wolverine into 3 into 10 at a high thrombus, we had the calcified lesion, got a little response, deployed a stent of 3.522 at only 10 atmosphere, didn't do any post dilatation, and this was the TIMI2 flow which was achieved. Then gave an intracoronary vasodilators, intracoronary epinephrine also, and this was a TIMI3 flow and TMP grade 2. So it does not always differ direct stenting. It is always the patient modified how to go ahead with this. What about the deferred stenting? Always some people say we should go for a deferred stenting in these cases. Many trial, defer STEMI, Dynami 3 defer, they all have been evaluated, but if we see the meta-analysis say the routine defer stenting should not be done in these cases because it didn't show any clinical benefit. Some studies show that maybe outcome in no reflow or slow flow. So when will you plan for a deferred stent? This is a 60-year-old female, inferior volumi, if we see, RCA is proximal 100%, did repeated thromboaspiration, gave intracoronary vasodilators, achieved distal flow, but the thrombus is persistent. So despite this, we're not able to clear the thrombus and the flow was not able to get a good achieved flow. So we deferred the stenting, took after 48 hours, put a stent, and this is a TMP grade 3 and TIMI3 flow which was achieved. So we have to categorize all these patients for going for whether to go for a deferred stenting or not. Third and most important is to prevent the patient with no reflow because the prevention is the most important. The don'ts in which I have been doing in cases primary PCI, avoid high pressure balloon dilatation, stent deployment, I have the full coverage, Stenting, imaging guiding, I think the guidelines also recommend, but if we see in a clinical scenario, how many of us are able to do the imaging in patients who are quite sick? So if you are able to do the imaging in a stable patient, it is always preferable because you can size the vessel. Maintain the adequate ACT. If there is hemodynamic instability, always go for IABP impella and direct stenting only in subset of the patient. If you feel that the stent is not expanded properly, always bring it back after 48 hours to see imaging guided PCI to be done in these cases. There are several future trials which are being evaluated, either in the form of impella or supersaturated oxygen. There is trial on dexmedetomidine, nicorandil, but still they are all ongoing randomized trials, so we really don't have a clear data. So the take-home message for preventing the no reflow, slow flow, it's a precision medicine approach which should be there. No treatment strategy can be considered as a overall thing which can be used in all the patient. It depends on the patient characteristics, and prevention is the most important strategies and identify these cases early, and intracoronary vasodilator therapy to be given in these cases. Vasodilator, try to have these vasodilator in your lab, which should be there. If it's in hypotension, nicorandil and epinephrine is a good option which can be given in these cases. And avoid high pressure stent deployment in these cases and thromboaspiration in selected cases. The best treatment for slow flow is to prevent it from happening rather than having a no reflow phenomena and regretting it later. Thank you.
Yeah, good presentation. I just had one question. For an under expanded stent, I am not very sure if we should defer actions. If the stent is under expanded, I think you should work on it right then, even in an acute MI setting. Maybe there is calcium or whatever is there.
Sir, under expanded means like because during MI, you usually undersize because the coronary arteries are not very clearly dilated. So my under expansion was not that you're not able to open it up. The basic was like you're undersized the stent. So it's always better after 48 hours when you have a good flow. You can do it imaging guided in these cases rather than undersizing.
You don't undersize the stent.
Yeah.
It's a 3.5 to 4 millimeter artery. You don't put a undersized stent. You do not do full or over dilatation. You use a stent which can
1:1.
Yeah,
size has to be optimum.
Yes.
Your dilatation may not be adequate in the beginning. The moot point is the longest the stent, highest the pressures, bigger the balloon, and if the wicket on which you are betting is like vein graft, acute MI, ectatic vessel, some thrombus. The moot point is this is a situation where you're likely to get into trouble. Nowadays, you can have imaging of the vessel wall and find out that this is high lipidic core vessel, which is more likely to get into it. So maybe all these precautions should be observed, in especially those cases where the likelihood of getting into trouble are high. Treatment is very little, according to me. Prevention is probably the most important.
Yes, sir.
And I think if you just gave busy slides and you didn't talk strongly about epinephrine, talk strongly about epinephrine, because epinephrine probably is one of the simplest, easily available drug, which is the biggest and the most strong vasodilator, which is not only vasodilator, it takes care of bradycardia, which is induced by your delta jam, and so it also takes care of hypertension, which is induced by nitroglycerin. And if you want to introduce through a balloon, very simple trick is just give puncture at the distal end of the balloon. Puncture with the smallest possible needle near the distal end of the balloon, which is tapering. Now, if you puncture it there, if you inject the dye, what will happen is there is almost no regurg. No regurg. See, otherwise, these patients who have a slow flow, their microvascular resistance is very high. Taking a microcatheter deep down, taking a thrombosuction catheter deep down, if you inject something, if you inject dye, what you find is the dye comes back. But if you have a balloon inflated, have tips with a micropuncture there, and then you inflate, the contrast is forced out of the circulation. That probably is one of the best ways. And I think you gave a very good message. Overall, it is a difficult topic. Thank you very much, Dr. Rupali.
I agree, sir. In the past 5-8 years, we have shifted to epinephrine. We have like adrenaline, like what you said, adrenaline, like for past 5 to 8 years in a lab, we have shifted to epinephrine. I think it's a very good drug, which we usually fear that, okay, might cause VT. But I think in our experience of 8 years, only one case we have seen VT, but it's a very good drug, I think.
That VT, you cannot be sure it's because of epinephrine or because of ischemic substrate. So, by the time Dr. Goyal is busy in finding out who is the next speaker, there are no speakers after this. This is only a discussion amongst all of us, including the trying to have the audience from us. So this session is supposed to last 15 minutes, and we are supposed to have a volley of questions from all of you. Where do you feel comfortable or uncomfortable in dealing with complications?
I think there are some questions there.
But sometimes it is very difficult because we are neglecting genetic part also. It's are predisposed to slow flow because of high platelet, which we take the patient in care.
So that is why we say it is more unpredictable than predictable.
Just because it is hemodynamic platelet reactivity, we are totally caught unaware. How much we try to anticipate, sometimes we are trapped, and then treatment is long list.
So thank you very much. Yes, please.
Now there is a question there. I think some questions are already there on the screen. Is there any objective criteria for deferred stenting? Rupali.
Dr. Rupali? Is there any objective criterion for a deferred stenting?
Because what happens is, I'll tell you my experience.
How long should we defer?
Well, I somehow do not
you have said it that you are not interested in deferred stenting.
Yeah, because I don't like
well
actually
but anyhow, what is the criteria?
There is no definite criteria. If you see the trials also, they have some trials have taken 6 hours to 12 hours, some has taken 6 to 48 hours. And it depends on the thrombus burden which we are dealing with. I think we are giving a high thrombus burden. We always want that maybe we can wait up to 24 to 48 hours, give GP2B, let its effect could be there. And that otherwise there is no clear-cut definite
criteria. That will also depend on the bill burden in private sector, because if you delay it for 2 or 3 or 4 days, you are adding to the bill.
The other thing is, I'll tell you a logic. Now, deferred stenting means you are doing only balloon angioplasty. And we know the results of balloon angioplasty in good old days when balloon angioplasty was the only thing available. We used to have clear 4 to 8% acute closure. Although now we have better antiplatelet agents, I agree. But I think we should make the bed and try to put optimal size stent.
At the same time, see, deferred stenting is, like you're not inflating a balloon 1:1. See, at the time of acute MI, the main thing is getting the flow. And getting the flow, not only TIMI3 flow, you have to get beyond TIMI3 flow. You have to talk about TIMI frame count. You have to talk about the TMPG grades. Sure. And if your TIMI frame count is fine, you should be able to address even the TMPG grade. And if you're not able to address the TMPG grade, that means it is equivalent to slow flow. So by doing a deferred stenting, what the concept is that you try to get a TIMI3 flow, get a good frame count, and apparently a good TMPG grade. Now, in these cases, by the token which Dr. Goyal is saying, if you try to achieve the maximum or optimum, you go by IVUS, and IVUS tells you it's a 3.5 vessel. You have already achieved a 2.25 or 2.5 lumen, and the flow is excellent. So, in an endeavor to get a good size stent and a good diameter of the cross section of the stent achieved, you get a reproduction of the same syndrome with which the patient was brought onto the cath lab. Patient was brought with chest pain, with ST elevation, sweating, ghabrate, and shortness of breath. And all those things went off the moment you passed the wire and inflated a 1.5 or 2 millimeter balloon. Now things are very good. There is no dissection. If there is no dissection, TIMI3 flow, this is a time when you can think of deferred stenting. If you try to do and give a best result, then some of these patients will on the table will start having a chest discomfort, ST will go up, flow will go down. And in fact, if you look at their CKMB kinetics, you will find a high and an early bump of enzyme. So I think though we have not kind of studied in a systematic way, but I think both the points, Dr. Goyal has a point that you can end up in about 5 to 10% patient who will occlude. But those cases where TIMI flow is TIMI3 and you have not done a full dilatation, there probably it is not 5-10%, maybe less.
Actually, just talking on that, there is a difference between balloon size and balloon pressure.
Yeah.
People think that I give bigger pressure, I get a better stent, this thing. It's not so. If you use a bigger size with a lower pressure, your negatives are down and you still implant the stent well. So
this hypothesis is absolutely correct in acute MI. where the size of the stent may be big, but the pressure may not be big, so that you are just able to deliver a stent there, have adequate lumen, which gives you TIMI3 flow. And then this patient can, if your condition permit, that can be brought back again, maybe after 24 or 48 hours, do an imaging and try to optimize the result.
See,
Dr. Bansal, please.
In addition to the TIMI3 flow that you talked about, the most important criteria used in most of these trials was a thrombus, which was more than 2 times the size of the vessel.
Yeah, double the size
So
of the
thrombus has
diameter.
to be present. If you have a thrombus present with a TIMI3 flow, do not, if even one of these is not there, don't defer.
Be chemically strong. Don't be mechanically strong there. Yeah.
Yeah.
So please.
So in case we do defer stenting, then what might be the best antithrombotic strategy there? Do we have a consensus one? If we don't, then maybe varied opinions, please. Is it GP inhibitor plus dual
See,
antiplatelets?
I take your question, but I don't think any study has shown deferred stenting to be better than whatever you handle.
Very well.
So I would not like to give you a message that this is how that do defer stenting. As far as possible, use your tactics of angioplasty and stenting and try to finish the case. Well, there are situations where you cannot put a stent. There's a lot of thrombus, and you may
Precisely
defer it. So that's the only thing I would
Is
say.
it a GP inhibitor plus DAPT or ticagrelor
No, you
plus
should give
Clexane?
both probably. DAPT has to be given otherwise. You should add a
Is it
GP2B blocker.
inhibitor
I would
or low molecular weight heparin or a heparin infusion?
I don't think we are using low molecular weight heparin these days. You give a dual antiplate plus GP2B blocker. Well, if it is a graft issue, sometimes grafts work well on heparin. So if it is a graft issue or something, or it's a very ectatic vessel, maybe heparin in a individual case may work better.
Can we work the same with ticagrelor, or do we have to de-escalate to clopidogrel if we are giving a triple antithrombotic? Acute.
3 agents, I don't think. Okay, I don't think we have. I would advocate 3. Ticagrelor itself is strong enough. Ticagrelor and aspirin is good enough. I don't think you need clopidogrel on top of it.
It looks there are no questions, so we can end the session and
Yeah.
thank everybody and the presenters. So thank you very much. We can now leave the podium for the next presenters and the chairpersons.
So we are moving to the next session, and there are 5 cases to be presented. 6, yes. So the first case is STEMI with delayed presentation management. Dr. Sandeep Bansal.
Good afternoon. At the outset, I'd like to thank Dr. Srinivas Kumar for having me here. This is not a very complex presentation. It's a simple presentation. I'd be talking because of certain nuances in this case. And also, I'd like to bat for a very popular way of testing viability, and that is the FDG PET. So, as I said, delayed Indian social nuances, delayed acute MI, and whether to test viability or not, because viability has been kicked a lot in the recent times, and in every conference, you have people kicking at the importance of viability. This is a story a couple of years ago, maybe about 6 years ago, actually. A 43-year-old male, diabetic for 5 years on oral hypoglycemic, smoker, normotensive, presented with chest pain. This story is from this part of the country, and I treated this patient in Delhi. So he had an episode of chest pain and sweating on an early morning at between the border of Andhra Pradesh and Chhattisgarh. This man drove 13 hours actually to Vishakhapatnam because the doctor he believed in was in Vishakhapatnam. This Google map I took at 5:30 in the morning, and it showed that it is not 360 kilometers and would take 10 hours. It took this patient 13 hours. He drove by himself with the pain on from this place right up to Vishakhapatnam where he was treated. This was the ECG at the time of arrival in Vishakhapatnam. One can see that there are Q waves already there from V1 to V3, and other than that, maybe a bit of tachycardia. This was the ECG next morning. The Q waves are again clearly seen, but note that the R waves are preserved in V4 to V6. Lab investigations done there were essentially normal. And this was the angiography, which was well over 24 hours because he was having pain already for about 10 hours. Then he drove another 13 hours. And then this was the angiography report, which said that there was a total cutoff of the LAD and very, very faint or no filling from the RCA. And there was another lesion which was present in the obtuse marginal. Now, this was the angiography at Vizag that was done at his hospital. And that was a right, which is essentially normal. Now, he was discharged on this very standard treatment. The only thing missing was dapagliflozin, which should have been started. I started it when he presented to me. This patient's niece, she was a PhD student with my wife, and that's how I got this patient about 5 weeks later. And he had stable vitals at that time. There was a third heart sound that was present. The echo showed an ejection fraction of 30%. LV was borderline. LAD territory was severely hypokinetic, but not dyskinetic or scarred, even at about 4.5 weeks or 5 weeks after this. So this is how it is recommended you manage. If there are anginal symptoms, then of course there is, you can just go ahead and do a SPECT. And if there's more than 15% of left ventricle which is at stake, then go ahead and revascularize. If there is more than if there's no angina, then again you do a PET or a CMR, particularly in much later stages, and I'll talk about the timeline for that. So this in this particular patient, when he came to us, this was the ECG. Note that this may be because of lead placement also, but note that the R wave is preserved only in V5 and V6. The Q waves have clearly appeared, and there's a T inversion that is noted. See, late presentation has evolved over a period of time. The 48 hours that Rupali was talking of was a class 2A ESC recommendation very recently, few years ago. When this patient had come, the recommendation was up to 24 hours. So the doctor he believed in was honest in giving him an opinion to get a viability testing done. And he did not open up the vessel just like that. At present time, ICMR is doing a latecomers trial. Many of us are a part of that, in which we are extending the window up to 72 hours. So even if the patient presents up to 72 hours, whether it is worthwhile revascularizing or doing a primary angioplasty or not, we're looking into it. In this patient, we did a PET scan. This was done across the road in All India Institute. And one can see here, the ejection fraction continues to be 23%. The end systolic volume, as one can see, is 100 ml, which is high. and there is a suggestion of viable myocardium. Closer look shows you that of the 152 grams of LV myocardium, about 77 grams is at risk, and 75 grams out of the 77 is actually viable. So a large area was viable. This is how one does an FDG PET. It consists of two scans. One is the perfusion scan, which basically has a radio tracer which goes wherever the blood is going. It doesn't talk of the metabolism. The second is the fluorinated deoxyglucose, which is a radio-labeled fluorine attached to glucose. And the second column that you see is the area where the FDG PET is filling. On the left side, one can see a dark blue area, which is the area of defect where the blood is not going, but you can see that the orange is getting filled up. And the third picture is the area where there is the glucose uptake. The normal heart, from free fatty acids being its major substrate, changes the substrate to FDG or to glucose. And that is the basis for this physiological test, which is very important to study the viability. Now, at Safdarjung, by this time, the lesion had eased out. So the angioplasty is not a very thing that I'm talking about. The lesion had become much simpler. There were two lesions, as I said, one in the OM and one in the LAD. Stented both of them, and that is it. The patient was taken care of. We'd used onyx stents, and the sizes are highlighted here. On follow-up, this patient, as he continued to have LV dysfunction, he was started on the guideline-directed medical therapy. His EF improved over about 6 weeks from 23% to 43%, highlighting that it was a hibernating myocardium, and this improved. He was NYHF1, and he continued to be on follow-up for 4 years, hasn't come for last 2 years. This case actually highlights the utility of viability testing and the time frame in which it is found to be most useful. We need to understand that a stunned myocardium is when the myocardium is dysfunctional, even when the epicardial arteries are opened. Hibernating myocardium is when the myocardium is hypocontractile, but that is because it has changed its substrate from essential fatty acids to glucose, but it continues to be viable, and hence the term hibernating, which is used for frogs, etc. These are the various methods. The viability tests can be done using dobutamine stress echo, SPECT-MPI, FDG PET that I talked about, the cardiac MRI, which is in absolute vogue. People talk a lot about this, particularly in the US. And there are others like CT perfusion, which is emerging. The important point is that FDG PET is the gold standard, and it is the most sensitive way to detect the viable myocardium. Dobutamine stress echocardiography utilizes contractile reserve. If the tissue is living, all the tissue has a contractile reserve, and that is what we detect with dobutamine stress. And MRI actually gives us an indirect indication. If the scar thickness of the myocardium, if the scar is less than 25% thick, it has a higher chance of getting reversible. Another important thing is that a regular scar takes more than 3 months to form. Therefore, MRIs, if you're using it to test viability, should be done ideally after 3 months. This patient had presented early, and that is how we used. And that is it. Thank you very much for your kind attention.
Thank you, Sandeep. What was the ejection fraction and the other dimensions of the left ventricle at the time?
I showed that. The dimensions of the left ventricle were 53 millimeters by 46 millimeters.
Yes.
The volumes were 130 and 100. And the ejection fraction on the FDG PET, that was 23%. On echo, at my place, it was 30%. So that much of variation is
Because
Understandable.
this is always a challenge to understand that in a delayed presentation, whether the area is viable or not. So out of all these tests which you have shown, which you think is the most sensitive to pick up the viability? Because
See, viability is a very funny issue. When you put in a pigtail catheter, if your catheter induces an extrasystole and you have post-extrasystolic accentuation, as I said, all viable myocardium has a contractile reserve. So if there is a post-extrasystolic accentuation, that itself can tell you that this is a viable myocardium. Angina is, of course, the best clinical indicator that this is viable.
Okay. Yes.
So, sir, what happens if somebody revascularizes without doing a SPECT scan? Somebody revascularizes the scar. What happens?
Sorry, say that.
The scar, if scar.
Sir, by definition, see, let us not forget our basics. Scar, we do not define an acute MI tissue as a scar for at least 6 to 8 weeks. That is when a mature scar forms. Okay, till then you can say it is hypokinetic, it is akinetic, it is dyskinetic. That is what we've been taught.
Okay, any questions from the audience or?
Yes, thickness of the left ventricle, if it is, that is what I said. Thickness on echo, thickness is a very good indicator. So if the myocardial thickness is more than 0.5 to 0.6 centimeters, 5 to 6 millimeters or more, then it is probably going to be viable, but you have to do a dobutamine stress again to show the contractile reserve.
Okay, thank you. Thank you, Dr. Sid.
In
We'll call upon the next
acute MI
speaker.
setting, within 3-4 days, is FDG PET better or SPECT better, sir?
None of them is better. You've already crossed the window, so you wait for a certain period of time and then do the tests.
Dr. Gaurav Verma.
Good afternoon, everyone. So moving from, theoretically discussions of viability, I'm going to present a case where the anatomy dictated our strategy rather than the clinical scenario. So the case is about a 60-year-old male who was admitted with acute inferior wall MI, clear ST elevation since 2-3 ABF with T inversion lateral leads. Echo showed a EF of 30% with severely hypokinetic inferior and anterior wall and mild to moderate MR. She had a duration of symptom for around 20 hours, and we thought of that he will be better suited for doing a revasculation in this case. And initially he was unstable, so we have to stabilize him with his inotropes, Lasix, diuretics, and then we thought of taking for ad hoc angioplasty for this patient. So if you see the angio, LED was totally occluded and it is highly calcific. RC is also totally occluded and there's a huge thrombus burden, what Dr. Rupali has talked before. And he was just living on a small circumflex. So we thought of that, the thoughts going in our mind was that he is a candidate to get a good, improvement with revascularization. But the thing was the calcium, 2 occlusions, low EF, and quite a sick patient. So the calcium, high thrombus burden, and the relatively unstable patient were our concerns, and we thought of boldly thinking of doing angioplasty, but we thought that we will require some calcium modification device in this patient. We discussed among ourselves and we thought that we'll just open up a RCA to restore some flow and then we'll see further for a stage plasty to LED. See, we began with a run-through wire. We could cross easily with a 1.5 and followed by 2 balloon. But it didn't help. There was no much flow across. This is how my thromboster was just staying in the proximal segment. I was not able to cross my aspiration catheter down. I dilated, but there was no much improvement in the flow. After a few minutes, again, it has closed down, and this was the flow. Now, the flow is zero. There's a huge thrombus burden, LED also CTO, and if I try to be doing some heroics, I may lose my patients. So the thoughts were going that for doing some plastic that time, I will require some calcium modification. Then again, we have some concern about no reflow. So what I thought was to do a intracoronary thrombolysis, and we have some paper from in the net about doing it, and then bringing the patient, especially with the high thrombus burden, and especially when the anatomy is not that suitable for doing a ad hoc angioplasty. So we did interlesional 5 ml tenecteplase and 10 ml tirofiban, and then we put him on an agriblock drip. This was the post thrombolysis with tenecteplase. We stopped here. Stopped, and we fearing no reflow and suboptimal result, we thought of to bring him back. So this time, after 2 days, I was armed with Rota, IVL, a good anesthetist backup, but imaging was not available at that time also. Wiring was easy. I could cross with different balloons sequentially, increasing the size. Then dilated with 3O balloon. This was the flow. So plan to stent it. One proximal. I thought the distal may not require, but there was some dissection and some slow flow. I thought of then putting a stent down as well. So put a stent down also. This was the flow, but again there was some under expansion. And again in this scenario, I thought of choosing a IVL to help. And then we did a IVL in both the mid and the proximal segment. And you can see now the results are far better than before, and we could achieve a TIMI2 flow at least. Then planned for LED because patient was stable. It was difficult to cross initially, so I have to do a parallel wire, and then that helped to cross over a microcatheter. Sequentially dilated it. And then after having good dilatation, also put a wire and dilated a diagonal, and then with the trapped balloon technique, putting a balloon there, I inflated the stent. But again, there was a waste because of the calcium in the proximal lesion. I was anticipating that. So then again, we used one IVL in the proximal LED as well. And this was my final result. So the take home message is that always clinical scenario may not dictate your strategy. Calcium is the biggest stone in our doing a good angioplasty, especially in acute and chronic disease. IVL is of great help, especially in pre or post stenting, whatever you can choose of. Of course, Rota is a good backup strategy, but the thrombus burden always is debatable to be used or not. And in PAMI setting, especially to open a CTO is always challenging, but maybe not that rewarding as in a chronic settings. Laser may have role in thrombus burden, but I'm not sure about its promising strategy. Thank you.
Thank you. So, the RCA, RCA is a CTO. So which wire you used to cross?
It was easy, sir. Run through wire also went. It was not that difficult to cross, but only problem was the dilatation with the balloons. I'm not getting a good dilatation with the thrombus. There was no flow. So that was the concern.
So you thrombolized the, and then you did the procedure.
Yes.
So any other approach of tackling the RCA? Why you have not opened the RCA before thrombolizing? Or
I tried with balloons, waited for 10 minutes, but it didn't help. There was no flow down, so I have to wait. Because probably the thrombus was very high at that time. And thrombolysis did help me in regaining a flow after coming up after 48 hours.
Because the thrombus was distal to the lesion.
It was all along, sir, from the proximal till this, and after balloon dilatation also it came up in the proximal segment.
Okay. Any other question from the audience?
The patient had inferior wall MI and hemodynamic was stable after 48 hours when you took the patient. So why did you decide to tackle the LED when patient was in a stable condition after you did the RCA?
for the complete revascularization, and when I could do RCA, it was not that difficult to tackle that. So I thought I'll finish off in the LED also. Because now even the trial says that you complete the revascularization, that benefit better than waiting. Already patient was on inotropes, on supports, it was quite stable. So I thought of doing that and I could do it.
So the complete trial was written at an institution that's just down the road from mine. We're recruiting, trying to answer some of these questions. We've got some evidence now to say that revascularization in the same hospitalization is probably the best idea because patients get lost to follow-up. But I'm going to put my ICU doc hat on and suggest to you that this patient was not stable. The presence of inotropes is the definition of SCI B shock. And if you're going to define a patient as stable, you can't even define them as SCI A shock, which is high-risk PCI, which is this in a patient who's immediately after STEMI. So I think that your result is great, and you should be commended on the result. But I don't think that it was all skill. I think there was luck there too. And I think if you're going to put a patient's life on the table, luck should not be a strategy. And the consideration of the patient's overall hemodynamic stability should come first. So if you were to do this again, or if perhaps I might consider doing this in your place, I think I might have done the same thing, which is revascularize the LAD in the same setting, though CTOs were a minority of patients in complete, and there were a minority of patients in multi-stars AMI, etc. But I would have probably done it after the patient was off inotropes, on stable medical therapy, walking around with no active heart failure, because you're starting way behind the 8 ball when you start here. That's just a comment in my approach to the management of these things.
That's right. I think that's another way to deal your case of
absolutely
two CTOs, RC and LAD
Yes.
with a thrombus burden. Thank you very
Thank
much.
you.
So we are going to move to the third case, and Dr. Satish Shurivanshi, double trouble in a primary angioplasty.
Very good noon to everyone, and thanks to Dr. Srinivas for making me a part of this conference, and the chairpersons, Dr. Tiwari, Dr. Keshav. So my case is not something like where you can plan these things and I'm anticipating this step 1, step 2, step 3, something. So this is a real nightmare which happened during a primary angioplasty, ST elevation myocardial infarction. So I'll tell the real story. What happens is most of the time we call it a nightmare, but usually it happens in the daytime, but still we call it a nightmare. So this is a 59-year-old gentleman, non-diabetic, non-hypertensive, and he was admitted in the ICU with a diagnosis of acute ST elevation myocardial infarction. So the plan was to take this patient for angioplasty, and our fellow, he was doing an angioplasty in the cath lab, had a severe LV dysfunction with regional wall motion abnormality with inotropic support. So suddenly what happens is, I'm sitting in the OPD and I get a call from the cath lab guys. So the patient is having CPR, you just run to the cath lab. So this is on the second floor, I just run to the cath lab, and I have this scenario where what is happening, you just see the patient already had a severe LV dysfunction, patient is in, the CPR is continuously going on, all inotropic support, the patient is on dopamine, adrenaline, high doses, non-adrenaline, vasopressin, everything. Intracoronary epinephrine has been given. Still, like, once the CPR is stopped, you see that the patient is not holding the pressure. So we are with it, we see that this is continuously going on. So my fellow. So what happened is the people, the cath lab, they were just doing CPR. So it is like I said, no, the patient is not going to survive. You see already the circumflex, which is a very moderate, big size vessel, had already gone, and LAD was already gone. So hardly any myocardium is left with the patient. So I said, okay, we will just do massage for more 5 minutes, something like that, and then we call it a day that we cannot do something. We cannot save the patient. But what happened is my fellow, he was a muscular man, a bulky man, and I thought that he had some feeling inside that this thing has happened because of him. So he went to do a cardiac massage, and with the robust cardiac massage, the pressures, they were on 200, and he continued this massage for 10-15 minutes. And after that, he stopped the CPR. We saw that the patient is holding the pressure and the ECG is also stable with no arrhythmias and all. So this is the scenario which I came here, and you see the wire is there and the CPR is just continuing, and there is a less flow in the LED. So this is the, I'll take you through the previous picture. So this is the LED, the left vein, there is a distal left vein plaque is there, ostial, there is 95% stenosis. And usually in anterior, this ST segment elevation myocardial infarction, usually you do a direct stenting. So this patient, he underwent a direct stenting, and this stent was put, and then the patient, post-stent dilatation was done. And you just see here what is happening in one of the shoots. What we had is the patient had an almost acute occlusion of the. So here the flow has decreased, but when I came here, so this was the scene. The circumflex has totally gone. The circumflex has totally gone. So after massage, we see that there was a slow flow and there was a severe pinching of the circumflex. So I tried to cross with the normal BMW wire, but I was not able to cross with the BMW wire. You can see the angle also. So you see this is the post-stent dilatation, and you see what happened. So there was a total acute occlusion of the circumflex. So I was trying to cross once the patient was little stabilized. I was trying to cross with the normal BMW wire, but because of the angle and the tip is soft, I was not able to cross with the wire. Then we decided to go with this whisper wire. So you will see the wire was just going outside always. So I tried, so it was going in some little branch whisper. Ultimately, I was able to cross the circumflex to the stent struts. And after that, we dilated the stent strut, left main stent strut with a 1 millimeter balloon. And here you can see there is some dye staining which you are able to see here. I dilated the LCX with 2 into 10 millimeter and the stent strut also, and after that I finished with 2.5 into 10 millimeter balloon, and I was able to restore the flow in the circumflex. So I thought that this there will should not be a pericardial collection, but ultimately when we saw in the echocardiography, the patient had started pericardial collection and the pressure started dropping, and you can see the tachycardia in the patient also. So then I decided, you see here, I cannot do a balloon occlusion. I cannot close down the circ. I cannot put down a balloon in from the left main to LCX because there was the balloon has to be in the ostial circ. So what I decided that this patient requires a stent graft occlusion of that perforation which the patient is having. So because of the angle, I directly decided that I should go for a guide plus because I was anticipating that I will have issues in tackling down the stent graft to the stent struts because it's a bulky device. We already know that when we need a support and there is a proximal lesion. So with the help of the guide plus, I delivered this graft master. So this is the second trouble which we got during this acute occlusion, and then now we have this problem. A graft master 2.8 into 18 at 15 atmosphere we just deployed there, and after that it was dilated with a balloon, and now we had this final result. After this, the patient was shifted to the ICU and he recovered after 5 days and then was sent home. So the take-home message is sometimes when you work in the cath lab, you can have sometimes two monsters coming one after the other. So you should be ready. Here, no planning, nothing. Everything comes at the fraction of the second. What you have to do, you have to do what you had learned from your experience. In this case, maybe dedicated IVUS guided left main bifurcation initially, which could have predicted significant plaque shift and disease of the LCX ostium. I think when the fellow was doing the case and there was a little slow flow, he could have seen that, and at that time he could have crossed the LCX and then restored the flow because before it went into acute occlusion, 100% occlusion, and patient going for a cardiac arrest, recrossing the LCX with a normal wire could have prevented the this perf which the patient had, but ultimately this was the only thing which we could have done in the patient and saved life of the patient. So sometimes you have two nightmares simultaneously in a patient and you have to act with all your reflexes. Thank you.
Thank you, Satish. But you are extremely lucky that you crossed the circle and then putting a graft master and getting the good flow. But after the CPR, what do you think? Maybe some thrombus migration distal to the left main, or what has happened? Why?
There was a plaque shift. The stent was put from left main to LED. And when the guy was doing with a high pressure balloon NC, after that there was a slow, the flow decrease, and after that there was a complete occlusion when he went at high pressures. That was the thing. So there was a plaque shift. There was no significant.
What happened in acute ST elevation MI, post stenting, you should be very cautious doing high pressure dilatation. So that is one of the concern.
And during the initial part also, the fellow was not able to recognize that the flow has decreased in the LCX. So he continued, he took a bigger balloon, went at high pressures, and ultimately he had acute closure. It just knocked down circumflex and he went into cardiac arrest. CPR.
Okay, so come over here. So moving to the fourth case, Dr. Ashish Tiwari. Yes, please come over. And the late STEMI with cardiogenic shock and heart failure.
Satish, can I ask you a question just as Dr. Tiwari prepares?
Yeah.
So do you now, if you're doing a crossover LED to left main, do you wire every circ? Like how have you changed your practice? Because what happened here is an unfortunate stroke of bad luck. Right? Like the Whisper ES is a relatively low tip strength wire. It's 1.2 to 1.3 grams, right? So it's not a bad wire to cross this with. I might have used a regular Whisper or a Xi'an Black with a microcatheter or something. Doesn't matter. I don't think anything was technically, like there was no bad decisions other than maybe not recognizing slow flow at the beginning, which is just an experience thing. So how would we kind of systematically change our practice to change this, right? Do you now wire every circ before you stand LED over left main? Do you do it in every STEMI maybe? Do you do it whenever you see plaque? Like what's the headspace change that comes from it?
Actually, if it is a disease-free vessel, so usually in acute MI we don't do it.
You're right, we don't. That's why I ask, what do we do?
There is at least some plaque is there, and we are able to anticipate that this patient is going to. So it's better to have a wire across the circumflex so that the flow doesn't go out. It's not knocked off totally, the circumflex.
I feel like what I take away with this is how am I going to, like I always ask myself, well, how am I going to learn from this? What am I going to do differently in my own practice, right? So what I take away from this, because we all stent left main LED crossover all the time, it's usually not a problem, is in high risk circumstances. So lots of thrombus, lipidic plaque, narrow angle bifurcations, STEMI, hemodynamic instability, you always throw wire down the circ whether there's plaque or not because you can't afford to lose it. That's my learning point from this. I don't know if anybody else has any thoughts about that.
That's what I told in conclusion. Okay? It would have been better to keep a wire in the circumflex jail. That would have helped. And then recrossing the things and restoring the flow in both.
Yes, Ashish.
So good evening, everyone. At the outset, I would like to thank Srinivas sir and organizers for giving me opportunity. And a packed hall in a conferences like these are rarity nowadays, and congratulations for that. So 10 years back, when I studied late STEMIs, I published a study of around 1,000 patients 10 years back in Lucknow. So when I thought, as the India will progress, 10 years down the line, maybe the things will be better. So 10 years down the line, late STEMI is still a nightmare for us. And every one of us, every week, if we have bad days, more than 3-4 cases in a week, or at least once in a month, we get stuck in these cases. And wherever I worked, late STEMI who presented to us are having different protocols in every institute. And if you ask 10 stalwart or experts, their approach to these late STEMI will be slightly different. Either in pre-op, either in post-op, either in drug management, either intervention is always different. Even in 2 premier institutes in Lucknow will be having separate approach for that. So coming to these late STEMI, there will be 2 substrates of that. One will be those will be having stable late STEMIs, where the guidelines are more or less confusion and they are telling about viability and different things. But luckily, in the late STEMIs with shock or heart failure, there will be a clinical indication for intervention. Now comes the main problem, how to approach these patients and when to approach these patients. And there is a trick. And protocol for every institute will be slightly different for them. Some will take these patients, they intubate it, they take these patients, they operate it, and they see the results. Few of them stabilize, few of them don't operate at all for 24 hours. And it is there in every city, and they operate in a particular manner. Guidelines those clearly say that these patients need to be intervened. So when they need to intervene, is a trick, and this has to be followed in every institute according to their protocols. So this is a 67-year-old gentleman with anterior wall MI, presented with angina, dyspnea, and shock, ECG anterior STEMI, and ejection fraction 25%. And he presented around 20 hours, so obviously thickness was preserved. And hemodynamics at presentation was 70/45 and SPO to 88%. All these patients, I always take lactate at the time of presentation. If they present in shock, if their lactate is 7, 8 or more, I try them to get those stabilized for a few hours. So luckily in this case, initial medical management stabilization has started, acidosis was corrected, SBP 100 systolic in our 2 hour, and then I put IBP and blood work was apparently okay. So augmented pressure, I got 150, 130. So within 2 hours, I started preparing, and angiogram shows proximal LED 100% occluded, calcified in proximal LED, and plan was PCI to LED. So here also, substrate will differ. All these patients who's about to crash or having severe shock or LVF, and if the respiratory rate goes more than 40, I always try to intubate them with my cardiac anesthetist support, and then I operate them. This patient gave negative consent for intubation, so I taken with NIV also. So this was the first shoot, as I told. Right femoral 7 French, left femoral 9 French IBP in long segment disease, wire run through NS, run through was taken, run through could not cross, chain to pilot 50, so the wiring was done. Thrombus were uncrossable, so it was a thrombus on, as the last speaker also said, calcium with thrombus in acute STEMI condition is a nightmare for most of us. So imagine a condition where if you don't operate the patient, he's eventually going to die, and 90% is the mortality in most of the series. And even if you operate this sick patient, the mortality still remains 30 to 40%, and it all lies on the operator. So this is a dilemma where we all have to face, and we have to operate these patients. Recently, athlete died post MI, late presentation, and it all went to the doctor that they have operated and patient, they could not save the patient. But yes, these patients have to be operated. So 2.5 NC, 2.5 NC did not cross, and then I keep all these cutting balloon from 2 to 2.25, 2.5, and they did cross, and then did dilatation 2.5. Followed by cutting balloon 3.30 also, and poor distal flow even with vasodilators, poor distal landing was there. So I could, in few of the runs, I could find a distal landing. I placed a 2.528 with guide plus support. Distal stent was put, and then 328 Elunir, and then I put a 3.440 crossover left main LED, and then post dilated also. So after that, patient final result was this. So we got decent kind of result. Hemodynamics was fairly better post-operatively, and patient started having further dyspnea, and then electively intubated. So patient electively intubated, respiratory efforts. So the patient did not crash, but intubated, and patient went into AKI, then started showing recovery. ECG improved on day, cardiogenic shock, there was no improvement in cardiogenic shock. Patient still was on high inotrope. I continued IABP for 2 more days. And extubation, when the patient inotrope was less, I tried to extubate. Our team, cardiac anesthetist, tried to extubate, but extubation failure was there. So I continued the support. And next day, at day 5, I was able to extubated, and IBP was removed on day 6, discharged on day 7. So this kind of patient will need excellent post-op care in your ICU. then only these patients can be saved. If they are extubated immaturely, they will arrest, or in these kind of patients will need a proper support in these cases. So coming to conclusion, the dilemma is in these, what was dilemma in these STEMI cases? So dilemma is very clear cut. When to take up these patients? When they are crashing at 70 blood pressure, or when the blood pressure is around 90 or 100, when IBP shows some improvement, then you have to take these cases. You have to intubate upfront, or you have to intubate them post-op, or when they are crashing. So these dilemmas we are facing every day, especially in STEMIs, those who are having calcified disease, cutting balloon and IBP support. Though the IBP, many of these trials of IBP are not are slightly positive or not positive, but in Indian setting, IBP still works very well. Even if it's giving some cardiac output to the patient, it saves few % of life, especially where the Impella is not available for most of us. In selected cases, IBP is still very useful for India, and leaving them medical management can be catastrophic, and most patients just succumb to medical management, and most of these patients shows mortality up to 90%. So excellent ICU care, post-op care, electively intubation rather than emergency intubation is key for success. And with this patient is now into follow-up, and his ejection fractions is 40-45%, doing absolutely fine class 1 currently in class 1 condition. So these are the bets, and even with all these, we do all these successful interventions, 30% or 40% patient may not go home, or they will die in first month. So that also has to be taken into account. Thank you very much for the patient listening.
Thank you for a good case presentation. There's always a dilemma when the patient comes late presentation, delayed presentation, especially 24 to 48 hours. And if the patient stays all right for 2-3 days, then he again becomes stabilized. The patient delayed presentation is the worst. That's a scenario where you see thrombus burden and a lot of other problems. I think we have Dr. Sanjog with us, and then in sort of a shock thing and impellers in sort of situations in our country, we face it as a challenge when it is too late to advise for the impella, and the problems are the cost is very expensive. And then in Canada, your place, that is not a problem, but in India, I think that's a major problem. Leaving the cost apart, and when you think is the ideal stage to advise for impella in such sort of scenario, can you highlight for the sake of delegates?
Yeah. So factual correctness. Canada. There's something wrong with this. There, Canada, the cost of impella is the same as it is here, and it's not paid for by an insurance company. The hospital has to pay for it out of their own philanthropic and research budget. So we get in big trouble when we use impellas if they're not indicated. So we follow the trial evidence, right? So median duration of support in danger shock in these types of patients was 52 hours. Median time to recruitment was about 4 hours. And so when you had giant Q waves and no ongoing chest pain, i.e. late presentation MI, they weren't candidates for the trial. These are the kind of things that we use as part of our decision-making paradigm. If the patient exits an acute MI cardiogenic shock presentation to a cardiogenic shock, heart failure, late presentation, dead ventricle, that's a whole different group of people, right? And the patient who you support in that circumstance may need dual ventricle support or may get an Impella 5.5 followed by an advanced therapies workup because their anterior wall and half their lateral wall is gone, right? So that becomes a clinical decision-making picture. But the key is, I think, in your own institutions or environments, to learn and tweak your own process. Have a protocol that says every single patient that meets the following criteria, and one of them is hemodynamics every time, because that's probably, to your point, critical ICU management, really good ICU management is key, and the backbone of this management is hemodynamic care. Every one of the patients that meets these criteria is approached. Document the ones that say yes, document the ones that say no, document the features in their file that suggest they are or are not going to say no. That's going to be your first step to going to funding bodies to say, these are the patients that could benefit from this therapy, but you don't let them have it because we have no funding. Fix it. That's how you turn. We now have funding from the government coming for hemodynamic support. It's a huge deal in a publicly funded health system. The government's not going to pay for people's impellas. That's shocking. But we actually did it because we collected all these data and showed them that just because death is cheap, it doesn't mean it's right.
Ashish, very good case. Sanjog has already clarified upon the shock. Two technical things I would like to bring forward. One is I would not have used thrombosuction because after 20 hours your thrombosuction is not going to work. The thrombus is already organized. Second is putting such two long stents. I would have put a DEB distally and ended with a hybrid procedure in this patient.
So that element,
well done case.
That element will always there. Just put a stent in proximal and let's leave it there. So that will be. And regarding thrombosuction, as I said, every institute follows. They do thrombosuction day 2 also, day 3 also. Yes, but that depends on that, right?
Thank you, sir. We are already running late by 40 minutes. So let's call the next speaker. From Mauritius, early experience of saving lives in STEMI in Mauritius. Dr. Shalol Umesh.
Thank you, Dr. Shamlal sir, for coming all the way from Mauritius for sharing your experience. And I'm happy to share a lot of doctors from Mauritius, Africa, Kazakhstan, Russia also participating in the separate translations arranged for them. Over to you, Dr. Shamlal.
Thank you, Dr. Srinivas, for having given me the opportunity to be on this stage. And today I'm going to present not interesting cases, but more of what we did in Mauritius to improve the cardiac services, especially the STEMI cases. When I was a fellow, I used to come to these conferences and everybody was talking about it 10, 15 years back about primary PCI STEMI cases, which was still not heard in our country because we didn't do STEMI cases. So you see, my slides are a bit different. So I am from Mauritius, which is also called the Paradise Island. You can just have a look at the pictures, why it is called so. So there was a famous writer and philosopher by the name of Mark Twain, an American writer who once said, God created Mauritius first, then copied heaven from it. But even in this heavenly place, you see we have ACS and STEMI patients, which obviates the need to have cath labs to treat them. So today I'll be presenting, I work in the government sector where our health sector is free of cost. So you get in the hospital and out of the hospital without paying a cent, whatever type of operation or whatever type of procedure you do. So I'm going to today present the implementation of 24/7 primary PCI in public hospitals in our country. What is our initial experience and how it has impacted the lives of Mauritians and health system as a whole. So if you go by any guidelines, be it any local guidelines or international guidelines, they all say only one thing, that in STEMI cases, which looks like this on an ECG, earlier the culprit vessel is open, better is the immediate, short-term, and long-term outcomes. Minute in MI means cardiac muscle, and every effort has to be done to open the artery as fast as possible. And we all know there are two ways to open the blocked coronary artery. One is medical management by thrombolysis, and secondly by intervention where we do your angiography and angioplasty. So up till 2020 September, thrombolysis was still used in most of our 5 regional hospitals for patients of STEMI. And coronary angiography was deferred or not done. The patient was put on a waiting list. He was sent home and then called later at a later date to do his angiography. Then it was decided whether to do a PTCA, go for CABG, or go for medical treatment. And this is a busy, nice guidelines, which basically says upon the first medical contact of a patient with chest pain, in 10 minutes, we should do the diagnosis and diagnose what it is. And in non-angiography centers, in 10 minutes, we should thrombolyze the patient. And in PCI-capable centers, an angioplasty should be done within 2 hours. And the wire crossing should be done within 90 minutes. So if a cath lab is available, primary PCI is the preferred treatment of choice. So before September 2020, our cath lab, my cath lab, used to be open from 9 to 16 hours. In the beginning, streptokinase was used. Then subsequently, tenecteplase were used to thrombolyze these patients. They were stabilized, sent home, and put on a waiting list for angiography. The cath lab used to get closed after 4 p.m. on working days, Saturday at noon, Sunday and public holiday, it was altogether closed. And all those patients who were having failed thrombolysis, for rescue PCI, they were sent to 2 other centers present in the country. And that also depended on the availability of the cath lab, place in the CCU, and of course on the mood of the doctor who was on call. So some patients passed on the way before reaching the hospital or after coronary angiography. Minute means muscle in STEMI, and precious time was lost just transferring patients from one place to another. Many patients ended up with heart failure or other complications due to delay in opening the blocked artery. So this is a hospital where I work, and in September 2020, I took charge of the cath lab. I was lucky to be surrounded by a young and dynamic team. Some of them are present here. But the problem was like we had an inexperienced team as to do primary PCI. But we were all ready to take the challenge and start primary PCI on a 24/7 basis. So on the very first day of my head of department, so at least we started doing primary PCI from 9 to 16 hours, because since I work in a government hospital, we had to take the permission of the ministry to open the cath lab after hours. And we all know how the public sector is. It always takes a lot of time to get things done. So 9 months down the line, on 24/7, primary PCI was started in June 2021 as a pilot basis of 3 months in my hospital. So right on the first day, I got a patient of 40 years old, uncontrolled diabetic, smoker, who was having chest discomfort since last night and started having central chest pain since an hour. He had a malaise, he lost consciousness. When he regained consciousness, he was brought to the hospital by his colleagues. So this was a time, this is his ECG, which shows no secret, it's an anterior wall MI. And this was a time where my first day, I get a first patient, 40 years old, what to do? So we tried to take him in the cath lab straight away. We didn't think of thrombolizing. So this is what his right coronary artery looked like, which is normal. And this is his left coronary artery. And we can see the LED is blocked. Just passing the wire through opened the artery. And I tried my luck. I directly stented it. The stent went on. And then this is the result. Very simple. 10 minutes procedure, 15 minutes procedure, and look at his echo. In a long axis, it looks very good. And in 4-chamber view, we can see some hypokinesia of the apex, which may recover maybe afterwards because the stunned myocardium are going to take over. So that day he stayed in ICU. Day 1, the patient was shifted to ward, and on the 3rd day, he was discharged from the hospital. We saw him after 2 weeks in a stable condition, no chest pain whatsoever, and up till now he's leading a normal life. So the advantages of primary PCI, 24/7 primary PCI to the patient is that the artery is open under vision, so the chances of success is very high. Pain and ST elevation subsides as soon as the artery is opened. There is no thrombolytic use, so risk of bleeding and all the complications are almost reduced to nil. The ejection fraction of the patient is preserved, so his personal, professional, and family life is preserved, and he is productive in all aspects. Days of hospitalization in most cases are reduced to 3 instead of 6 or 7. Number of medicines reduced dramatically, so the side effects of the medications are also less. And early return to professional, personal, and family life as damage to the myocardium is very little. Advantages to the system and the hospital. One tenecteplase vial cost 50,000 rupees in our country, and a stent cost only 6,000 rupees. And in any way, if we're going to thrombolyze a patient, we are going to do an angioplasty, so that makes up to 56,000 for one case, where it could have been done in only 6,000 rupees. So days of hospitalization are 3 instead of 6 or 7. Number of beds are simply doubled as we discharge the patients in half the time, and we can accommodate for more beds. The risk of tenecteplase-related complications are reduced to a minimum. This is where our Ministry of Health is located in this building, and we have 5 regional hospitals. And for whole country, we buy at least 2,500 vials of streptokinase a year, which amounts to $2.8 million US. And one cath lab, it costs around 1.2 million US dollars. And by doing 24/7 primary PCI, 2 labs per year can be added to any hospital just by doing primary PCI in our 3 cath labs that exist. And the money saved can be used for other development in another health sector. So we had some trouble, of course, implementation, acceptance, preparation of the team and the approval, anesthetists, radiographers. These are all rare birds and it's always difficult to get them. The place to rest, mess, payment issues, etc. We had multiple meetings at the level of Ministry of Health. We had to convince everybody and finally everything was settled and the program started on 21st June 2027. In the beginning, our aim was at least to open our cath lab on a 24/7 basis in our center, and every patient presenting with STEMI benefit from primary PCI on a 24/7 basis, and primary PCI to be extended to the other 2 existing centers and get 1 more cath lab at the other 2 regional hospitals. But then what is the actual state of affairs? After the tremendous success of the initial pilot project at G2 Hospital, the Ministry of Health decided to extend the project nationwide to the other 2 centers since July 2022. And patients from almost each hospital now, especially those where cath lab is absent, are being transferred as far as possible to a primary center to do the primary PCI. A small spark that started in one of our hospitals has taken a nationwide dimension now. An introduction of primary PCI in our health system has brought a paradigm shift in the treatment of patients presenting with STEMI. And we can now say that we are at par with the latest mode of treatment as any developed country for at least STEMI patients. If a patient is coming with an ECG like this or with an angiography like this, we can't give him anything better than this one.
It's time.
So we won quite a lot of awards.
It's time
because of that. And then, yeah, I'm finishing 1 minute, sir. And these are the awards that we won everywhere. We got the gold award. And then finally, there was an article on the European Heart Journal in 7th April 2023 saying, a small country, big difference, how one physician's vision became a reality and transformed acute myocardial infarction management in the Republic of Mauritius. And in conclusion, primary PCI is undeniable treatment of choice for STEMI cases worldwide, accredited by all international guidelines since years. It is the best gift that can ever be given to a patient presenting with STEMI. It has advantages of not only to the patient, but to the health system and society as a whole. There should be a political and professional will to impose such decisions in the benefit of all and the system. And Mauritius has the advantage of being a small country and any corner of it is reachable in less than 120 minutes as recommended by all international guidelines. And after doing around 560 cases over 5 years, I can say our success rate is more than 95%, and primary PCI, though more risky, is easier to do than many other interventions and is the only procedure that saves lives in STEMI patients in immediate, short, and long term. There is a learning curve, and we have to go through it. And implementation of 24/7 primary PCI has been the most rewarding progress in cardiology in the past 20 years in Mauritius. And with this, I thank you all for your kind attention.
Thank you, Dr. Shamri. Please join us. Since we are running short of time, so moving to the last case of this session, intervention to prevention, Dubai experience, Dr. Brajesh Mittal.
Good evening, chairs, and many thanks to Dr. Srinivas for inviting me. This is per se not a case, and I would like to draw attention of Dr. Umesh. Dr. Umesh, so I was privileged to be in the Ministry of Health where you are working in 2002 until 2004, and that was just the beginning of the primary PCI. So I was part of the process with all other colleagues in DDY Hospital. And then I came to Dubai in 2004, and again in Dubai also, the primary PCI program was not as much advanced as it is now. And it was again my privilege to set up a very good primary PCI program in Dubai starting 2004 when I came there. So after that, the gears are being shifted, and this is not a case per se, but this is a very important discussion on intervention to prevention. And let me confess that this presentation, the backbone and basis lies in a TCT session in 2024. And I took that concept so close to my heart that now I am almost always ready to speak on this topic in any forum. So you can see this kind of patient, a 66 years old male, acute inferior MI, 6 years back, primary PCI to RCA was done with a great effort because there was a very dilated, tortuous, highly thrombotic artery, and everything went well, and we pat our back once, and we thought everything is done well. And then we forget often, like Dr. Umesh showed the case, that we feel very good after opening an artery, but successful PCI is not the end of the thing. It is actually the beginning of treating of these patients. So our patient is doing well. We have put him on multiple medications, and apparently his all parameters are, according to guidelines, are controlled. HbA1c is good, LDL is good. He is the first patient in UAE whom we give inclisiran 5 years back in May 2021. And his triglyceride is controlled, eGFR is normal. Then the question comes, have we done enough? Apparently you would say yes, but no, we can do still many more things. This is what the basis of this presentation. So what else and why? Because recurrent MI is a real challenge. It carries high morbidity and high mortality. And our offer should be that if somebody has suffered once and if we have treated him well, it is my responsibility for my patient that I do not let him suffer once again. That is what is the meaning of real good practice. So we have to look for the redefining and residual risk from all different angles, which besides LDL and HbA1c, also the inflammatory marker like hsCRP, like lipoprotein A very meticulous control of thrombotic events. Then we have to address diabetes with the latest medications. We have to also look for ApoB. So there are many more things which we have to look for. We have to improve the adherence of the patients, and there are various methods by which we could improve the adherence. In one of the trials, it was shown that patients who were given 30 days supply at the time of discharge versus patients who were given 90 days of medications on discharge. So patients who were given 90 days did fairly well, and they were much more adherent. And similarly, the patients who were given polypill, a combination of multiple things in one, they had much better adherence. So it is our duty to ensure that there is good adherence of the treatment after primary PCI or after thrombolysis or after treatment of the acute MI. Also, a thing which is very much lacking is the cardiac rehabilitation. And you can see the survival rate was much better in the patients who were put into cardiac rehabilitation program versus those who were not. So this part is still lacking. And then this debate continues, but although this debate should have been settled long before, that what should be the long-term monotherapy, aspirin or clopidogrel? Clearly, right from the beginning, the trials have shown that clopidogrel is superior. The host exam trial, in which even the thrombotic complication and in any bleeding complication, both ways, clopidogrel was superior as a long-term monotherapy. And the latest one is the Smart Choice 3 trial, in which clopidogrel showed benefits over aspirin monotherapy following primary PCI, following PCI. This is as recent as March 30, 2025 in ACC. And then, are we using the right medications? Do we know all the therapies available with us? One of the important thing in our armamentarium is low-dose rivaroxaban. In the COMPASS trial for CAD, in the Voyager trial for PAD, it was clearly shown that patients with high risk, multiple episodes, polyvascular disease, low dose 2.5 milligram twice a day rivaroxaban along with aspirin 100 milligram should be considered. And this is very much in the guideline. And we have many patients like those who are taking rivaroxaban also. Lipid lowering is very, very important concept. Not only we have to reach to the target, but we have to reach the target aggressively and very early. So early and aggressive lipid lowering should be the goal because it stabilizes the plaque. We have trials done with PCSK9 inhibitor, both with alirocumab as well as with the evolocumab in the acute MI settings, and both have shown benefits in the patients who were treated early with the PCSK9 inhibitor. And similarly, we have the trial with the inclisiran, Victorian Initiate trial also showed the same thing. hsCRP, very, very important thing. Many times we do not do it. It is a more powerful determinant of cardiovascular death than LDL cholesterol among statin-treated patients. And you can see in the black or in the blank, the quartile, the patients whose LDL was controlled but whose HSCRP was still high were at a higher risk. It is a much better predictor. Comes the next question, influenza vaccine. Are we really giving our patients influenza vaccine yearly? Are we talking about it? Are we advising it? Clearly, trials have shown, meta-analysis have shown, and influenza vaccine is in the guidelines that all patients should receive influenza vaccine, anybody who has cardiovascular disease. Then colchicine. It is been in the chronic stable angina, it has been proved conclusively that it should be used. In the acute MI setting, the trials are conflicting. The LODOCO-2 trial in the chronic CAD and COLCOT trial in the acute MI setting, both were in favor of colchicine. However, the CLEAR OSS 9 trial did not show advantage in ACS patients, so there was a conflict in the two trials of acute MI. Yet, there was another trial for chronic stable angina, Ekstrom trial, which is very recent one trial in last ACC 2025, and it showed the colchicine on the progression of known coronary stable CAD. Based upon that, all chronic CAD patients from both the guidelines, ACC and ESC, they recommend colchicine as class 2A indication, while ESC also indicates in ACS as class 2A indication. So are we doing these things or not? This is why I opened up this subject. There are so many things which we are not doing. Lipoprotein A, now we are regularly measuring, and we know that it increases the attributable risk, and we are very glad that Novartis is bringing down Picatrexel by the end of this year, and Amgen is bringing another medication by the end of the next year. So we'll be having direct therapies for lipoprotein A. CKM syndrome is very much in the vogue now. We should all understand this because presence of one proliferates the if two are present, this is not 1 + 1, but it becomes 11. So if somebody has diabetes and CKD both, the mortality rate is much higher. That's why it is our duty to look from the CKM aspect. And now you know that recently there was a guideline only a few weeks before, a proper complete paper on this subject, and we have to use the right medications in the patients with CKM syndrome. And this is as a cardiologist, interventional cardiologist, we are finally doctors. We are not just a plumbist. I've done hundreds of primary PCI myself, but that is not the end of the story. We have to take the shared responsibility to give the right kind of long-term therapy to the patients. We have to understand that cardiovascular disease is primary inflammatory disease, and we know the anti-inflammatory effects of a statin. And besides that, there are so many other medications are being developed and being studied, like Zilti, which has been studied in multiple trials now, and there's the IL-6 interleukin-1 beta CANTOS trial for canalicumab, and then there are some other trials. So inflammation is essentially a part of cardiovascular disease, and we must start addressing the inflammation very meticulously, and we should give enough heat to it. So this is my last slide. It was just to create some understanding about the long-term therapy, and I personally take it to myself that anybody who has been in my care and I have treated him as a primary PCI, I must make sure that he should not suffer ever again. So we need to have earlier aggressive lipid-lowering therapy. We have to give attention to HSCRP, lipoprotein A, triglyceride, and ApoB. We have to address inflammation by various modalities, which also include influenza vaccine yearly. We have to give appropriate antithrombotics, de-escalation, aspirin versus clopidogrel, low dose rivaroxaban. We should know all those concepts. We have to understand cardiovascular kidney metabolic CKM syndrome properly. We can incorporate in our EMR systems AI-tailored algorithms. We can consider giving polypills. We can consider giving long prescription refills, and we have to have incentivization of the physicians after the proper auditing, whether they are doing guideline-directed medical therapy or not. Thank you so much.
Thank you, Dr. Mittal.
Thank you.
Very well done, because after intervention, one has to be very cautious about there may be a recurrent of events, and then you have a recurrence of the disease process. So all these points which you have highlighted has to be taken care of. Very, 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 very important.
I think one doctor asked in the chat that what is the care we need to take post-procedure, post-PCI, you already covered it. I think any more thing further?
anti-wall MI case scenario, both in cardiogenic shock with ejection fraction less than 30%.
Cardiogenic shock, interval MI 30%. Which MCS device should be
Sorry,
device of
this
choice? I
this question does not pertain to this
Yeah, I
presentation,
think
if I'm sure.
it's already told
Yeah,
by
another
Sanjog before.
presenter.
I think we'll close the session. Now we go into interesting congenital intervention session. We have none other than Nageshwar Rao and all.
Thank you so much, guys.
Thank you, Dr. Brijesh, for coming all the way to share your experience and take about this. Now we go on to interesting congenital interventions. Request Dr. Nageshwar Rao to come over and conduct this session along with Dr. Nitin. I saw Nageshwar Rao and Nitin here. And the other panelists who are here, please request all of you to join over the stage. And you'll have a very interesting discussions there. Now going to the next stage, I really appreciate Nageshwar's team that even the intra-uterine work, that's where it is going on. And they're on par in the any part in the world. That things are also being covered. And so such things, and we as adult cardiologists, we're also facing up with this problem of adult congenital heart disease, how to tackle that. That also will be discussed. And we are proud of Nageshwar Rao because he himself made a device on Konar MF device that will be also discussed. Over to you, Dr. Nagesh, for conducting this session. Thank you.
Thank you very much, sir. And it's a great pleasure indeed to have a pediatric cardiology session in this interventional forum. My colleague Dr. Nitin will introduce the other chairpersons and we'll start the program immediately.
May I request all the other panelists to please join us? Dr. Edwin, Dr. Sushil Azad, come this in. And Dr. Shweta, please join us. We are running late. So this is a very interesting program. Thank you, Srinivas. Thank you, ACVS, for giving us the opportunity to talk of congenital interventions here. And our first speaker will be Dr. Shweta. Shweta Bakshi. She is a very erudite, very well-known pediatric cardiologist. Does a lot of interventions, but is very good at fetal echos also. In fact, they run a training program for fetal echos in a training hospital, Hyderabad. So they do a lot of fetal echos. She does fetal interventions that is very rare, none in India and very few in the world. So she's going to talk of interventions, very interesting, waiting to hear. This is a keynote address, introductory interventions, when, where, and how. So there was none other than the right person to talk than Shweta. Please, Shweta.
First of all, thank you so much, the ACVS team, Srinivas Kumar sir, for allowing us to present, coming from a paradigm shift of 70 kg to 700 grammer. So I thank you all of you also to attend this meeting. And also I would like to thank Nitin Rao sir and all the chairpersons to have a kind introduction that they have done. So my topic is fetal cardiac therapy, when and where and how. The fetal cardiac therapy and intervention was started almost 20 years back, mostly in the Western countries, and it was considered an untouched sector for all of us. But as we have advanced in the understanding of the pathophysiology, we came to understand that the fetal therapy can really change the outcome, the natural history of the cases in selected population. So if we look at the CHD in fetal life, is not divided like cyanotic heart disease or acyanotic heart disease, like how we discuss after birth. Whereas they can be an anatomical and structural problems like TGA, TAPVR, pulmonary atresia, or single ventricle, or there can be a modifiable or hemodynamic alteration related problems like critical aortic stenosis becoming into an HLHS or restriction of foramen ovale causing the hypoplasia of left ventricle. So this becomes a modifiable disease. Or there can be an environmental risk factor like transplacental factor of antibody, arrhythmia, or the regurgitation, myocarditis. So these are all the modifiable factors that can be seen. So a lot of interest has come in modifying the natural history of the congenital heart disease so as to have a better outcome. So if a critical AS is unoperated, what happens? This is one of the autopsy of our case where it was critical aortic stenosis. They deferred a fetal therapy, and we can see that this is the left ventricle which became hypoplastic and also developed the hypoplasia of the ascending aorta. So this is a potential problem where it starts with the primary lesion of aortic stenosis because of the hemodynamic alteration of diastolic dysfunction that sets in, and that would lead to a much more complex heart disease like hypoplasia of left ventricle or hypoplasia of right ventricle in case of critical pulmonary stenosis. So can aortic stenosis is a very simple subset? No, it can be a vast spectrum of disease. It can be just aortic stenosis or dysplastic mitral valve, AS with intact septum, or it can be a multiple valve problems, mitral valve, aortic valve, coarctation of aorta, and therefore a case selection becomes very important while dealing with this. This is a case of purely hypoplasia of left ventricle, absent mitral valve, and probably this is not a good case where intervention can change the natural history. Then which is a good case? Now look at here. This is a severe aortic stenosis. We can see that the forechamber is normal. The flows are adequate, but the left ventricle has not changed its size. So again, mere presence of critical aortic stenosis is not the indication to do the fetal procedure. Like in this patient, we have done the balloon aortic valvotomy after birth and baby had got very good outcome. So in case selection criteria, if there is a hemodynamic alteration in the form of foramen oval flow reversal, development of endomyocardial fibroelastosis, and the left ventricle which is still preserved, probably the patient which would benefit from the procedure of the fetal aortic valvotomy. So here we should understand that there is one disease case, but there are two patients. So fetus is disease, but mother we are going to intervene. Therefore, a good team of members involving everybody, cardiologist, anesthetist, obstetrician, nurse, interventional is very, very important. Now let us look at this, one of the very interesting case. This we have done almost last year. This is a 35-year-old and 27-weeker. We can obviously see the left ventricle is struggling to pump, and there is a severe ventricular dysfunction, and there is a severe mitral regurgitation, and there is a critical aortic stenosis. So if you don't intervene here, this would develop hydrops or will go into the hypoplasia of left ventricle. And we can see that there is a development of mitral regurgitation. There is a good foramen oval. That's a good sign in fetal life to prevent the pulmonary venous congestion. There is severe aortic stenosis, and there is a flow reversal in arch of aorta. So we have taken this case for fetal PBAV. The procedure is done in transabdominal method of the mother. We have to anesthetize the fetus, and there should be a direct puncture of the maternal abdominal wall to placenta to amniotic fluid to chest wall of the baby, entering directly into the left ventricle. And you can see the arrow mark where the needle has entered and facing towards the aortic valve. Gradually, we have positioned the balloon, and in the down panel, you can see that the balloon is getting inflated. When we inflated the balloon, it got ruptured because we wanted to dilate it to the maximum segment. But while withdrawing, we noticed that the fetus developed severe degree of bradycardia. There was episodes of VT, and because the annulus was well dilated and it could not open to that degree with the smaller balloon, baby still had quite significant severe aortic stenosis. So what is the option? If you just leave this baby here, the fetus would succumb because there is a dysfunction, there is pericardial effusion. So we drain pericardial effusion, we drain pleural effusion, and then we introduce a bigger needle. Now the problem with bigger needle is you're creating a bigger hole in the left ventricle which can bleed. But we had to take that step, otherwise the fetus would have succumbed. So with the intention to dilate in a bigger balloon, we have taken a 16 gauge needle and we went maximum and we dilated it. But after dilation, how to remove this? Because there will be acute loss of volume with already existing a compromised fetus. So while coming out, we placed the specular device and close the entry point of the needle. This is the first case in the world literature where the exit point of the left ventricle was closed to prevent the fetal volume loss and to maintain the hemodynamic stability of the fetus. And on follow-up, you can see that the left ventricle became very good. There is no mitral regurgitation. And after birth, this baby did not even require any procedure. And we can see that the left ventricle has grown very well. This child is almost 1 year now and doing very well. So this was the most encouraging case that we have observed in last 1 year. But can we do all the cases? Severe mitral regurgitation with dysplastic mitral valve are the worst subset in the fetus because they develop pulmonary venous congestion and the death is inevitable even if you do the procedure. Now let's go to the another case where there is a hypoplasia of right ventricle because of severe pulmonary stenosis or pulmonary atresia. And you can see that there is a tricuspid regurgitation here and there is a struggling right ventricle. So again, we have introduced the needle across the right ventricle, across the RVOT, and now you can see that the to and fro flow is established across the pulmonary valve. And you can also notice that there is a good forward flow across the pulmonary valve. And after delivery, the right ventricle is well formed, there is a good antegrade flow, and this baby fetus has done very well after the birth. Now, there are special pharmacological medications that have really changed the outcome. This is the case where it is 21 weeker, multiple previous miscarriages, no live baby, and she is strongly Sjogren syndrome positive, which had severe ventricular dysfunction, mitral regurgitation, and there was pericardial effusion also. And soon after a week, we saw that the fetus developed 2:1 heart block. So the atrial rate was around 140 to 150, whereas the ventricular rate was only 75. Now, if we go back and see for the conventional therapies, either steroids or maternal IVIG, plasmapheresis, immune-modifying agents. These are some of the therapies which is prescribed. The problems remain with the maternal IVIGs. We don't know the appropriate dose. We don't know how much it would cross the placenta and also how frequently it can be given. And also it may cause severe volume overload to the mother because it has to be given at a very high dose. So with the previous experience of intraperitoneal therapy in some of the viral infections, we decided to give direct fetal therapy to the fetus. So direct fetal therapy is given in the peritoneal cavity, and it was observed that the Fc gamma receptors would be blocked by this gamma globulins, and therefore there would be reduced transfer and the effect of the antibody to the fetus. With this case, we have given direct fetal therapy in the peritoneal cavity, and you can see after a week itself, the ventricular function improved, the heart rate became almost normal, although there was prolonged PR interval, and baby delivered with the sinus rhythm. A similar case was observed with the high drops. So not only it can affect the pericardial effusion and it can also cause ventricular dysfunction, but it can also cause myocarditis, as you can see in this case. So this child had sinus rhythm, but had severe high drops due to immune-mediated cardiomyopathy. And therefore, again, the IPIG therapy was given with a direct fetal therapy. And we can see that post-therapy, there was no pericardial or pleural effusion. There was no high drops. And this is a tissue Doppler, which shows that the baby turned back to the sinus rhythm. With that experience, we have presented our data in heart failure cardiomyopathy cases in JACC, and it showed the promising result of the first 5 cases where the ejection fraction improved, tissue velocities improved, 2:1 heart block became sinus rhythm, and myocardial performance index of the fetus also improved. I'll end my presentation with this case. What do you think? What is there inside the heart? Is it a foreign body? So we can see the left ventricle is completely occupied. This is a 27-year-old primate referred with a small mass in the left ventricle cavity. And you can see that there's hardly any left ventricular cavity. Again, if we leave this back, what would happen? AV valve regurgitation, reduced flow to aortic valve, and can develop high drops also. She was genetically positive. The fetus, when we did amniocentesis, was genetically positive to the tuberous sclerosis. If we leave this fetus, the eventuality of death is possible. So what should we do here? Leave this fetus? So what did we do? We gave mTOR inhibitor, which is a everolimus, and it started on the mother. After the ethical committee discussion, this is the first case in India where the mother has received everolimus for the fetal indication, and it's a Schedule D, Category D drug. So we had to go through a lot of ethics committee approval, and they understood that there is a significant impact of everolimus on rhabdomyomas and tuberous sclerosis. Therefore, we got the approval, and after that, she has received the everolimus. We monitored the everolimus of the fetus, and you can see that it has completely resolved after the birth. And you can see that there is absolutely no tumor at left ventricle, which was noticed after the birth. This child is almost 3 years now and doing well, and neurologically also, the baby is doing well. So in conclusion, in utero intervention for selected cardiac condition has got its role, and it changes the natural history, but technical challenges are still there and needs to be developed. I thank you all of you for kind attention.
One thing, which period is safest for these intervention? Second trimester or weeks? How you select?
For aortic stenosis, after 25-26 weeks is the best time, because you can use a single balloon and then we can open the aortic valve. If we do it earlier, there is a chance of restenosis and re-balloon dilation may be required in later trimester. So 26 to 30 weeks may be the best time.
Very well, Shweta. Thank you for sticking to time. It's a very nice question. All these cases. I just wonder, was the maternal acceptance, family accepted for the intervention? Was it okay? Did it require a lot of convincing, or they were okay?
I agree with this. This requires counseling, and it is never a one-stage counseling. So we always explain the pros and cons of the procedure. They are often not the single procedure. After birth, the baby may require second procedure, need to be categorically followed up for development of Schoen's complex. So we always explain the natural history, the available data in literature, and we allow them to come back with their decision.
Very well. Yes, sir.
An excellent presentation, really.
Thank you.
Lucid presentation. I just want to know, this parvovirus B19 infection also causes hydrops.
Exactly, sir.
With severe fetal anemia and all.
Yeah.
Do you have any intervention for that? And what about the fetal tachyarrhythmias intravitreal interventions?
Absolutely. That's a wonderful question, and I actually missed the fetal tachyarrhythmia. Fetal tachyarrhythmia, the transplacental therapy is there, where you give the medication to mother and would control the heart rate of the fetus. There is a possibility of direct fetal therapy also. We have given intramuscular digoxin in atrial flutters, where the heart rate can be controlled. We have few cases of fetal ventricular tachycardia as well, which got controlled with the maternal medications. So this is about the fetal arrhythmias, tachyarrhythmias. Whereas coming to parvovirus infection, as you rightly said, the presentation is high cardiac output failure with anemia. So they need the blood transfusion to fetus, and with that, the hydrops is usually improved.
And about the congenital diaphragmatic hernia is also one of the important neonatal emergencies you manage.
Yes.
Where some people are doing tracheal obstruction,
fetoscopy induced, they do the tracheal dilation. Absolutely. They are all
for the development of the lung and all.
Yeah, absolutely. So these are all the procedures which are available, and usually that has been done with the help of the fetal medicine specialist, and the fetoscopy induced, they insert the balloon, they dilate the trachea so that the air trapping improved in the lungs and will allow the growth of the lungs.
Excellent job. You people are doing pretty good job. Fetal therapy is the new intervention.
One small comment. Actually, the hydrops, several times we were diagnosed as a parvovirus. Actually, in Telangana, patients coming from Nalgonda, Mahabubnagar, Khammam districts, they are predominantly rice eaters. So fetal beriberi is one of the things which we found recently for the past 2 years. Any unexplained hydrops, you give maternal thymine, usually it subsides. We estimated the maternal thymine levels, but the fetal thymine levels estimation, the ethics committee did not approve that, therefore we can't do that.
Is it the maternal thymine levels or RBC transketolase?
No. The maternal direct thymine levels is the now investigation of choice. Earlier, when we are MBBS time, we used to read that trans RBC ketolase and all. That's all gone. Now direct thymine levels.
100 milligrams?
You give 100 milligram BD because thymine is a water soluble vitamin. You can give as much as possible. Nothing will happen. It will come in the urine.
Thank you.
What is the dose of everolimus you gave for the mother, ma'am?
We gave 5 milligram, but we also monitored the everolimus levels. So it should be in the range of 3 to 10.
Route of administration?
The oral, maternal oral. And we did cord blood sampling of the feet of the newborn when he got delivered. And it was also in the range of treatment, therapeutic range. Like if we take the normal newborn's everolimus drug level should not be detectable. So we did cord blood sampling and it showed that it was in the therapeutic range that suggested that the everolimus has got transplacental transfer. Like if you give to mother, it will transfer to the placenta to the newborn, to the fetus.
No side effects.
No,
To the mother, no side effects because we give only, like in drug-eluting stents, to my knowledge, it's only in microns, which is being
absolutely. So
then
it needs to be
you're
monitored.
giving milligrams.
Yeah. It should be monitored like liver function tests. There is a protocol for that. It should be monitored very carefully. The mother should not suffer with the side effects. Therefore, the drug level monitoring of the mother is very important.
Okay, that's fine.
Like
Thank you.
oncologists and all who give for neurotuberculosis, they monitor drug levels. So it's very important to monitor.
Just one point. BAB can be done after birth also. What are the red flags we decide that fetal intervention is required in this AS? That is the setting of fibroelastosis or what? Because LV is also slightly underdeveloped as compared to RV. So how you decide whether you have to intervene in fetus life rather than going BAV after birth?
Yeah.
Because there's one procedure very important.
Yes, so just mere presence of aortic stenosis is not the indication. Reversal of foramen oval flows, development of endomyocardial fibroelastosis, severe ventricular dysfunction, development of mitral regurgitation, and where you find that LV has just started shrinking, altered mitral valve, Doppler ductal flow are the indications.
Thank you, Shweta. Very nice, very lucid presentation. For short of time, we'll go. We have Dr. Sushil Azad, who's going to talk of closure of large ASDs. Sushil Azad is a very senior cardiologist from Delhi. He's now at Amrita Center, Kochi, and he's going to talk of large ASDs, from fetal intervention to large ASDs. Good to hear. Yes, please. Dr. Sushil Azad's presentation.
At the onset, I'd like to thank Dr. Srinivas for giving me this opportunity. And thank you, Edwin, for allowing me to talk first because I think I have to leave after some time. Can you please get my presentation? So what I'm going to talk about today is the ASD device closure in complex and large ASDs. What are the technical challenges and how we overcome those challenges? So whenever we are deciding about intervention in atrial septal defect, the decision is primarily based on the anatomy. What is the size? What are the margins, which is the most important factor? And how many defects are we going to close? Are there two or there are multiple defects? Along with that, in adults specifically, the comorbidities affect the decision making. What is the age? What is the LV function? And last and most important is the operator experience. So sometimes we do face situations where we need to adapt different strategies depending upon the anatomy of the defect. So in this talk, I'm going to discuss what are these technical issues and how we overcome these challenges. So very large ASDs. So is there any definition for that? Actually, there is no strict definition for to define this is a large ASDs. Literature says more than 25 millimeters is the large ASD, more than 35 is very large ASDs. But apart from the size, the factors which are taken into consideration for successful device is the margins. What are the margins? Even a 20 millimeter defect with deficient margins can become technically challenging, will be large. The other important factor is device versus body size. We deal in pediatric patients, so the size of the defect versus the body defines the size. So a 15 millimeter may be a large defect for a 10 kg child and may not be a large defect for a 20 kg child. So that also we have to take into consideration. So margins, as I said, is the most important deciding factors. So assessment of margins is the key to decide whether this patient is suitable for device or not. So how do you define adequate margins? Any margin which is more than 5 millimeters is adequate, but with increasing experience, even 3 millimeter margins can be taken up for the device. Sometimes in the absence of atrial margins, we use atrial invagination or the aorta to support the device. So assessment of margins is the key. In pediatric patients, transthoracic imaging suffices, but in adults, you should always do TE to assess the margins, because by the assessment of SVC and IVC margins is very difficult on a transthoracic in adults. So TE is mandatory. So bicable view or basal long axis view on the TE is for the assessment of the SVC and IVC margins, which is the key. 4 chambers gives us the atrial and the AV septal margins. Absence of deficiency of AV septal margins is, a contraindication for device closures. So this can be assessed using a 4-chamber view. Basal short axis view gives us the aortic margins and the atrial margins. So these are the examples. We clearly see complete deficiency of the atrial and AV septal margins, deficiency of the atrial and the aortic margins, and IVC margins. So assessment of margins is the key for deciding whether this patient is suitable for the device or not. So this is an example for a particular defect. Though the defect size is only 29 millimeter, but if you look at the device sizes, the margins, the IVC is only 3.5, atrial is 4 millimeters. So deficiency, the incomplete deficiency of the atrial or IVC margin, this particular case, although the size is only 29 millimeters, can become technical. You may have to adapt alternate strategies for successful device closure. So whenever we have assessed the rims, we need to look at which particular rim is deficient, or is it single rim deficiency, or there are multiple rim deficiencies. It's a combination of deficiencies. So we have to decide, and depending upon that, take a decision, and sometimes decide which modality, which alternate strategy we are going to use for that particular defect. So deficient rim is not, as a contraindication for the procedure. So there was a study which was published. So retroaortic, margin is the most common deficient margins. But overall success rate in these particular patients is almost 100%. It's only when the combination of deficient margins is there, then the success rate reduces. If more than one margin is deficient, the success rate reduces to less than 86%. So which rim is deficient? If atrial rim is deficient, it may not be a contraindication in alone. So you can use the atrial invagination to hold the LA disc into position, but our right upper pulmonary vein technique may be more suitable in these particular patients. But we have to assess if any other rim is also deficient along with it or not. If IVC rim and atrial rim are deficient, this is an absolute calling for disaster during the procedure. The chances of embolization increases in this particular subset of patients. SVC rim deficiency alone is not a contraindication, but we have to, don't oversize the device too much, so that it can lead to SVC obstruction. And right upper pulmonary vein technique in this particular patients also is more effective rather than usual technique. Aortic rim deficiency in our experience is the most common deficient margin, but is it a contraindication for device? No. The procedural success is almost 100%. There were initial red flags that it long-term may lead to erosion, but later studies have not proven that. So absence of aortic rim is not at all a contraindication of procedure. You will find that particular rim deficiency in almost all the cases. There was some risk of erosion which was flagged, but they also mentioned that there are certain red flags that once you are assessing the echo, if these things are present, you should be more careful. What are those red flags? Like if you have to assess the aortic margin in multiple views, like from 30 to 60 degree. If it is completely deficient in this complete range of motion during the TE, then it is a red flag. And if it is absent at 0 degree, that's a definite red flag. You should be more careful in these patients. Presence of malaligned septum is a definite red. If the malalignment is more than 15 degrees, it definitely tends to increase the risk of erosion on a long-term basis. And if the AC device that you have put tints on the transverse sinus, so here you can see if the margin of the device is tinting on the transverse sinus, there is more risk of erosion. There is a more chances that this patient can have erosion on follow-up. Malalignment of septum, you have to assess very carefully. If the malalignment is more than 15 degrees, your device is not going to be well centered, and this increases the chances of erosion. IV serum deficiencies, again, you have to assess the IVC like aortic in multiple views from 90 to 120 degree. So whether it is completely deficient, which means from 90 to 120, if it is completely deficient, the chances of success rate are far less. If it is incomplete deficient, some amount of IV serum is there, like 1 millimeter, 2 millimeter, 3 millimeter, or if the deficiency is less than 30 degree, the chances of success are there, though less as compared to the presence of IV serum. So in this particular study, it was they included the patients with IV serum either incompletely deficient or completely deficient. So whatever the 50 patients that failed had complete deficiency, and the defect was also more than 38 millimeters. So in incomplete deficiency, the success rate was far higher as compared to the complete deficiency of IV serum patients. So now whenever we have assessed, the other is the approach of the, when we are deploying the device, what is the angle of the approach? That also, even if the margins are adequate, you may find that the device keeps coming back into the LA. So what do I mean by that? Whenever we are deploying the device, the LA disc needs to sit parallel to the atrial septum. If it is coming parallel, the chances of success are far more. So this is what I mean. So if you look at it, the LA disc is coming parallel to the septum. Once it is parallel to the septum, the chances of it holding on to the LA side is far more. Whereas this is the example, the usual technique, we place the sheath in the left upper pulmonary vein and subsequently release the LA disc, get it aligned parallel to the septum. Once it aligns parallel, you release the RA disc. So this is the usual technique which most of the time works. But what happens if the angle of approach is not correct? The angle is such that the upper margin of the LA disc keeps slipping back into the RA. So how do you tackle these situations? So this is where the alternate techniques come into place. So what are the alternate techniques? There are no fixed rules. You can use whatever technique that you are comfortable with. So what are the alternate techniques? You can use the left upper pulmonary vein technique. The left atrial disc is placed deeply into the left upper pulmonary vein. You can use the LA appendage approach. You can use the right upper pulmonary vein approach, or most commonly used is the balloon assist technique in such situations. So what is the basic principle of all this technique is that you are trying to get the LA disc parallel to the atrial septum. Once it is parallel to the atrial septum, then subsequently you can release the RA disc without any problem. And this is best visualized in LA with cranial 30, where your septum is, you can see the complete septum in totality. So doing in AP or in any other angulation doesn't give us that liberty. So this is the example where, the left atrial disc was positioned in the left upper pulmonary vein, and subsequently once it aligns parallel to the septum, the RA disc was released. So one person has to hold once you are releasing the left atrial disc, the one person holds the sheath so that it doesn't fall. Once it has aligned, then you release it quickly, it usually falls into the place. So this is an example where the left atrial disc was, invaginated into the right upper pulmonary vein LA junction, and let it take the shape. And once it takes its shape, one person keeps a little push. Once it takes its shape, you rapidly release the RA disc. It usually falls into the place. So this is another example where, the LA disc was keep pushed at the pulmonary vein LA junction, and once it has taken its shape, it's aligned to the septum, you release the RA disc. So this is the example of, release using left upper pulmonary vein technique, where the LA disc is completely released in the pulmonary vein, and once it has released, you rapidly release the RA disc and give a gentle tug. The LA disc falls into the place. This is an example of using the mitral valve technique, where the LA disc is released around the mitral valve. There may be some fall in blood pressure because it obstructs the flow, the cardiac output. But usually, as you pull back, the LA disc aligns to the atrial septum, and you can release the RA disc safely. Now, the most commonly used technique, which was described by Dr. Bharat Dalvi, is the balloon-assisted technique. The balloon, what balloon does is suppose the LA disc, and it decreases the space in the LA. So it allows the LA disc to take its shape, and once the LA disc has taken its shape, you release the RA disc, deflate the balloon, and remove the balloon and wire before releasing. So this is an example. You can use a spherical balloon. This is an example of using a spherical balloon, and you can use a cylindrical balloon also. We don't have spherical balloon nowadays, so we use cylindrical balloons. So you really inflate the balloon, release the LA disc, let it take its shape. Once LA disc has taken its shape, you release the RA disc, subsequently deflate the balloon, and see whether the device stays in the position or not. Once you have checked using T, you remove the balloon, remove the wire, and then check again the position and then release the device. So this is another example where the balloon assist technique was used for the So once we are doing all this maneuver, we have to be aware that sometimes, the device can unscrew. We have to be aware of that because the procedure usually takes a longer time. You have to be aware the clots can form in the sheath can distort. The best way is if you have done 1 or 2 attempts, best is take it out, reposition, flush the sheath, reposition, and then try again. The other important issue is lack of femoral access. You have some certain situations like interrupted IVC, or there is IVC thrombosis, or because of some reason, injury or surgery, you don't have femoral access. So right interjugular vein approach can be used for the ASD device closure. So to conclude, isolated rim deficiencies apart from the AV valve rim deficiency is not a contraindication for device. But a combination of IVC with posterior rim, you should be careful. If it is completely deficient, you should not take up the patient for device closure. Rest all deficiencies you can tackle with experience with using alternate techniques for doing device. ASD, as we know, ASD is the standard of care, but there is no fixed formula. Versatility of the self-centering device helps in such situations. Absence of IVC and combined IVC and aortic rim deficiency is a recipe for failure. T is mandatory whenever you are encountering a complex procedure. Better to do under GA. Put a T. Look at the imaging more carefully before, during, and after deployment, and that helps in increasing the chances of success. Thank you.
Thank you. Sushil, it was a pretty illustrative, good talk on a complete area of how you tackle difficult and ASDs without REMS. Any questions?
Dr. Srinivas Kumar.
Many of us were not doing procedures regularly, but sometimes forced to do because of various reasons. Little oversizing of the device because it doesn't slip, it shouldn't embolize. What are the downsides of that? Up to what extent oversizing allowed? In adults, there is no problem. IAS length is not a problem, but the stretch of the IAS on with the device, it could lead to some trouble. Can you throw some light on that?
Yeah, in pediatric age group, we usually don't go by like weight. If the weight is around 10 kgs, we don't usually, it's 1.5 times the weight of the patient. We don't try to use a device size which is more than 1.5 or maximum 1.6 times weight of the patient. Rest in adults, we can always check the septal length. Usually the LA and RA are significantly dilated over a period of time. So up to 50 millimeter device also can be.
No problem even if you oversize a little.
Oversizing specifically if we are dealing with deficient rim, specifically the aortic rim deficiency, you should not try to oversize it too much. If it is a malaligned septum, don't try to oversize it too much because it can, impinge. The LA disc can impinge into the transverse sinus, it increases the risk of perforation. In atrial rim deficiencies, also try not to oversize too much. It increases because the lower end compresses on the AV node. Chances of complete heart block also increases in such situations.
Thank you.
There is a small risk of erosion, they say. Nowadays, we don't hear much about erosions, but when you oversize, obviously it's a quite subjective. You can keep on oversizing and be successful, but then end of the day, it might get into trouble. Nowadays, we don't hear much, but then the erosion might be a risk if you keep oversizing so much.
Specifically, when we are dealing with malaligned septum, complete deficiency of the aortic rim from 30 to 60 degree. Those are the cases we should, be little careful. So assessment of the aortic rim and IVC rim is not in one view, like we try to do it in 45. Actually, it is from 30 to 60 degree for the aortic rim, and for IVC from 90 to 120 degree. We should try and do that. You will definitely find some amount of rim there, and that gives you more confidence.
What are the chances of atrial arrhythmias following the large device closures as well as complete heart block?
As I said, complete heart block, definitely. If the atrial limb deficiency is there and if you oversize it too much, the chances of heart block are there. Atrial arrhythmias usually happen. Some amount of ectopics we always, see immediately post device. We are, if we are dealing with, floppy septum, or there is, the septum was aneurysmal because the device tends to, but usually it settles down in the next 24 to 48 hours.
Thank you, sir.
Sorry?
Sushil, it's written that what's the best way to deploy the device, whether it's PA, LEO or LEO cranial?
We have never done in any other view except for LEO cranial. In that view, the septum is, you can see the whole septum and you can see the LA disc coming parallel to the septum. The aorta is above, the AV septum is below. So you can see, even sometimes notice that the aortic rim, you have missed the aortic rim. It has, prolapsed into the right atrium. So in that particular view gives us a lot of confidence. I know most of the people down south use the AP view. I have never done it in AP view. I've always done in LEO cranial. It gives me I can see the alignment, whether my LA disc is coming parallel to the septum or not. It gives me very much confidence that it is coming parallel. It's okay, I can release it. Sir, I have no experience with sinus venosus defect, unfortunately.
I think I'll just give a comment. I think it's basically you have to confirm under transesophageal echo or transthoracic echo. It's like you do transseptal puncture. Many people, they do AP lateral, some they do RAO view, some do LAO. Similarly, the operator, how he understands the interatrial septum configuration is essential. Most of the people worldwide, they use the LAO for the deployment, but many, including us, we also use the AP view also to deploy. So it's not hard and fast rule, but how you used to deploy the device is
understanding of the understanding of the anatomy of the septum in the PA view or in the LEO cranial becomes important because
Sushil, there's one more question. What about floppy rims for device closure? Like rims is more than 5 millimeter.
Yeah, that is why. So the important thing is to, in one view it may appear floppy, but if you rotate your probe, T probe, it gives you might find some thick margin there. So try and assess the size of the defect starting from the thick margin to thick margin and then decide upon the size. This is what I usually do.
It's a bit of subjective. What is flimsy, what is thin is a bit subjective. So you go by your experience. You slightly oversize by 2 or 3 millimeters. That's all I would do. It's very aneurysmal. You might go even more beyond that. That's all.
Like the case that we saw in the afternoon. I mean, the person who showed us some complication where the device ultimately embolized into the aorta. In that particular patient, if you look at the margins were all floppy. And he just from 10 millimeter defect that he measured, rest the margins were floppy. So he measured the defect, actual defect size was 10 millimeters. So he just oversight by 4 millimeter and 14. It embolized. And subsequent to that, when they rechecked the T again, that floppy margin was not at all seen. So they ultimately had to put a bigger device, after retrieving the older device. So you have to assess in all the views actually. So it's not one view like 4-chamber only will show atrial and the AV septal. The other views, you may see some thick margin based, depending upon that,
Sushil, many of the people may be interested in knowing one point.
Sure.
Do you regularly do balloon sizing? or what subset of population you still practice balloon sizing? I want that answer to educate.
So we have not done balloon sizing. If we have doubt about the size like floppiness, we put color, sometimes measure the color size, but we have stopped doing balloon stop flow technique that was initially used, primarily because it overstretches the defect.
Yeah.
So what it does by overstretching, you tend to oversize the defect device size subsequent to that more. And that oversizing specifically in pediatric population is troublesome for us, because that increases the risk of complications, like it may impinge on the AV valve, it may increase the risk of perforation, it may increase, the risk of arrhythmias in these particular patients. So we have stopped doing that. If we are worried, apart from 2D, we put color and check the color size as well, and subsequent to that, we decide what size of device we want to put.
Okay, thanks.
Hello, excuse me. How much oversizing allowed? Oversizing 3 to 5 millimeter oversizing is allowed.
That again, if you are talking about a pediatric patient, you don't want to oversize too much. So if the margins are good and it's an oval defect, I don't oversize much. Say 2 millimeter. If it is a 10 millimeter into 8 millimeter defect, I will put a 12 millimeter device because it's an oval defect. So that can fit. But if it is an adult patient, you can usually oversize by 4. If these margins are floppy, then I oversize by 6 also sometimes.
In case of multiple SD, what should be the distance between two consecutive SDs?
Sorry?
In case of multiple SD, so what should be the distance between two consecutive SDs?
7 or more than 7 millimeters.
I think this should be the last question.
Yeah, I think we'll stop the questions because a lot of time lag behind. Thank you very much, Sushil. Really wonderful and very lucid. Now, may I request Dr. Edwin to talk about the Konar MF device, concept to reality, enclosure of different defects. Actually, Dr. Srinivas Kumar initially thought of having this talk. Then he said that he should come from other people to validate the device, whether it is really useful or not. So, therefore, I think he himself has chosen Edwin is the right appropriate person for this.
It's a pleasure to talk to you on the Konar MF device. It's one of the only device came from in our Indian side, because we talk about innovations for like the last probably almost a decade or more. I don't think in pediatric cardiology, and I don't go into adults much nowadays, but we haven't had anything new come up except that sinus venous ASD. Somebody spoke about sinus venous ASD. If I have time, I'll speak about it. I regularly do sinus venous ASDs. But other than that, and some transcatheter fundants, and the device, it never, only from India, we have Dr. Nageshwar come up with this idea and design. And for the last 15 years, there's the one and only major development in the device and in structural and pediatric interventions. But as we said, that is, even though the science and technology has moved in leaps and bounds, we haven't had any major changes in the pediatric cardiology because of economic reasons probably. I'll probably go faster since a shortage of time. So this design is quite unique, and then probably you have almost like if adult cardiologists, most of your adult cardiologists, you have a regular ADO1 device, the regular PDA device. And we have heard about the ADO2, which has a moving part, and probably almost combined both the good things of both the devices and came into one, in which you have a regular, our conventional PDA device on one side, and you have a tiltable disc of equal size on the other side, which is softer. And then this helps in using in these devices in multiple locations. So it comes in different sizes from the smallest size 5.3 to 14.12. Another improvement here or innovation here, it came as in between numbers. We had only 4, 6, and then you have 8, 4, 6, 4, 8, 6, and 10, 8. Here you have even numbers also, 7, 5, 9, 7, 11, 9, 11. So if we can get into even smaller kids, we can utilize this device. And then this have PTFE membrane beyond 8.6 device. From 9.7 devices, you have the PTFE. The occlusion rate is better. But in the smaller devices, they have removed it because you can go through even smaller sheets. And you have the major advantages include it can be done through a smaller profile, makes it go through a smaller sheath. Up to 6.4, it easily goes through a 5 French guide catheter, which everybody is most used to. So it can be utilized in many scenarios. It can be deployed from either side. most of the devices have only one screwing area on one side. Here, both sides are different, and you have screws on both sides, so you can deploy from either side, from venous side, arterial side, either of these. And retrieving also is quite easier. Probably the unfortunate scenario, you lose a device. Again, the screws protruding out marginally, and retrieving also is equally easier. So the common indications, as you all know, it is basically designed for a ventricular septal defect and a PDA probably. But then almost any structural thing you find, you can utilize this. And those who are doing structural, you should have this device in the shelf, without which you should not be doing pediatric interventions as of now. Probably I will just go through a few case scenarios in which this is particularly useful, because a routine PDA and VSD, anybody knows and anybody can utilize any device, and MFO could be equally useful. But I'll go to specific scenarios. I think this not playing, I cannot touch it. It's a smaller kid, an 8-month-old, 6 kg. Actually, this was a kid who was referred for surgery. I think this is not moving probably. So no, I think so. Okay, so it was a probably bigger device, which actually the patient was advised surgery in another center, because I've done the device for the mother, probably getting older, because she came to me bringing a grandchild. I mean, the grandmother brought to me. So I waited for another month. He came to me around 5 months. So waited and then went ahead. You can do an angiogram. Nowadays, I think many people are moving away from doing angiogram. But then when you're starting off with VSD devices, definitely should do one. But when you're trying with these biggish devices, unless you give huge amounts, you go and profile it very well. You take the distance predominantly based on the echocardiogram. And then nowadays we gain cross from the venous side. So I'm not going through that because we are focusing on the device here. We cross from the venous side, from the IVC, cross the larger defect is quite easy to cross with an RCA. Just go in, it goes in. And you can use the roadmap as the angiogram as a roadmap. Go in, put a sheath in, and deploy the device. You can see you can leave that PDA, the regular PDA end of the device is kept on the arterial side, on the LV side. So it's more stiffer. And then you wait, it slowly falls into the VSD area, and then you push out the other device, the other part of the device, the RV disc. So this, and then an angiogram to make sure the person is okay. You see how beautifully the LV is seen, because the shunt is gone, the large shunt is almost moderate pH, and the person is good, and then you can release it, and then it gives you a beautiful result. So in this selected subset of larger devices in smaller kits, this is softer devices tend to be easier. I never had any heart block, which used to be a major concern when we started off doing the perimembranous asymmetric devices. I don't think the younger generation may not know about it. And give you another example here when it's useful is an older patient, an 18-year-old kid, around 8 to 10 mm defect, is a moderate size defect, LV is dilated. And then I tend to do with an ADO1, is an adult patient, probably gets cheaper to an ADO1 device. And here you see, I just, sorry, it's gone, and it comes the second one, you deploy the ADO1. Here's a larger defect which is partly restricted by the STL aneurysm. So STL many a time may not hold that ADO1 device. So when I did deploy the device, it was good. I asked my colleague to have an echo. By the time she couldn't find it, then I know that it's already popped out into the RV cavity, into the RA actually. So then I take, actually the 1412 is the biggest ADO1 and an MFO device. So it was like, it looks crazy, like with the same device, it is softer on an adult patient. So, but then I go ahead and put a MFO 1412 in the same patient. And then you see there's a minimal leak because of it. Initially, it was pulled also, but it went off later because the STL may not be able to hold the stiffer device. So this is softer device, makes it more easier to hold it, and when you get a good results. So this is a thing which utilizes the device for an area in which even adults also. I'll give you a third example again for a VSD. It's not a very big one, small to moderate size defect. Here, I tried a usual routine way of putting it from the arterial side. I do a F53 MFO from the arterial side. If you look at carefully, you see a whiff of aortic regurgitation there. Say I put it in the routine way, in the conventional way, with the ADO1 type on the LV side and the smaller, thinner frame on the RV side. So I change over, cross from the RV side and reverse the device and put in the reverse way. You see the thinner, smaller one is on the left ventricular side. I do an aortogram, it is clean, there is no AR, and release it as patient is doing well. Almost a year I've done that. So these are the specific modifications you can do. It can be quite useful when you use this MFO device. And you give you other scenarios in which almost any scenario you can use it. Here is a 5-year-old kid who came with a large coronary fistula. You can see quite tricky. I use a regular method of making an AV loop, tracking from the RV side. It was not tracking. Then I switched over and used a regular 6 French guide, went all the way in with two PTCA wires and went in all the way in, and then deployed a 5.3. This one I used a 5.3 MFO device. So here you can use either a vascular plug or MFO device or an ADO2, but MFO consistently goes to the sheath, the guides which the recommendation. Many a times ADO2, if there's such a big curve, it may not track. So it's always safer to have an MFO device. Here's a final position here. There's a minimal leak, but then by the next few days, it goes off. Here, this is a smaller one. It doesn't have fabric, so it takes somewhat longer time to get the clot formation happening. Here's another example which you may not be regularly seen in other cardiologists because a Fontan fenestration is a pretty larger fenestration. You can see here at the device in this playing the other way around. I put in a 9.7 MFO device in the Fontan fenestration, and it does a good job. And here is another case in which is a regular right RSOV. I do it in a routine way. You use an AV loop, and then somehow it is coming into, if you see it, it's just coming below the tricuspid annulus. So when I try to take an AV loop and then put in any sheath, nothing is going. Even guide was not tracking. It was doing it somewhere in Calicut, I think. So somehow they didn't have it, the MFO device. I tried to wait it for half an hour in the lab to get an MFO device. So I switched over from the arterial side itself, put a guide in. I put a 7 French guide, went all the way into the RV cavity, and then you deploy the MFO 10.8 MFO device, and then you get a good results. But be a bit careful here because you're doing from the arterial side. Make sure you should be properly sized it because it can run away into the RV if you are not careful about the sizing. So again, that indicates that it is quite useful in many scenarios. I think one or two cases I will stop here. Here is another, it's a rarer thing, an Abernathy malformation, which is not very common. I think Nagashra has done a lot more in this southern part in Kerala. We haven't seen much. I've done 2 or 3 only. Here's an Abernathy malformation where there's a portosystemic shunt. It bypasses the liver. So here you see there's a one catheter came from the IVC, goes into the portal shunt, it's a Abernathy malformation, and the other one coming from the femoral vein from the lower part. And then we go in, and here again, it is quite useful to have a, you have a MFO device here doing a good job with a good result. Here is another scenario. I think this is probably is not an MFO, but then I think I mistakenly take another one. But here is a case of paravalvular leaks, which I routinely use either an AVP or a MFO. This is one is an MVP, but then again, this is quite good because beyond 8.6, you have a large paravalvular leaks. I prefer MFO devices because it has a fabric. It causes almost immediate paravalvular leak closure because otherwise it tends to give trouble because of residual flow causes hemolysis. So such a lot of sitting, I think, will conclude here. MFO device is certainly a multifunctional device, quite useful in many scenarios. It is compatible with alternate delivery systems coupled with downsizing of the down sheath, underscores its versatility and applicability in clinical practice, and is a champion device and here to stay. Thank you.
Thank you, Edwin. Absolute multitude and galaxy of cases that speaks volumes about the device. I must say thank you, Nageshwar. It's lovely cases you've seen all different. And one thing I want to say this, if you see the 4th slide that Edwin put up, the profile is very low. You can go to 4 French, 5. Yeah. That's the biggest advantage of this device, that you don't need bigger sheets. See, in pediatrics, you always want a smaller sheet, small. The profile is very important. This can go through absolutely smaller, and the results are absolutely fantastic. My only thing was the coronary AV fistula that you put. That I thought we should put a bigger device, and anyway, maybe it was too tortuous for you to be going.
I didn't want to stretch through the corona. It was a huge 2 full circles I have to take, so I didn't want to put.
And like Dr. Edwin said, that device does not have fabric, so it will take some time for it to thrombose. Ultimately, it will thrombose. Very nice, Edwin. Thank you so much. Very lucid.
Thank you, Edwin. One small correction of Nageshwara's comment. It is not that I wanted to hear whether it's working correctly, not for others. We are extremely happy and thankful and proud of you, Nageshwara, for this device, and really congratulate you for this. What I wanted to hear is, now the time has come where others should speak about your device.
Yeah, absolutely.
That's what I meant, not to elevate your device.
No. I think it is very essential to listen from others to see the real problem, so that MFO 2 and 3 are coming in future.
Okay.
For the post MIVST and other things.
Great.
So that's the reason
and
why.
Even now it is being used in Europe and other places also. No, a lot of.
At this point of time, 42,000 devices are deployed in the 96 countries.
Great. Congratulations. Thank you.
Pardon?
So what is the innovative idea, prevention of the heart block with the membrane type of PSD there?
We have a significant reduction in the era in which asymmetric devices were used. That's an era in which asymmetric devices were used, but you had the very high incidence of heart block. But with these devices, I haven't had any heart block till date. I mean, I'm not a very vigorous in closing small VSDs. I tend to close larger VSDs. So maybe I don't know others' experience.
I think it is not only the device factor, patient factor also is important. Myself and Dr. Narasimhan sir, we studied VSD before closure. There are multiple types of conduction pathways identified. In that type D and E, where they closely follow the posterior border of the VST. Those are high risk for the heart blocks. But however, the earlier devices were having shear stress and clamping force was very high. So the 2 millimeter, 3 millimeter distance was rubbing the conduction system. Here the MFO has got a length, you can stretch up to 12 millimeter. So you don't have clamping force or shear stress. The only one case report happened so far in the literature from Majni LV group from Malaysia. They used it in a Down syndrome baby with inlet VST. The ECG was showing left axis deviation. Probably I won't do when there is a left axis deviation. They did and they had complete heart block. Otherwise, so far, no official reports as such. Thank you.
Last speak, Dr. Jairangan is not here. So we'll have Dr. Nagesh Rao speaking. After all these talks, you'll have very nice talk. This is on. We are seeing a lot of adults with grown-ups with congenital heart disease and a lot of adults with CHD. So we are seeing more and more. So he's going to talk on contemporary transcardiac interventions in adult congenital heart disease, the challenges, strategies, and outcomes. We're waiting here. Over to Nagesh.
Thank you, Nitin. Thank you, Dr. Srinivas Kumar and other organizing committee members. So if you look at the adult congenital heart disease, that is congenital heart disease in adults or grown-up adult congenital heart disease, GUCH, all this happened because the surgeries started in 1950s and 60s. So you have significant number of population who underwent surgeries in the early life. Now they became adults. Some will have a residual problems. Some are untreated. Some will have complications. Some will have various other problems like ventricular dysfunction, pulmonary hypertension, arrhythmia, so on and so forth. Who will treat this? There is no structured adult congenital heart disease program in the country. So therefore, when we collaborate, we'll have a good patient outcome of all these patients. The predominant challenges are physiological challenges, some residual pulmonary hypertension, ventricular EDP will be high, the systolic dysfunction, and anatomy is very complex. Sometimes a congenital corrected TGA, single ventricle with palliation, so on and so forth. And patients will be at various natural disease state. You will have the presentations. How to deal these problems is a major issue. So the predominant challenges, as I already told you, pulmonary hypertension, ventricular dysfunction, arrhythmia, they are on oral anticoagulants. Some may be having a thrombotic state, pregnancy, and occupational disorders. All these should be addressed in this. The common problems which still you get is atrial septal defect with pulmonary hypertension, VST either operated, unoperated, RVOT conduit obstruction, post-operative conditions, pulmonary wall leaks in tetralogy of Fallot, and branch PA stenosis. As Edwin has shown that Fontan Bayful leak, which is a Fontan leak, which is causing a desaturation. All these things should be addressed properly. So structural, valvular, vascular, and all these things will have different strategies. I will go through 4 illustrative cases. You all can see that. This is a 44-year-old gentleman with a history of antival MI, delayed thrombolytic therapy, aneurysm happened, LV aneurysm, on multiple medications. JVP was here, heart failure, and you can see the ECG, poor progression, cardiomegaly is present. The I don't know whether some problems are there with this. I am saying that. So that is actually, somebody click on that actually. You can see that I can't click here. But believe me, that is a mid-LAD total obstruction with a poor collateralization, and you can see the LV apex, it's an aneurysm, and there is a large atrial septal defect. You can see 0 degree, 45 degree, and 90 degrees. So what do you do with this? You want to close this, you want to medical follow-up, or you want to just do a device closure and leave it, or any suggestions? So patient is quite symptomatic. He goes to class 3 and comes back with medications and all. This is the realistic scenario we faced, and we discussed it almost like 6 weeks to 2 months. Then we thought we'll do differently. So did a cardiac catheterization. You can see that QP by QS is 5:1. Why 5:1 to that? It's a definitely large AST, and also you have both the systolic and diastolic dysfunction. LA pressure, LV EDP is very high. So in this scenario, it's a, if you close that, he may develop a pulmonary edema. So are we ready for that? So how to deal this? So we thought we will discuss among ourselves. We prepare the patient. We do systematically. So what we have done, you can see that the device is fenestrated significantly and deployed from the upper pulmonary vein. And unfortunately, a very big device, it formed a cobra shape and managed that cobra shape, waiting for some time and pushing the device back. You can see that. So big device using the 14 French Mullen sheath. And patient developed a flash pulmonary edema. Inspired that flash pulmonary edema. To prepare these patients, you have to admit 2-3 days before, give aggressive diuretics, inotropic support, ventilate them before the procedure, at least 1 hour before, and optimize the PEEP levels, and then do this kind. So we followed the same protocol. After that, we anticipated pulmonary edema and managed that furosemide and nitroglycerin and discharged after 2 days. This is the follow-up. The echocardiogram showed you can still see LA to RA gradient is quite significantly high. Now this is almost 6 years old case. I thought I'll present this is the appropriate form. He's doing very well, and he has a ventricular dysfunction. He's on beta blockers and AC inhibitors. So this is one of the illustrative case where you may come across these kind of problems. The take-home message from this case is balloon occlusion testing is very important to actually bring out the occult LV dysfunction, LV diastolic dysfunction. Several times, 70 years old gentleman, you directly put the device, he will develop flash pulmonary edema, you need to ventilate. So you have to do balloon occlusion testing, see the LV EDP, then do the strategy of fenestration and treat physiology, just not the defect. Several patients, they come to us actually with the PAH and all. Those patients also you have to do significant workup and do the oxygen study and take a call. So transcatheter treatment of coarctation of aorta, left side disease. This is very common. The ESC guidelines recommend covered stent in the recent timings when adults with severe coarctation with collaterals. What is atretic coarctation? You see several times that there is no antegrade flow at all. Over the period of time, the interruption is different. It's a ductor-dependent pulmonary systemic circulation, whereas atretic coarctation is over the period of time, there will be significant collateral flow. The antegrade flow will be stopped over the period of time, and you will have the fibrotic or very tiny antegrade flow, which you won't be able to see that. So in this setting, you have to have the workup, imageology workup, either rotational angio, what you are seeing there. Nowadays, not many people are doing rotational angio because your CT angio itself is extremely great. You can do AI-gated CT reconstruction in many of the cases and measure the length, everything, and imagine where you are going to put the covered stent. So a dual angiogram is going to be useful. Here you can see that dual angiogram here. So then you will get the idea how much of distance is there, how much of perforation you have to do, and identify the exact atretic segment and confirm the alignment. You need to have the multidisciplinary and surgical backup. Heart team should be informed and have the surgical backup, general anesthesia, radial, femoral, all sort of complications to be handled. So the first step is crossing the atretic segment. We generally nowadays using a CTO wire with a surgical cautery. You take a CTO wire, compressed probe we take and go from the superior and use the surgical cautery and snare it out from the descending aorta is the best approach rather than broken barrel needle and all. You will not have control over the mechanical perforation. That's why electrical perforation is much easier and snare assisted. The microcatheter guided one is going to be much more useful. Once you do that, in a coarctation of aorta, you don't need to do pre-dilatation, but whereas atretic segment, you may have to do with a smaller balloon so that your sheath can be negotiated easily into the transverse arch. So once you do that, a proper covered stent based on the length and the dia you have to take, and final check angiograms are important. Let's see one example here. You can see the rotational angiogram, a dual angiogram done there, and this person was having a significant hypertension. The important aspect here is subclavian origin is very close to the coarctation of aorta. So if you put a cover stent, you are going to take compromise on the subclavian artery. So how do you handle this? Any ideas? You have a subclavian artery. If you put a cover stent, left subclavian artery going to be sacrificed. I think it's a fairly okay. Many of the radiologists, they sacrifice the left subclavian artery provided your vertebral system is very good. You can accept that, but we did not opt for that. You have any idea what you want to do? So what we adopted, you can see that we perforated that first with the hard end of the thermowire, not to CTO wire. Now we actually adopted to CTO wire with electrical cautery, and we placed two wires, one in the subclavian artery, one in the transverse arch, and we took two balloons. You calculate the balloons for the desired diameter. We measured for the 16 millimeter diameter and put the two balloons in that. So the stent was mounted on the two balloons like this. You can see that 2 into 12 into 40 balloons and crimped onto one sheath. And you can see that the stent is being placed and flared into subclavian artery. So here subclavian artery is not at all compromised, whereas the atretic segment, whatever it is, addressed properly with the CP covered stent here. So that's going to be your own thinking how you can prevent that. These are common situations which you come across in the adult scenario. This is another interesting case. I think I impressed Srinivas Kumar in one of the meeting. Therefore, he asked me to actually talk about adult conjunctivitis. This is 27 years female, 21 weeks of gestation age, a single ventricle path, saturation was 80%. So any saturation lesser than 85%, fetal risk is very high. They will be having a miscarriage at 24 to 26 weeks mid-trimester itself. So how to address that? You want to improve her saturation or you want to do miscarriage? So the local people advised MTP, but they came for the second opinion. Myself and my colleague Dr. Shweta, we deeply discussed. We took second opinion also ourselves, and we thought we'll improvise the saturation. So how will improve the saturation when at that particular time? So we waited for 2 more weeks. At 26 weeks, we did the TE, and we found that there was a tiny antegrade flow. So we thought that it was not suitable for the TCPC, that is total cavopulmonary. She underwent already Glenn. We discussed in our meeting as well, and then we thought we'll do the stenting to RVOT, taking care of the fetus at 26 weeks. Usually they don't develop any kind of radiation related injury. So these are all various precautions we did. But here, most important thing is you reduce the frame rate, avoid the steep angulation so that fetus will be minimally irradiated. So all that, and you keep the lead upper and below. I'm sure that you are doing balloon mitral valvotomy in many of these pregnant ladies. I don't need to explain that. But since it's a rare case, we try to use the TE guided as much as possible. We avoided the angiograms, only very bare minimal angiograms we did. And we had to put the stent there. You can see the stent there. And the saturation improved to 88 to 92%. So these are the parameter, total fluoroscopy time and the air karma. All those things were very much acceptable as per the world norms. So after the procedure, very important, you have to keep the patient as some kind of wedging of the pillow and abdomen, reduce the aorta cable compression. Otherwise, again, maternal discomfort will be there. Fetal abortion or miscarriage may happen. All these precautions, and the patient delivered elective cesarean section at 34 weeks because we don't want to prolong till full term and then have again a miscarriage or IUD and all. So we actually accepted 1.4 kilogram and managed it very well, and child is doing very well now. I think 8 months old. So this is very important to collaborate, obstetrician, neonatologist, cardiologist, pediatric and adult cardiologist who has got interest in this kind of thing. Now you all must have faced more and more patients with pulmonary regurgitations where post-tetralogy fellow, earlier people used to do transannular gusseting. You cut the pulmonary annulus, leave the free PR, they will live with that for many, many years. Now RV is dilated, dysfunctional. They are progressing into VT, other arrhythmias. So these issues can be addressed by percutaneous pulmonary valve. The guideline showed that now it is actually not more than 160, 150, and people talk about RV, ESV itself. So a lot of valves, I will show only one with the interest of time. This is the free PR. MRI data showed that we had to do that. Nowadays we do harmony valve. This is one of the harmony illustrative case. We sent for the analysis. The analysis, you can see that they will check with pulmonary valve 22 and 25. So this is the patient who is suitable for 25 valve. They will give the landing zone also. So we go lateral as well as the RAO view. And you can see the harmony 2 valve and various steps. I'll just rush up because of the, I'm sure that you all must have had experience one type of valve, at least my valve in our country. This is the post procedure, absolutely no leak. And I found that recently the Harmony 2 valve is much more versatile and easy to operate. Our experience is only on 10 cases, which we found extremely great. So imaging is everything and which is critical for all these cases. The risk stratification we need to answer, we have to explain to the family before we do the procedure. What I have learned for past 25 years, treat the patient, not the lesion. Imaging determine the strategy. The physiology is more important in adults, not the anatomy alone. And work with the team, and every successful intervention should improve the lifelong quality of life. Thank you very much.
That was a great talk, Dr. Nageshwara. Any questions? The shortage of time should be. I think adult intervention should be, a lot of questions should be there, but then they are eager for the adult topics.
I think many of them are thinking that is going to be a little late. That's why they're not asking, but we congratulate for the excellent talk. And that's why he talks very passionately. That's why I requested. Thanks for conducting the session also, Naishulu. Thank you.
Conclude the session now, and we should say thank you to AC and Srinivas Kumar especially for giving this session, and thank you for all sticking for being for this session. It was very good. Thank you. We'll conclude. Thank you.
think after an interesting congenital interventions talk, now we come back to our regular coronary stuff, and then we have interesting cases for CTO interventions, and I also have good lectures on CTO, and then we'll have a post-bypass graft interventions complex PCIs. We have CTO experts, Dr. Pratap, Dr. Goel, sitting here will be dealing with it, and post-CABG, we have Marasolo-pharynx talk, which all of you are eagerly listening to wait. We are slightly behind the schedule, but I think we should catch up with time. So I request the next set of chairpersons to come over and panelists to come over, and then we conduct the proceedings. Who is there? Sanjay.
I was going to say, I'm sure I'm not going to be totally alone, but I have stalwarts on either side now. So this is going to become a good discussion. So welcome to CTO Interventions at ACVS 2026. This is a case-based session. To my right is Dr. Surya Prakash Rao, to my left, Dr. PK Goel, and to come up as well as they are available. We'll get right into it given the time, and introduce Dr. Reddy, who will talk to us about when calcium deceives, a resistant RCA CTO requiring extensive atherectomy and balloon granuloplasty.
Good evening, everyone. Thank you for the organizing committee for giving this opportunity. So this is an interesting case. So where I thought initially it was a CTO, so crossing was the difficulty, and later we faced the other issues. So patient is 65 years male, non-diabetic, non-hypertensive, and non-smoker, and he's having existential angina for more than 4 months, and ECG showed no ST changes and only poor RA progression. Echo was normal, and TMT is positive. Angiogram was done outside. It showed DVD of LAD and RCA CTO. This is the angiogram. LM was normal, proximal LAD mild disease, and mid LAD is having borderline lesion of 50 to 60. Calcium is there in the mid LAD. And this is the RCA. Proximal normal and mid is very tight with CTO and bridging collaterals and distal TIMI1 flow. And there are also retrograde collaterals from the left epicardial LCX and some septal collaterals also. So here the JCTO score was 1, calcium. We initially didn't have much priority to that calcium where it was not clearly visible. So we started doing PCI. We taken 6' shale 1 and I taken a run through wire. Wire went easily. We crossed the lesion very easily. Then we had taken balloon. I tried 1.5 and 1 and sequentially 0.75. Nothing was going. So then I reassessed the angiographic, clearly showed around grade 2 to 3 calcium, not tram track, but when closely observed, it showed reasonably significant amount of the calcium. So what's the next step? Balloon uncrossable. So we have to opt for atherectomy. So at the time, I got availability of the orbital. So I exchanged for the Viper wire by keeping the wire at the proximal end of the CTO segment. And started doing OA at 80k RPM, but it's a very slow runs, so we are not progressing very slowly. So almost after 10 to 15 cycles, so only minimal progression across the calcific segment. So patient also complaining of mild pain whenever we are engaging the CTO segment. So we withdrawn the bar in glide mode and checked the shoots to confirm the distal flow. So after a few runs, it's not further processing. So what we have done is we increased to 120k RPM because even we don't know the size of the vessel clearly. Looks reasonably good size. So I've done few runs at 120k RPM for few seconds, and there is a mild further progression distally. So after some more runs, nearly around 25 runs, it's not much way progressing. So based on inputs, I withdrawn the bar and try to pass the balloon again so that we had any chance, but still it's not going. So we again have to go for further more runs with the OA. Again, we started runs at 80k RPM. It's a very slow and very inch by inch, very minimal progression. So again, we had done some more few runs 120k RPM for few seconds and showed very minimal advancement. Finally, we reached up to the distal cap, but you are not able to cross even after multiple runs. Really, we are exhausted with that. Also, nearly 40 to 50 runs we had done. So we want to try other options, what we can do. So I came out of the bird. I exchanged the wire to run through wire because we tried over the wiper wire. It's not giving good support for the balloon to push. So we exchanged to the run through wire. And initially you can see the persistent tight stenosis there. So I taken 1.1 mm balloon and dilated that segment. And we are able to go till the distal cap, but you're not able to cross that. You can see the persistent tight stenosis. And finally, we started inflating, slowly increasing the pressures. We can see in the last view, run, where we are increasing to pressures. Finally, it resulted in balloon rupture. You can see in the last video. So then we taken 1.5 mm balloon. So it was going till to the distal cap, still not crossing. And I inflated there, it's not yielding much. So angio shoot still persistent narrowing. So I taken 2 mm balloon further to dilate the CTO segment. It's not crossing beyond that. And later I exchanged again to the 1.5 and to try one more time. So it reached to the junction and not crossing. And now at this time, it was inflating well. So I thought to increase to higher pressures, and finally it resulted in second granuloplasty. And we can see the last run, and compared to the fourth video, there is clearly giveaway of the tight segment at the acute marginal. Then I can 2 mm balloon. We can see in the second video where the 2 mm balloon is going easily after 2 granuloplasties. Again, further dilated with 2 and 2.5 mm balloons from mid to mid segment. Later, I tried to image it, but they are having problem at the time. So finally, I just want a good run to understand it. I done manual IVAS at this from distal to the proximal RCA. We can see here there is distal mild calcium with a significant fibrous plaque. And now we are coming to the very tight segment, distal cap, 360 degrees calcium. We got regional breaks in the calcium. And there are few nodules here. You can see small protruding nodules in the 6 o'clock and 5 o'clock positions in the CTO segment, mid portion, proximal to the tight portion. So 12 and 3.25 into 12 in the mid RCA segment. You can clearly see the good expansion of the balloon. So this is the final angiogram. Achieved reasonably good result. There is a problem with IVAS, whatever I use, so I am unable to do the post-standing IVAS run. And after the procedure, I had done this procedure in the late evening to night. So after the procedure, later shifted to ICU. After a few hours, patient developed angina, and ECG showed ST elevation in V2 to V4, but patient is not severely symptomatic and hemodynamics are stable. So echo was done, no new RWME, and the LV function is good. So tropi was sent, it was elevated, it started on nicorandil infusion and unfractioned heparin infusions. After a few hours, 1 to 2 hours, we can done the ECG again, the ST segments decreased and resolute, and the patient symptoms were also decreased. So I planned the check angio the next day. So this is the angiogram. The next day what we had done, LED was showing slow flow. RCA shoot was good flow in the RCA. So possible mechanisms of transient LED slow flow after RCA, CTO, orbital atherectomy. So extensive orbital atherectomy with repeated high and low speed runs generated a large burden of calcific microparticles, and granuloplasty fracturing the dense 360 calcium may increase distal particle embolization, and microvascular embolization leads to microvascular obstruction and myocardial ischemia despite a patent RCA. And endothelial injury also may happen from calcium modification triggered LAD-CVS spasm leading to slow flow and anterior ST segment elevation. And rapid resolution of these ST elevations with nicorandil and heparin we showed transient microvascular dysfunction rather than acute LAD occlusion. So extensive calcium modification may rarely produce remote non-target vessel ischemia through combined mechanisms of microvascular embolization and coronary vasospasm. And the time of discharge patient is good. Hemodynamic stable for the next 2 days. We shifted in from ICU to general ward. Patient was symptomatically free, ECG, no new changes. Echo was also good LV function. And I kept on DAPT and low-dose rivaroxaban for a few days and anti-angiolus at the time of discharge. So my take-home is severe circumferential and nodular calcium in CTO lesions can prevent device delivery despite successful wire crossing. Orbital atherectomy is effective, but heavily calcified distal caps may still remain resistant. Adjunctive techniques as balloon granuloplasty can be crucial when atherectomy alone fails to achieve lesion crossing. IOS is essential for identifying the calcium load and morphology for guiding optimal stent implantation. And complex CTO PCI with prolonged runs may trigger delayed ischemia and slow flow in borderline non-culprit lesions due to vasospasm or microvascular dysfunction. And prompt recognition and aggressive medical management can successfully stabilize post-PCI ischemic complications and avoid further interventions. So my understanding is if a low-profile macrocatheter cannot cross the calcified lesion, despite adequate guiding support and appropriate wire position, the lesion is generally too tight for the orbital atherectomy. So making ROTA may be the preferred initial modification strategy. And once a low profile can be crossed across the lesion, orbital may be considered provided the OA crone can be advanced safely. Thank you very much.
Thank you, Dr. Reddy. So that was an interesting case where you used a lot of different techniques to be able to gain distal vessel access. So I'm just going to ask about the, maybe one question for each case given the time. So approach to distal vessel access, how would you have approached the balloon uncrossable lesion in this type of a CTO case?
Yes, I think a pre-procedural CT could have helped you. You may be underestimating the calcium here. I don't say it's a great CTO, that then it's a calcific, maybe a neo channel, because we don't try with a run through via a real CTO. First point. Second thing is, what is the mode of atherectomy in this case? That's what we are discussing. Maybe you can have a ELCO also a good alternative in this type of balloon uncrossable lesions. And why not root ablator? This is one discussion.
So there's a question from the audience that says, why did you consider ROTA after the first cranioplasty? I might actually change that and say, why didn't you just consider ROTA up front? Because the purpose of atherectomy is a distal vessel access device, right? Like we live in 2026 now, where there's a lot of really good options to deal with calcium in vessels that are relatively low risk, which I think is almost certainly going to be a great talk.
Yeah, thank you very much. First of all, thanks for having me here. And Sanjog, I'll make sure I fit into the CTO agenda with the case here. Okay, so let's talk about SVG interventions. And I was asked to give some 10 commandments. Here it is. So these are the 10 commandments. So we'll kind of use this as we talk about SVG interventions. So here are 10 commandments to think of as we are looking at SVG interventions. The first one, I would say, know the graft, understand the biology. And I think this is very, very important because what I've seen is many people do graft intervention similar to that they're doing with native coronary PCI. It's important to understand the biology. What is the biology of SVG failure? The key concept I want to emphasize is vein grafts. Veins are not made to withstand arterial pressures, right? I mean, it's clearly in the venous system. The typical pressures are, 20 to 30 millimeters of mercury. They're not exposed to systemic pressures. So when you put them in a systemic circulation, you're suddenly subjecting them to an arterial systemic pressures. And typically, the vein graft undergo a process called arterialization. So initially, as soon as the vein graft is put in, seconds to minutes, there is arterial shear stress and wall stress. This leads to platelet adhesion to injured vessel. And many a times there is intraluminal and adventitial leukocyte migration to vessel wall, which typically takes days. And this migration of leukocytes into the vessel wall results in increase in release of cytokines, growth factors, chemokine, etc. Many a times, early graft failure is due to thrombosis, but as we see, this increase in cytokines and chemokines are no different than the usual atherosclerosis, and there is smooth muscle cell proliferation and accelerated atherosclerosis down the line. So in terms of graft failure, vein graft failure, pathophysiology-wise, if it is within the first month, and especially if it is within the first few hours to days, make sure that it's not a technical issues. I've had cases where there is kinking, there is suturing of that distal part of the graft, resulting in acute closure. There may be damage during vein handling, and the surgeons have tried different techniques to reduce this, but still there is no clear-cut answer for that. Or the graft may have been grafted into a distal target with this small and poor runoff, which can lead to early graft failure. The intermediate graft failure, usually within 1 month to 1 year, is due to intimal hyperplasia, the mechanism which we talked about. And late, which is after 1 year, is typically atherosclerosis. And we'll come back to that. Many of us are seeing patients who present late after 1 year. And the question is, what is the pathological findings of a plaque in the vein graft? If you look at a vein graft, and this is what you're going to see. You're going to see a lot of cholesterol crystals, atheroma, thrombus. And I'll come back to this thrombus, which is very, very important. It's not necessarily patients present with acute coronary syndromes, but even in patients present with stable coronary disease, there is thrombus in an SVG graft, unlike patients with, who come in with a native artery severe stenosis. So compared to native atherosclerosis, SVG atherosclerosis is typically diffuse, concentric, thin cap, large lipid pool, calcified, and thrombus. And I think this is very, very important to recognize that even in stable coronary disease, they can have thrombus. And so there is a risk of distal embolization and slow flow in these patients. Clearly, studies have shown SVG PCI, their angiographic success is lower, and in-lab complications, especially peri-procedural MI, is higher when compared to native coronary PCI. So the key thing is to know which SVG lesions to avoid PCI on. Some of the broad rules are, if the lesion is chronically occluded, try not to open that. It's likely full of that material that we talked about. If there is old degenerating graft, you can try to open it, but you likely will risk no flow or slow flow. If it is thrombotic throughout, these grafts can accumulate a ton of clot, and it may be very difficult, even with mechanical thrombus aspiration, to completely remove it. If you have no or poor distal flow, it may have already embolized, and you may not be able to establish flow despite opening up an SVG graft. And there is also some concern if the graft is occluded acute, or there is subacute occlusion. Typically, what you can do is wire and take a microcatheter distally and assess the distal graft and outflow. So the first commandment was to know the graft, understand the biology. So after you do that and you've decided you're going to do PCI intervention, engage with intent. Use supportive guides, and I think this is very, very important. Graft, whether it's a graft to the RCA or to the circumflex, know your supportive guides. And typically, as a general rule, I would try to use an AL or an AR guide for a graft intervention. I have a very low threshold of using a guide extension for these patients. And if you're doing any kind of CTO PCI, remember the graft adds to the length, and consider guide shortening up front if you're already starting with a retrograde CTO PCI via the graft. So you've used a supportive graft. What to do next? The key thing with graft intervention, as we saw the biology, it's full of lipidic plaque, cholesterol crystals, thrombus. It's going to distally embolize. The last thing you want to do is put a stent in and realize there is no flow. So the key is to protect the distal bed using embolic protection device. Here is an embolic protection device after an intervention. You can see, this is a filter wire device which is no longer available. You can see clear debris into this. So there was a lot of excitement when we saw initial images like this, and there were a number of randomized trials in the acute MI space which didn't pan out to be good. But the only place where embolic protection device has been found to be useful is in SVG intervention. There have been 6 randomized trials. All randomized trials have shown benefit in patients undergoing SVG PCI. and plaque volume and SVG degeneration are the strongest predictor of MACE. So despite this, despite every randomized trial being positive for SVG intervention, if you look at in the US, the amount of cases where embolic protection device is used, it's only in less than 25% of cases. One of the major reasons I have seen is lack of familiarity. Not a lot of people are doing a lot of intervention, and among the intervention to do, the SVG PCI tends to be very few. So they're not comfortable with using the filter device, but the data strongly supports the use. In fact, I was part of the 2021 ACCHA REVASC guidelines, and we said in select patients with previous CABG undergoing PCF and SVG, use of embolic protection device when technically feasible is reasonable. We gave it a class 2A indication to reduce the risk of distal embolization. So for me, when I'm doing an SVG intervention, I use embolic protection device. There are times when you have to think of when is EPD not required. So if it is an osteal lesion, most osteal lesions are fibrotic, so you may not need it. If it is ISR, I have a small caveat that sometimes ISR could be due to neoatherosclerosis, and if it is neoatherosclerosis, use a filter device. If it is neointimal hyperplasia, you may not need it. If you have focal lesion, again, may not be, but consider it if you can. And distal lesion, of course, if you have no landing zone, you have no options of using embolic protection device. Okay, moving forward, if you have a supportive guide, you've used a distal protection device, and what to do next? I would say, imaging also is really your ally. So learn from imaging. IVUS and OCT is your ally. Many a times you see things, we talked about the concept of arterialization. So veins are not made to withstand pressures. So when they put them into systemic circulation, they tend to harden. So here you see on OCT, concentric calcification throughout. And the way I use imaging is, it's no different than native vessel PCI, but you're going through the same MLD max if you want to, but more looking at plaque morphology. Is it fibrotic? Is it calcified? Is there a lot of lipid pool? Is it thrombotic? Because that can change the way you manage it. Here you see concentric calcification. There was an area which was which had a lot of fibrolipidic plaque and atheroma and plaque rupture and thrombus. So imaging can really help. The fifth point to consider is prep the lesion, debulk, dilate, and optimize as needed. And we'll talk about 6 and 7 also. Size does matter. Choose the right balloon and stent. And ensure full lesion coverage, expansion, and opposition to make sure you get optimal results. So the problems with SVG PCI is distal embolization. So there have been a number of studies looking at how can we reduce distal embolization in patients undergoing SVG PCI. Should we direct stent it? And of course, no randomized trial, but this study, which is non-randomized, looked at direct stenting versus pre-dilating and showed that direct stenting will reduce in less procedural MI when compared to pre-dilatation and stenting. And in essence, I tend to do this. If we after intravascular imaging, you see lipid pool. The same applies to STEMI patients. I rather go with an appropriate size stent and deploy it to high pressure rather than risk distal embolization in these patients. There have also been studies looking at should stents be intentionally undersized, and again, observational, where it has been shown that if you undersize it, there is less plaque extrusion on IVUS and less procedural MI, and there was no price to pay for in terms of TVR and TLR because the vein graft tends to be large. And I would highly recommend avoiding aggressive post-dilatation in these patients, because if you do aggressive post-dilatation, you will have distal embolization, slow flow, or no reflow. And also, let's not forget that vein grafts are thin-walled structures. Even though they may be calcified, you have risk of perforation with aggressive post-dilatation. What about stent choice? And again, this is not relevant now. In our case, we don't even stock bare metal stents anymore. But interesting to know, there have been a limited number of trials of drug-eluting versus bare metal stent. The largest is the DIVA study. In the DIVA study, they had problems enrolling for the trial. But when the trial was completed, just over 600 patients randomized, no significant difference between drug-eluting and bare metal stents for any of the outcome tested. And if you look at the meta-analysis of 6 randomized trial, 1,500 patients, so all of the data for SVG intervention is based on 1,500 patients. No significant difference across many of the endpoints, but MACE and MI numerically are better with drug-eluting stents. But in other words, I mean, I still would go with the drug-eluting stent in these group of patients. Numerically, I mean, these are all underpowered, but numerically there is a benefit. The point number 8 is the treat slow flow, no reflow. So I think this is one of the biggest bane for our existence in terms of SVG intervention. Of course, there are a number of pharmacotherapy we can use to treat no reflow or slow flow. But what I want to emphasize is no reflow is not just an angiographic phenomenon. Clearly, we have shown that if you have it, and even if you make the flow better, that these patients have worse outcomes, increased infarct size, low EF, increased risk of cardiogenic shock and heart failure, and increased short and long-term mortality. The one thing I want to emphasize, my treatment strategy for no reflow or slow flow is intracoronary epinephrine. And this is supported by randomized trial. This is a cohort trial looking at intracoronary epi versus intracoronary adenosine. And intracoronary epinephrine was significantly better at improving TIMI flow and myocardial blush grade. So my usual cocktail, if I have a slow flow or no reflow, is I administer intracoronary, especially in the distal bed, 100 to 200 micrograms of nitroprusside, followed immediately by 10 to 20 micrograms of epinephrine, and then that's my cocktail. So nitroprusside many times reduces your blood pressure. Epi will increase it, but it works pretty well. So how to treat this? I mean, try to figure out what is the cause and I would strongly advocate use epinephrine. It's a very potent one. Point number 9 is antithrombotic therapy. It's essential, not optional. Back in the day, people used to say, potentially use 2B3 and all vein graft intervention, regardless of whether you see thrombus or not. But studies have shown that is not of any benefit, and it increases your risk. What I emphasize is make sure patients are preloaded with antiplatelet, and you make sure your ACTs are appropriate for that intervention, because the risk of thrombosis is high. And finally, respect the patient, aim for durable outcomes. And the question has been, should we be fixing the vein graft, or should we fix the native vessel? This is observation study from Manos Brulak is looking at over 10,000 patients, whether the grafts were intervened or native vessel. And in this observational study, there was significant benefit with the native intervention, reducing the risk of death, reducing the risk of MI, reducing the risk of death or MI, and also probability of repeat revascularization. And because of this, we said in our guidelines that in patients with previous CABG, if PCI for diseased native coronary artery is feasible, then it is reasonable to choose PCI native coronary or PCI severely diseased vein graft. But of course, now we have the Proctor trial. This is the first randomized trial looking at patients with a vein graft stenosis, considering native vessel PCI versus SVG PCI. In the interest of time, I want to keep this simple. So the trial was originally planned to have a sample size of close to 600, and they only were able to enroll 220 patients. So right off the bat, it's a very underpowered study. For me, when the studies are underpowered, you have to take the results with a grain of salt. But the results of the study suggest that SVG PCI is actually better than native vessel PCI. But let's not forget that in the native vessel PCI group, over 63% of patients underwent retrograde CTO intervention. Okay, let me quickly go through a case. 68-year-old guy, multiple risk factors, bypass surgery, came in with chest pain, inferior and lateral wall ischemia. And this guy, you can see he has a CTO of his RCA. And on the right side, you see severe proximal SVG to RCA, proximal to osteal stenosis. This is his left side. Again, a lot of disease. He has a proximal severe circumflex, occluded radial to OM1. He also has an occluded SVG to ramus. He also had a proximal severe LAD, but patent lemur to LAD. But distal to the lemur touchdown, he had severe stenosis. So what we ended up doing was we went through the lemur, fixed his LAD distal to that touchdown site, and then we brought him back for a stage PCI of his SVG to RPDA. So here you can see we went right radial. We used the JR4 again, breaking the commandments I just told. I mean, we were unable to seat an AR guide. So we went to the GR4, we wired it, and we ballooned it. We took a 4O spider and embolic protection device. It's distally, you can see it down there. Pre-dilated with the 2O by 12. And, we had some difficulty doing intravascular imaging at this time, but we said, look, the balloon expanded. Again, we'll come back to this part of it. Then we said, okay, we're going to put in a stent, a 3.5 by 40 or 0 stent, and you suddenly see that the proximal part is not expanding. So here at this point, we're able to IVUS it. It showed a concentric 360-degree calcification, MSA of 2.27. So very, very tight lesion. We have to do something about it. So what did we do? We took a 4.0 by 8, 26 atmospheres. And I was like, you have to be careful. It's a vein graft, but it's not budging. So then we took a shockwave. This was back in the day when it was only 80 pulses. We delivered all 80 pulses, including the fact that during the last few inflation, we went to 10 to 12 atmospheres in the shockwave. I can tell you, increasing it beyond 4 atmospheres does not give you any benefit, but we did it anyway. And then we took a 3.5/10 angioscalp, still not expanding. So at this point, we said he had no chest pain. We said, look, the last thing we want to do is rupture this vein graft. So we said, we'll cool off and bring him back for an elective PCF, CTO, or RCA in a few weeks. We brought him back, and interestingly, when we took a look at it, the flow in the SVG had already slowed down. So you can imagine a few more weeks and this graft would have completely closed off. So in terms of the CTO, ambiguous proximal cap, there is a side branched proximal distal cap. There is greater than 20 millimeter occlusion, moderate calcification, no septal collaterals, and TME2 flow in the graft. We first dilated the graft with a 2.5/12 compliant balloon to facilitate passage of equipment and avoid ischemia during the procedure. We used the Turnpike LP150 Sion back retrograde into the distal RCA. We did the retrograde wire escalation. We used a Gladius Mongo to cross it. We were unable to enter, typically I prefer a tip-in technique, but we were unable to enter the antegrade guide at this point. We externalized into the Yoda, and we were able to snare it, exchange it to an RG350, and then we did an IVUS guided PCI, you can see a good result. Let me stop here in the interest of time, and leave you guys with these 10 commandments for SVG intervention. Thank you for your attention.
Excellent lecture. What's your experience in the stroke incidence in SVG graft interventions? Because when you're engaging in osteal lesions, particularly, there's higher incidence of stroke. What we
I think I would say it's similar to any other osteal lesions, and specifically if it is thrombotic, etc., you have to be extremely careful. So I agree with you that you have to be careful in not only engaging, because sometimes you're manipulating the aorta, you may throw emboli.
What the best debulking device you use if you find a very calcific lesion in SVG?
Yeah, typically for me, IVL is the way to go. For a number of reasons, including the fact that most of the SVG grafts are bigger, and you typically have 360 calcification. So, and the safety is more well established than any of the atherectomy. So I start with an IVL.
Thank you.
I just had one question, in the sense I had the experience of doing the native vessel of a vein graft, which was all right, but the which has had a big aneurysm. I don't know why and how that.
Of the aortic dissection, bilateral renal artery stenosis, subtotal occlusion, and infernal artery. Now, particularly just going to the carotid artery, we have done the 40 lesion dilatation, among which 15 cases of total occlusions, and your success rate is 70. And this patient, you see, the 7-year-old girls with a recurrent syncopal attack, but activity of disease is there. But the activity is a relative contraindication. But as there is a repeated convulsion, we have to do the release of the right carotid artery. And see, by coronary balloon, only sufficient to open the artery, which is acceptable result, and convulsion disappear. After 5 years of the first, then again there is some restenosis develop, and now this time we have done again balloon angioplasty, only plain balloon angioplasty. And interestingly, after 18 years, she developed restenosis once again, and there's a syncope. Then ultimately I give the stain, and on the right carotid artery, patient doing well. At present, she give birth the child also is doing well. So therefore, we prolong the life by doing the intervention. In case of the subclavian arteries, we have done the 64 lesions, among which 20 lesions in total occlusion. And you see, right subclavian artery total block, it is cases done of the 30 years before, and then that time it is the only plain balloon angioplasty done, which opened the artery with a great difficulty because all layer, intima, media, adventitia, all layer is inflammatory disease involved. And this case, once again, after 50 years, developed the stenosis of the same area. You see, the subtotal occlusion of the right subclavian artery, and this is very important. And whisper wire crossed the lesions with a great difficulty. And then, balloon, plain balloon angioplasty done by the NC balloon, coronary NC balloon also used. After that, deployed the stent, and post dilatation also done, and final result, acceptable result with some minor dissection. Interestingly, and therefore self-experiment stent ultimately given 6.5 into 6.5 peripheral stent, and self-experiment time is, and there are some minor, particularly some narrowing is there, but if I dilate more, the chance of dissection there, that is the acceptable result. Then what happened? The excellent result after post-dilatation, you see, ultimately you see, after same patient, after 1 year, developed the huge aneurysm from the distal part of the stent. And it's very difficult to cross the lesion. Ultimately, the great difficulty, we cross the lesion from the radial approach, ultimately give the stent is working well, and therefore long and therefore acceptable result as a whole. I believe that some initially there's some dissection because of stent, and then the last time we are given the cover stent, he is doing well. Now, in cases of the renal artery CTO, and these after stenting on the right, and patient on dialysis, and then dialysis not required, is doing well. And coronary, you have done the 21 cases, and that case is 12 were girls, and the huge pain, but you cannot cross the lesion, so failure in that suspect is doing well. Now talking about the renal artery CTO, the CTO renal artery, non-specific outer artery, and these the 38 lady came to me from Raipur, these 10 years before, and there was a Pianka Shenka positive 5 years before, and therefore the carotid bruit, internal bruit, and abdominal bruit also there. And there was a put on steroid and methotrexate. When it came to me, the creatine was very high, 6.8 and 120 urea. The Raipur nephrologist planned for the dialysis, and also they refused for dialysis, then came to me in the Calcutta and the Bellevue nursing home. And do the angio here, you see, there are total occlusion of the right renal artery and subtotal occlusion of the left renal artery. Very difficult situation. And then ultimately, with a great difficulty, we crossed the lesion by the filter X-ray wire and dilated by the plain balloon. And result is plain balloon dilatation done. Now artery is open on the left side. And then I planned for the onyx stent, and ultimately post-dilatation 4 into 18 millimeter non-compliant balloon. The result is acceptable result, circulation to the left renal artery. Now the CTO of the right renal artery, you see, no flow is there. With a great difficulty, we cross the wire, with particularly with the whisper wire, I use it, and then balloon dilatation, initially 1.5, then sequential dilatation 2 and 3, coronary balloon used to open the artery, and ultimately, again, sequential dilatation, with even in the NC balloon also used, there oil opening of the renal artery. Artery is very small, and then ultimately 4 into 18 onyx stent are deployed at the 18 atmospheric pressure. These also acceptable result to flow to the right renal artery, and therefore the excellent result on the right renal artery also. Good flow of the right renal artery. Now, The result, after 6 weeks of this girl, blood pressure was controlled without any drug from 220 to 120, and creatine also 1.4 after 6 weeks. She is a doctor, husband is a doctor, they're worried for that. So in this kind of patients, there is enough scope of intervention in spite of the kidney CKD with the total occlusion. Meticulous decision making extremely important for the long-term follow-up, prevention of the restenosis, because tracheostomitis, waxing and waning, recurrent inflammations, and the recurrent restenosis may happen. We have to, after the intervention, both on the carotid, subclavian, as well as renal artery, we continue the steroid methotrexate lifelong after the so 6 months to 1 year, so all the patients doing well. Thank you very much indeed for patient hearing.
Thank you, Dr. Panja, for that lucid presentation. I just wanted to know, when do you choose a stent? In aortoarthritis, what makes you choose a stent? And in descending aorta, do you use a covered stent or a regular stent?
You see, in my case, the subclavian artery, I used to give the covers. If there is some aneurysm, initially plain balloon and dilatations. If a plain balloon fail, if restenosis is developed, then only without cover stent. But the aneurysm last case you develop, we have to the cover stent frame, she was given an excellent result.
Okay, so initial go you may not put a stent. All balloon.
Yeah, they are doing well.
Any role of drug-coated balloons in your cases?
Pardon?
Drug-eluting balloons, you say?
So, coronary balloon, all the use. Initially, semi-compliant, then the NC balloon, and they're commonly used. We are reluctant to put this stent, really speaking. We are repeatedly dilated sufficient enough to delay the restenosis and ultimately delay the implantation of a stent. Stent is employed at the end stage only. Okay, thank you.
All right, so we'll move forward.
Next talk is, I think Dr. George Thomas is not here.
Yes, he's presenting for us.
Okay.
So next one is difficult triple vessel CTO.
Good evening, everyone. Thank you, Dr. Srinivas, for having me over. My talk is about a triple vessel CTO. Interesting because everything is occluded and ideally he shouldn't be even alive, but let's see. So it's no way forward, no way backward, and a stent in the way. So his story starts with being a 52-year-old male with 20 years of diabetes, 10 years of hypertension, admitted with cardiogenic shock 2 years ago. The surgeons couldn't see where the distal vessels were, so they just could not operate. And he had a pressure of 85 or 80 or something from I remember. And CJ at that time showed CT of the LAD, CT of the circumflex. There were some spider webs for coronaries as an excuse. On max supports and IABP at that point of time. The surgeons asked, do you want to do something? So I said, okay, we'll just do an angio and see what it is. So as I said, the wire went somewhere and I deployed some stents in some imaginary vessel that looked like the LAD. I attempted a CTO of the circumflex at the same time because it looked doable, and I perforated, caused a pericardial effusion. We tapped it. Somehow, by grace of God or luck, this gentleman went home 45 days later, completely lost to follow-up, and I did not see him for 2 years. So I thought, okay, guy's dead. No. 2 years later, he found me again. He spent some time in Tamil Nadu. And his cardiologist said, go back to your doctor. He's the one who fixed you and saved your life the first time. So let's see. That's the RCA for you. And that's the left system. Now, whatever you see stented out there is what I stented. And I can't, for the life of me, see anything going forward from here. Beyond this, that is the big vessel that I stented, which I thought was the diagonal, but actually now you can see the LAD has appeared. Now at this point in time, the best thing to do is please go for surgery. Now the LAD is visible. Please go. No, sir, please do it. Go. Okay, so imaginary LAD was the large D1. LAD was totally somewhere else. Looked easy to wire. Was it easy to wire? Does it look easy to wire? You don't know that right yet. So strategy was attempt the LAD first. Reasons: if I can get into the LAD, well, maybe I can give him a chance at life, because that may be the only vessel needed, because we've seen lemas to LADs produce channels to the other vessels and somehow patients pull on. Antegrade wire escalation, then go retrograde, and then I expect that this will not be an easy exteriorization. Mentally prepare for a long procedure, probably wear diapers because even you don't get a urine break in between. Approach to the case was split it into tasks. Do not be a scatterbrain, because if you're going to do a difficult intervention, you must know how to do your case, you must know your equipment, and you must know what your wires do, what your equipment does, and what it cannot do. And do not screw it up so bad that later on the surgeon also has no chance. Okay? So this is the starting point. It is the last living vessel. So first thing, I've asked my surgeons and my guys to stand by. We have ECMO in the lab. So we said, okay, in case I screw up, bail me out on ECMO. Then we start. What are the things to do? Tasks. There is a stent sitting there, and there is one more beyond it. We have to get this is the CTO segment. And wherever I wire this, the wire is not going to go into the CTO segment. The first wire will always go into the septal. Expect it, and that's what it will help. But you need to cross these struts from the stent and then turn the wire towards the LAD CTO. Not a mean job. Turn in the CTO segment, yes or no. If it turns, well and good, antegrade access. If it doesn't, no, retrograde access. Great. Cross the CTO segment, yes, we all want to do that. Antegrade, retro, we don't know. And dilate and stent in the LAD. Pretty simple thing if you split it into tasks, but let's start. What is the JCTO score? It's a tapered end where I can actually get in there. Calcification? No, it's not calcification. It is steel there. There's a stent there, and I don't know if there's calcium there. And there is restenotic material there and a CTO there. Bending? Yes, through that stent, there is a bend. Okay, so that's definitely there. Occlusion length, definitely about 20 millimeters. So now we have 3 points on the JCTO score. It's not a retry. I just didn't try anything ever before. So very good, 3 points, very difficult. What did we do? Task 1, get the septal through the struts. What do you do? What wire can you use? Use a wire that you're familiar with, a polymer coated, because you want to go through struts and you want to know a wire that will do it. Cyan black on a fine cross, drill through. Now, as I said, what will happen? It went into the septal. Next, it goes into the septal. I get a fine cross across there because I want the fine cross to engage and give me the space to turn antegrade to the right of the vessel into the LAD. And I use a wire in the vessel to support me. You can see there's a lot of collaterals there. There's a lot of septals there. This wire for its life will not go. So cross the antegrade CTO. Yeah, let's try. There are many wires to use, right? So we use a Fielder XTA on fine cross, hoping it will turn. No, it doesn't turn. Then cyan black, Gaia 2, Gaia 3, everybody refuses to go. Failed, what do? Don't dwell on the same thing. Do not keep doing the same thing 100 times thinking one wire will go someday. Because if you repeat a mistake 10 times, it doesn't become a correct. So stop it, switch modes. So you began therefore I began the collaterals. Now you can see the collaterals on the right side of the screen. Interesting W-shaped collaterals. There are no straightforward collaterals there. So but this time I want to change my microcatheter because I need a taper tip microcatheter. Now you see the micro channels that are going to the LAD. W-shaped. Can anybody spot a straight channel to the LAD? So what do? Think. Don't just throw wires in. You need a soft tip wire. You need a taper tip microcatheter and a microcatheter that will turn and listen to you. So what do? There's a company from China called APT. They had something called as an Anyread 03, something like a SUO and a SUO. The SUO is like 5 times costlier than the Anyread, but both do the same thing. But we just tried switching out both the wires to go forward. And even with the SUO wire, I successfully managed to create a hematoma there. So should we stop? Should we not stop? No. Take a deep breath, take a step back, pull the guide wire back, take an injection. The collaterals are still there. I was over aggressive. So game is still on. We take a SO3, doesn't work. Now at this point, you need to turn your wire. The wire needs to turn somewhere. We shift to an XTR with a tip so that you can actually direct it someplace. Turn somewhere. Keep the microcatheter tip away from the tip of the wire. Why? Because you want the wire to do its thing, not the microcatheter. Because when you take a microcatheter tip to the tip of the wire, you will weaponize the wire and make it a needle. We already did that once, right? So now when you let the wire do its own thing, you see the wire nicely finds a channel, goes into the LAD. Okay, is the story over? No. Now you need to get the microcatheter up. By now, the caravel is fatiguing. I need to push it through. You can remember there's a proximal 90-degree turn and all these convolutions it has to go through. Managed to push it more. It's gone up the LAD, but the microcatheter is still down. Next, the microcatheter moves further and then gets stuck at where the red arrow is. Now, beyond this, the caravel will not go. I can try many stunts to do this. So what do? Increase the support. Balloon the proximal segment, create that hole to become bigger, then anchor support it, push it forward. Pushing, 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 nothing will work. So what do you do next? Change the microcatheter because the hydrophilic coating on the microcatheter has gone. So second caravel actually flies through and reaches the LAD. But then what next? Now it is antegrade wire escalation backwards. So again, now it is a microcatheter, it is a fielder XTA trying to go backwards. Now that wire decides to hide under the stent, it doesn't cross into the stent. What next? Next wire, MG13, Gladius wire. Gladius wire finds one way left around the stent. Next view, one way around the stent on the right, but it will not enter. Now what do? Think. There you need disruption of that tissue out there. So you wire down that vessel, disrupt the entire area, go to high pressure balloons, try to disrupt. Then with a little bit of luck and a stronger wire, 6-gram wire, crosses into the stent and into the aorta. So now we have the thing going backwards into the aorta. Game over? No, because the microcatheter will not cross this area. What do you do next? You need to convert this antegrade. How do you convert this antegrade? I need time. Should I continue? Convert this antegrade, tip in. I remember I have a fatigued microcatheter there. So saving money, I try to push the microcatheter forward. But that microcatheter will not go forward. So I said, okay, there are 2 wires there. I can do a rendezvous technique. Rendezvous fails. Caravel will not go forwards. So everything fails here. Again, I have to start from 0. So go back, get the wire back, and I get a Corsair Pro tip in again. This time, I'm able to screw in the microcatheter forwards, antegrade into the LAD. Now, I have LAD access. Now, everyone can breathe because the rest of the plasty is easy, right? You get a decent wire there, dilate, stent, DCB into the proximal vessel, DCB into the distal LAD. Now remember, let the surgeons have their chance, right? So don't stent the entire vessel thinking you are heroes. Stent only the proximal because the vessel has not flowed for a long time. Let it grow. DCB the mid part of the vessel and leave it there. Maybe he'll come back. See, the vessel is open there. Maybe he will come back. Maybe the vessel will grow. If this fails, at least I have an excuse for sending him for CABG. Thank you for your personal listening. So basically I wanted to develop a disciplined approach, develop a plan, patience, 4 hours of work. It's equipment intensive, radiation intensive, fatigue intensive. Repeating the same failed maneuver 10 times won't make it work. Need to change your plans. Plan A, B, C, D, E, F. You should have 100 plans in your head. If you don't know to plan, don't attempt. Sharpen your skill set. You need to wire backwards. You need to wire microcatheters. You need to know what your microcatheter can do, drilling forwards, drilling backwards, push, pull, and always leave space for the CVTS team, right? Thank you.
Great case, Dr. Thomas. Did you use imaging at any stage?
In this, there was probably no point of imaging because I just had to get the vessel open.
When you externalize into the left main, it's always safe to use the image?
If the catheter is there and I know where the wire is going, probably, because I was not in the left main anyway to externalize.
Main problem was microcatheter transit through the septum, right? So that's a classical problem in those septal to septal loops, particularly at the bottom end, because the heart's contracting around the microcatheter. The other thing you might have considered, just instead of tip-in, because that's a higher end maneuver, as a second guide, pinning that wire, right? So you externalize your wire, pin it in your second guide with a balloon, and that might give you a little bit more strength. And when you push, you push in diastole, right? Because I think part of what we've learned is that when you start to spin microcatheters when the septum is contracting, it will grab and it will create a spiral mess around your wire. But that was an expertly done case. It was really nice.
Thank you.
Great. Let's move forward.
I think one small announcement I'd like to make, because it's getting slightly delayed. We requested the last 3 speakers as well as Sanjog's talk. We'll have it on tomorrow's lunchtime. So we'll have Dr. Rath's talk and Dr. Miraslo talk, and then we'll try to end there. Thank all the other speakers who cooperated, agreed to change to tomorrow. I also request to keep the discussion a little less so that we can finish the lectures and finish the program on time. And after 9 p.m. we will have the dinner. It is here, and then tomorrow again morning we have to come back by 8 a.m. Thank you. And
thank you.
Next session, Chair Dr. Jain is here. Please come on. You join because we're clubbing almost both sessions. Thank you.
Okay, so proceeding ahead, welcome Dr. Jain. Always good to see you. Proceeding ahead then with image-guided PCI of CTOs with Dr. Krishna. Dr. Krishna here. Thank you. Mamsi Krishna.
Good evening, respected chairpersons, dignitaries, and at the outset, I would like to thank ACVS Facts Foundation, Dr. Srinivas sir, for giving the opportunity to present an interesting case. This is an long segment CTO case of an right coronary artery using an imaging guidance. My case is a 43-year-old male patient presented with chest pain, unstable angina of 2 months duration. 2D echocardiogram showed regional wall motion abnormality in the LAD territory with moderate LV dysfunction of ejection fraction 38%. His biochemistry was within normal limits. Hemoglobin, creatinine all within normal limits. Troponin is negative. ECG showed poor R-wave progression. Then we went ahead with coronary angiogram. Next. Play. Coronary angiogram showed right coronary vessel partially occluded at the mid part. It is right coronary vessel is tortuous. Distally, it is CTO segment. In left coronary system, left main look mildly diseased in the distal part. Ostium of LAD and LCX looks normal. LAD vessel in this view showed diffusely diseased. LCX next. LCX is non-dominant and next. Play. There is ramus intermediates which is very big with mildly diseased. Left corner is LCX is only having a discrete 70% lesion. LAD is diffusely diseased distally. Proximally there is 80 to 90% discrete lesion, and we can see collaterals giving to PLVB and PDA. Next. Here. Yeah. Now considering heart team approach, we gave the decision for open heart surgery, but the patient was reluctant for open heart surgery and he opted for percutaneous treatment. Now I went ahead with first initially right coronary PCI. My approach was right femoral. I took JR6 French guiding catheter. Initially I opted for Filder FC wire, which initially it was buckling at the mid part of the right coronary artery. It was not passing through. Then I changed the vessel wire. I took Whisper medium support wire, which it was able to cross distally up to the crux. Then I pre-dilated with 1.5, 12 mm and 2 into 12 balloons. After balloon dilatation, this is the angiographic film. The vessel is almost completely filling up to the crux, but here I was struck. I was not able to find any PDA or PLVB. My wire was not, I felt I should take a dual injection. At this stage, I took right radial and TIG injections. This helped me show the distal path. Almost the distal wire was up to the, has crossed the crux and it is into some small branch. After gentle manipulations, I was able to go into the PDA, and after confirming it, again I dilated with 2 into 12 balloon. This is the check angiogram after the pre-dilatations. Now I went for imaging guidance. Angiographically, the lesion was appearing, the lesion looks like 2.5 and 3 vessel, but surprisingly in the IVUS, I was able to see the exact vessel size. From the crux, the vessel is almost 3 and 3.5 vessel. IVUS showed almost the vessel is diffusely fibrotic with occasional areas of calcification. Calcium is mostly superficial. At the mid part, I can see vessel growing to 4.5. So there might be some ectatic vessel in between. Next. Then I went ahead with stenting, right distally with 3 into 48 mm drug-eluting stent. Then with mid to the proximal RCA with 3.5 into 44 mm drug-eluting stent, almost up to the ostium. Because the vessel looked almost 4.5 proximally. This is the post-stenting check angiography film. It's very good TRIMI 3 flow into the PDA vessel. All through the procedure, I was operating with that same Whisper support wire and the JR guiding catheter. And after stenting, I was able to pass the IVUS catheter to up to the crux, but it was not passing into the PDA. Distally, the stent looked well opposed. At the mid part, I felt that the stent is underexpanded. And again, I post-dilated with 3.5 12 balloon and 4 into 10 NC balloons from mid to proximal. This is the final RCA result, showing good TIMI 3 flow and acceptable result. Then I went ahead with PTCA for the left coronary system. I took EBU guiding catheter with the same Whisper wire. I parked into the distal LAD and I pre-dilated comfortably. Then I did imaging. Imaging showed diffusely diseased. Vessel is around 2.5 into 3, 2.5 to 3 mm, with a minimal lumen area of minimum 2 millimeters square. So I stented distally initially with 2.5 into 38 mm, mid part with 2.75 into 38 onyx, and proximally with 3 into 12 drug-eluting stents. And then I have done post dilatations with 3 into 12 at the mid part and 3.58 NC balloon and the proximal. Yeah. After post dilatation, distally there is no dissection. Stent is well apposed. Again at the mid part, mid LAD, I felt stent is little under expanded. Again I have done post dilatations. The vessel looked 3.5 even at the mid part. After post dilatation with 3.5 balloon, this is the final result. Yeah. In conclusion, from my case, CTO segments require dual injections. So this is very important in my case because it helped me plan, wire and safely cross the distal CTO segment. So, and very important is guide support in a CTO procedure is very important. Actually, initially I should have planned with AL guide catheter or 7 French guiding catheter so that it would all the gadgets would have passed through distally. And imaging is very important in my case also because it helped me size the vessel appropriately, and in the long segment CTOs it helped know the vessel size and exact landing zones. In diffuse disease segments also it's very important to know the vessel size using imaging. And DEB is an alternative for drug-eluting stents in all the branch vessel disease or diffuse segment with vessel size of less than 2.5 mm. Thank you.
Great, thank you. Thank you very much. I think we're going to push forward in the interest of time to try to keep us at a reasonable time endpoint. So with that, I'll ask Dr. Goel to step up and speak to us about how to select guide wires, selecting and escalating.
Can I speak on that? Where is the double click button? Okay. Yes, so this is to move forward. Can you get my slides, please? Okay, thank you. And at the outset, I must thank Dr. Srinivas to have invited me. And so what I'm going to talk about is the CTO wire selection principles. So this will be a little basic talk. So you have to bear with me because this is a teaching talk that I had made. So, you know, when you're doing CTOs, physics of CTO wire tracking lumen to lumen, this is very important. You're dealing with 3 forces: the wire tip force, the resistance in the loose tissue through which you want to track, and resistance in the plaque which you don't want to go through. So ideal wire would be where the tip force is more than the resistance in the loose tissue, but less than the resistance in the plaque. Well, if you can get that, that is the ideal situation. And the guiding backup force adds to the wire tip force. And guiding backup force is very important. And if the guiding backs out during your wire manipulations, it tells either the wire is too weak so that you compared to the resistance in the lesion, so it is backfiring, or it is heading in the wrong way. Again, the guiding is backing out. So you have to have the guiding in place. And two important prerequisites before CTO wiring: must be able to see the distal vessel. How you see is your lookout, contralateral injection, ipsilateral, collaterals, whatever. And always use a microcatheter for these wires. Now, the CTO wires are talked in terms of tip loads. Well, I don't think I'll be able to tell everything about each wire, but yes, you have tip loads varying from 0.6 XTR to about 8 to 20 grams Conquest Pros tapered versus non-tapered tips 008 to 012 and then 014. Coatings, hydrophilic coating, polymer jackets, penetration force, which is like tip load, and penetration efficiency, which is a little different from penetration force. We talk about it for Gaia wires, where the tip load may be a little less, but the tip design, the tapering design and the dual core makes it more penetrative. So the penetration efficiency is better, and the composite core makes 1:1 torque control, especially for the Gaia wires and the several other Asahi wires. So wire handling principles: one is a controlled drill. You rotate the wire clockwise, counterclockwise, and the wire finds its way through the loose tissue. And this is usually with the either the coated wires, the XT type of wires, or the polymer jacketed wires. Or you have an active penetration technique wherein you deflect the wire, you direct it, and that is best with more penetration force with the Gaia type of wires. So wire choice, decision-making factors, I think this slide summarizes several of the things which are pretty basic, I would say. Now, if the duration of the occlusion is less than 3 months, then an XT or Pilot 150-200 could be used. If it is more than 3 months, then it's better to use a XT type of wire to explore the lesions, see how the channels, the loose tissue is, and if it goes fine, otherwise you'll need penetrative wires. Post-MI settings, especially if the distal vessel is not seen, then a Pilot 150 finds its way in areas where vessels are not seen, especially in post-MI settings. If the proximal cap is tapered, then a XT followed by XTA or Gaia 1 may be a choice. If it is blunt, then you need a penetrative thing where a Gaia 2 or 3 or even a Conquest Pro might be needed. Antegrade trickle, if it is there, it tells there are microchannels, and usually a XT type wire will work. If the CTO segment is bendy, then hydrophilic wires are better, like Gladius, UB3, but no Conquest, because Conquest will not go through bends and you cannot deflect or direct it. Calcification, if it is there, then Gaia can get stuck. Gaia next is better, but if no success in a very calcified artery, then retrograde is the way to go. Branch point at the distal cap, if it is present, then Gaia is a good choice. You can direct the Gaia, and then your techniques you can use. I'll just tell you. CTO length, if it is long, then retrograde is a better option. Short, most wires are okay. ADR, well, you have a microcatheter, and for knuckling, Pilot or Gladius MG specialist could be a choice. Understanding the CTO anatomy, there is a proximal cap, body, and distal cap. You have to always understand it like that, because proximal cap, you will find more penetrative wires might be needed. Body is easier to cross, then you can downgrade. And then the distal cap, again, you might need to have a penetrative wire. Step down approach: once proximal cap penetration is done with a stiffer wire, microcatheter to follow into the CTO mouth and step down to a softer CTO wire for traversing the CTO body that is known to be less tough than the proximal cap. Direction control wire at the distal cap is always better. And if you get suboptimal, you could do 3D wiring, parallel wire, IVUS guided wiring, or ADR. The softer may not always be safer. You feel that there's a soft wire I'm using. No, what happens with the soft wire, it cannot go through the calcium that is there, and it will deflect into the subintima. While a penetrative wire, if you direct it well, it can go through the CTO. So this just shows the soft wires get deflected, don't cross it. Stiffer wires like Conquest may just go through straight and still not go the right way. Gaia is a good wire, provided you know how to handle it. And it has a good penetrative power because of the tapered Act 1 design. And it has a good deflection control because the tip load is less, so it's more flexible. And the 1:1 torque control, you can rotate it in the direction that you want. So you can literally guide the wire, provided you know where to go. That's just the picture of the Gaia Act 1 microcone tip and the things that I told you. So my choice of wires for anti-grade approach usually is step 1, XT or XTA, step 2, Gaia 1, Gaia 2, and step 3 is Gaia 3 or Conquest Pro. Now this just shows you the different wires, soft, intermediate, and stiff, which are available as of now. This shows that the Gaia wires with a lesser tip load have penetrative efficiency more than some of the higher tip load wires like Conquest Pro. The limitation of the current Gaia, the regular Gaia, was because of the higher efficiency of penetration, it goes into calcified spots, but because of the lesser tip loads, it cannot exit it and gets stuck. And then when you over-rotate it, it will break, and it had a single coil which will uncoil itself, and so you have to be very careful on that. The Gaia next, which is there, has multiple coils around the thing, and each is like a rope coil, so they don't untwine as much. So what the Gaia next has done, preserving the Gaia concept of 1:1 torque control and guidance, enhanced the ability to avoid being trapped and avoid coil stretching when fractured. The tip to handling a Gaia wire is never over-rotate, always advance 2 millimeter, and maybe withdraw 1 millimeter to ensure the wire tip is not stuck, and redirect and advance. The 3D wiring approach, well, this is what I keep topping. I think I don't have the time to tell you that, but yes, if you at the distal cap, you are not in the right track, you can always, with the help of 3D concept, locate where exactly your wire shaft is, which way the tip is directed, and then rotate it accordingly so that you get perpendicular and penetrate. So that's the app that we made for the 3D wiring. So it basically asks you 2 questions in RAO type view and LAO type view, 2 orthogonal views, which will help us locate the wire shaft location, the wire tip direction, and then it will tell you where exactly you are in that particular situation in space. So here, the wire is on the left of the true vessel, the tip is for anterior, so you rotate 90 degrees and push, you will probably enter. I think I'll skip that. Some of the wire equivalences, XT is like Fighter of Boston, Conquest, Hornet of Boston is like Conquest, Infill Track is also like Conquest. It's a non-tapered, that's some new, this Gladius is a non-tapered hydrophilic polymer jacketed wire. EX is practically like a UB3 but can be directed. It has that composite core tip, and MG is good for knuckling. SUO3 good for retrograde procedures, very low tip load, 0.3 gram wire. This is infill track, very much like Conquest. It has a tip which is like a golf ball, so it doesn't get stuck, and it gives you feedback of the wire tip position. I don't think I have time to talk about retrograde wiring. I think that's enough. I have examples. Well, this is a circumflex CTO. It's pretty straightforward. Now it has anti-grade leaders, strong ipsilateral collaterals. So the CTO segment is straight, and this is where XTA would work well. And XTA goes down, and then you can confirm it through, it is ipsilateral filling collaterals, and you can go through. This is the final. Another RCS CTO, this is a recanalized segment, 2 channels, recanalized CTO. So Sion does not move forward. XT moves forward, but is stuck intra-lesion. and XTA makes its way across. XTA you can direct as against XT, which you cannot direct. And then you exchange the workhorse and finish. This is a, now this actually this is a recanalized CTO if the Sion will not go, and we put a XTR. Now you see the bend there, and in a little bendy lesion, XTR is better because XTR you can direct and it's 0.6 gram load only. And because it is patent, looks patent vessel, so to go through microchannels. And that's how the XTR traveled down in this case, and we could complete it. This is again a case for XTR, very bendy, tortuous segment, not really a CTO, but failed outside. And so if you see, we have used the step-by-step advancement with the XTR soft wire 0.6 gram, and then got subintimal also, but then because it can be redirected, it has the composite core tip, and you redirect and gradually you can enter. This is, I think this is a case LAD CTO. So XTA was buckling, so we upgraded it to Gaia, I think. Then Gaia went into a side branch, and the tip injection shows that you have the channel towards the LAD, and a Gaia 3 could go in. We will skip this. Now this is one, there is a side branch here. You can use a IVUS guided wiring. The other thing, what happens is even with IVUS guided, your wire always goes into the side branch. So what you can do is you can occlude the side branch with a balloon and then try advancing the wire. And that's what we did after occluding the side branch. And then we used a stiffer wire to penetrate. That's the infill track wire. And that went in, and then microcatheter could follow. This is a parallel wire. I think we can, LED, it was getting stuck. This is a RCS CTO. So the first wire went into XTA, went into a branch. So we upgraded it to a Gaia 2 at the distal cap. And here, this was done in two orthogonal views. And if you see, the wire is, oops, can it run? Oops. The next one should run. The next one should run. Okay. It is not running. Anyhow, so this was subintimal at the distal cap. Time's up. Okay, that's fine. So I'm just showing some examples. You can.
Thank you.
So that's fine.
Go ahead.
Can I show the last slide if it's okay? Someone has stopped it. If you can show, because this then I use the 3D concept and you enter the position of the wire and where it is and you can enter. Conclusion. So what you need for these wiring understanding, need to have a good understanding and knowledge of the CTO wire technicalities and the angiographic anatomy of the CTO lesion, which is fundamental to a successful wire crossing, along with good wire handling skills, and need persistence, patience, and passion, I think. And you must know when to stop.
Thank you, Professor Goel. Because 85% of the success and at the same time failure is the wire cross. The most important step. Very educative and narrative slides for the fellows, and people who are doing CTO also very useful because we are running short of time.
Thank you. Thank you.
I invite Dr. Sachendra Tiwari for the Gaia wire CTO crossing without micro. I'm sorry. Okay. No, yeah.
and then you. They're just finishing this session, and then it's yours.
Thank you, Dr. Srinivas, for inviting me in your this very prestigious annual conference, which you hold it every year. So from Dr. Goel's educative class from the different wires, so he is smiling. He has made me very easy to move forward to a simplified, cost-effective approach in very selected lesions of chronic total occlusion. And it is a challenge that these Gaia wires, CTO crossing, and without microcatheters, sometimes you are happy not using the microcatheters when you are stuck up with these supporting devices. We all know that this microcatheter is the default in CTOs, and without it, it's very difficult to do to complete the procedures. Number one should have a guide and wire support. Second thing, the tip stiffness modulation is very important. And third is what it does is it facilitates the wire exchange much easier, shorten the time, and then you can still shape the CTO wires much easier when you are using the microcatheter. So the question is, these rules are real. So, but are they always necessary? Because in very short selected lesions, one can use these Gaia series wires without the microcatheters. So there are merits, but there are challenges also. It has an added device cost, number one. Then there is an extra step and extra time to devote and doing these challenging CTOs. Then crossing profile is also a challenge because it's a bulky, and then it crosses a very tight and heavily calcified long segment lesions, make it much more difficult. And then you should have a feel of these CTOs wires, how much pressure, how much exertion you have to pass in from the hub to the tip. It's very important. So genuinely a valuable tool. This case is for deliberate selective use, never withholding it when support or safety demands. Then certainly one should use the microcatheters. So does every integrated CTO crossing begins with a microcatheter in a selected lesion, in selected lesions with a strong guide support and a favorable anatomy? A modern polymer tipped wire may cross integrate without microcatheters. So these two important both must hold when you are using, when you are not using the microcatheters. So as Dr. Goel has said, these Gaia wires, because they have an outer and inner composite core, it has a dual coil structure, and there is a superior torque when you are using the Gaia series and has a taper polymer tip, which negotiate and cross the proximal cap and going into the body. So as I'm not going into the detail of the structure of the Gaia wires, but it has three advantages. One should aware that it has a tip flexibility, it has a lower tip loads, and it's a greater penetrating efficacy. So one should know how it is useful, and one should know how much pressure and rotation one can apply to these Gaia series. So there are distinct three advantages: the tip flexibility, the pressure you convert from the hub to the tip, and the directions to control these use of Gaia wires. So there are differences in the torque response from hub to the tip, and probably the Gaia has a much more conversion rate. So there is a good penetration powers and a good deflection and a rotation. One should avoid the spinning of these wires. So one should do a clock and anti-clock wire and avoid getting this stuck. They get sometimes stuck up in the heavy calcified plaques. And these core wire also get distorted and fractures. So then when wire is removed, the coils may remain inside. So one should be very careful when you are using it. So the golden is never over rotate these wires, advance 2 millimeter and up and come back also, and then redirect and advance these wires to the distal tip. So there are favorable anatomy when there is a short segment, there is a mild moderate calcifications, and then there is a clear-cut torch, there is a clear-cut segment, you can see it. Then certainly one can use a guide wire without the microcatheters. But if there is a long CTO segment, heavy calcified, it is a tortuous, then probably one should use the microcatheters. So when there is a green bell, then probably wire only is a reasonable first line. But when if you are land up into a red flag area, then probably the microcatheter is your friend, not a habit to break. So these wire guides have a tip configuration that there is a 3D deflection in the two views one can see while moving forward with these wires, have a controlled rotation, and two orthogonal view guide you to go into the main lumen. So if this does not mean if there is no control, there is a constant tactile assessment of the resistance, then it replaces the catheter tip stability. So step by step, the guide engagement is very important. The wire escalation is to understand, then 3D wiring, then there is a confirmation, and then the crossing segment is very important. So I'll share with a few cases of coronary artery disease, not going into the details. So this is a LAD segment with a main branch coming out, and then one can start with the microcatheters, but one see once the wire is crossed with the LAD, then probably I remove the microcatheters, and then the guide wire crosses to the main LAD and complete the procedures. So sometimes this is a second case of chronic stable angina. I had a MI earlier with a RCA CTO, a short segment with some moderate calcifications. I started with a microcatheters with the guide wires, and then one can remove the microcatheters, and then guide wire slips into the main lumen and cross the wire and complete the procedures. The other third case is it has a LAD segment CTOs, and then it has a branch coming out from the main segment, and then you cross the lesion without the microcatheters and complete the procedures. So this is another case of 60 years old male with an NSTMI 1 year back, and then it shows a LAD lesion and a RCA CTO, which is a long segment, and then you start with the guide wire with the microcatheter, and then once you remove the microcatheters, then you can negotiate the guide, probably much more you can better handle it without the microcatheter, and then you go to the distal tip and then complete the procedure successfully. So these are the challenges when you are using the microcatheters with the Gaia in a CTO complex. And then if you remove it, sometimes if the segment is short and there is not much calcification, heavy calcification is not there, then probably your wire can go easily to distal end, and then you can complete the procedure successfully. So there are challenges when you are not using the microcatheters, and so there are challenges of the wire instability without the microcatheter support, but then one should guide the backup. You should have a good guide support, balloon anchoring, which reduces the working length. Then there is a subintimal entry risk. So there is a frequent orthogonal view. You can see where your wire is going, whether it is going into the false lumen. And then support of the balloon and the delivery of the stents become much easier when you are controlled with the balloon. There is another economic issue of treating such patients because it's a cost-effective using microcatheters, but it's not the reason not using the microcatheters. So there are challenges. So saving is not real, but conditional on a correct selection, cost is never the reason to skip a microcatheters. So once you feel that you need a microcatheters with a long segment, CTO segment, heavy calcification, one can use the microcatheters. So Gaia design enables wire only crossing in selected cases. That's very important because it has a dual core architect and it has a very good torque transmission from the hub to the tip. It make easier. Less is more is a viable in experts in a high volume hands. It's totally dependent upon the operator's experience, and one should know the limits. This is not for every lesions. In a heavy calcified, high JCTO scores, long segments, tortuous scores, if you are not sure, always use a microcatheters to complete the successful procedures. So know when to reach for the microcatheters. So one should protect the lumen. This is very important. Never compromise true lumen access for the sake of dividing, not using your devices, the support system, the microcatheters. Reach for microcatheters the moment support or tip of the control becomes inadequate. Then case selection is very important. So the guide support and the imaging disciplines, not the wire alone, make the safe procedure successful. And certainly to complete the procedure, it's very important. So to conclude, the support optimization is very important. And then also you should have a tactile feedback. Then only can, in a selected cases, one can use, challenge the convention of using Gaia CTO wires without the microcatheters. Thank you very much.
Thank you very much, Dr. Tiwari. So that's sorry, Dr. Franek, there's one more before your talk. There's one more. Yeah, sorry. So I think just as Dr. Kumar gets set up, so I think point number 2 that you said, which is in expert hands, maybe this is a viable technique, I think is an important message. I don't know. I mean, I think if you cross with a Gaia wire, you're going to have to switch that wire out anyway. You're not going to be doing a PCI on a Gaia wire, so you're going to need a microcatheter one way or another. And the other point that I would make is, in all honesty, I think for a group of operators where you're starting CTO PCI and learning techniques and learning systems, this is probably not the right way to go. The expert box is a really big, bold, red, super important box. I have done 2,324 CTOs in the last 12 years. Average JCTO score of 2.8 to 3, and there is no way I would ever start a CTO without a microcatheter. That is my honest opinion. I don't know if anybody else on the panel has similar thoughts.
See, for 10 years, but if you are an experienced person, more than 10 years, and you are doing CTOs, complex CTOs, maybe 100 CTOs in a year.
As I said,
probably sometimes in selected cases,
as I said,
not as a
2,300 CTOs in 10 years. So that's 230 CTOs a year.
Yeah,
and I still would not do this without a microcatheter. Yes. That is my opinion.
Then in selected cases, I'm not showing not using the microcatheters, but certainly a small subset of selected cases, one can go and do this procedure. Yes, that's right.
I can't let that message get out.
Can I have my slides actually before the speakers call? For the dinner, I'm just making it faster. Can I have the slides? Can I go ahead? Slides are not there. Please. You're leaving. Okay, thank you. No problem.
Where are the slides, man?
Where are the slides? I think 8:30 the program finishes. That is why. भाई किधर है मेरा स्लाइड्स?
Can we, no, what? Pratap, we are here, so can we have the next one so that, no, I think, yeah, so we can have the next speaker till his slides come. No, have they come? If they have come, then नोट किया है
Madam, I have given to you.
ये लगा दिए.
You are not showing it. Not here.
It's very simple approach. I don't know.
It's not getting connected.
Yeah, but it's you are on the team. Yeah, it's easy. Yeah, just connect and you have me. What is the issue? Yeah, but was it this one here?
Whenever they're getting an opt-out, the problem started. तुम्हारे से ऐसी कर तुम्हारे से not alone. हाँ, time waste हो रहा है.
Actually, you are showing my presentation. That is my presentation.
Yeah, yes, sir, yes, sir.
But should actually keep
But sir, the laptop is
connectivity machine. Can I go? Ferenc, I don't know whether, is it okay? Can I go? Okay. Anyway, some fixing is happening, CTO fixing. I don't know where I can speak. I have to go here. Okay. Can you just go to the slides? But your audio visual is very bad. Huh? I can only tell that. Actually, the algorithm of CTO crossing, I'll just go very fast because of the time. Whenever we are doing CTO, when you do only antegrade, the success can be up to 65%, even in the best hands. But it can go up to 95% if you go with retrograde also. So when a CTO operator should have the chance of doing retrograde and antegrade together, that makes from 75% to 98%. It depends upon the people. Dr. Goyal and Dr. Suryaprakash doing 97, I can have a 92% success. Some of the people have 80% success. Japanese claim that they have 99% success. So retrograde approach increases the success in CTO PCI. So, but it has a lot of complications and should be performed by people who are experienced and just doing this CTO in a different way. When you do the CTO program, you have a stage 1, stage 2, stage 3, stage 4. Stage 1 is actually antegrade wire escalation. Stage 2 is actually antegrade dissection re-entry, which we are not clearly interested. And stage 3 is the third one, that is actually retrograde intervention by septal collaterals. When you go to the last stage, that is retrograde intervention by epicardial collaterals. So, but you should have a flexibility of change of making a success. You should have a flexibility. You may go from antegrade to retrograde and retrograde to antegrade. That should be there. What is Asia Pacific CTO algorithm tells? What is the first and foremost thing is actually antegrade wire escalation. This is a 41-year-old male patient with an angina of 18 months. We have done this IGCTO in the IGCTO program in 2018 in Mumbai. So this was actually a double, the basic principle of CTO, you should have 2 catheters to be on either side to see the retrograde vessels also very clearly. So when you look at the CTO, you just think that it is very simple. So the dual injection is needed, yes. Which route? You can have a bifemoral or a biradial, or you can have a radial and femoral route. What size of catheter? We prefer to take 7 French or 8 French. Which projection? You can have an REO cranial projection or an REO caudal projection, 2 orthogonal projections. How to inject? Your first injection should be on the recipient vessel knot. The other one, which is supplying the vessel, it should be the retrograde connection should be seen very clearly. Anticoagulant, we don't give a low molecular heparin. We give heparin. Usually we make ACT to be more than 350 or 300 in retrograde, otherwise 250 to 300. So this case actually we go with 2 catheters, 7 French EBU 3.5 on the left system and Amplat's catheter AL1 on the both should be stronger catheters. So a long CTO, retrograde filling from the left system, antegrade filling seen, but you cannot see a proper interventional collateral. So bifemoral route, 7 French EBU 3.5, 7 French AL1, guide wire and microcatheter choice is the next one. We decided to take AL1. I have taken a fine cross with a filled FC wire to take the wire into the proximal part. If you look at very carefully, the first wire I chose was an XTR. That is actually 0.6 gram, as Dr. Goyal mentioned you clearly. But you have a conus artery there that makes me so happy. So I decided to take an anchor balloon technique here. We took a 2 into 12 millimeter balloon. The anchor balloon should be of the same size of the vessel, but should not increase the size, and you should make it 6 atmosphere pressure. That's the best one. Then we decided to take the wire. Wire did not. Wire crossed some progression, but distally, I am totally out of the vessel. So the first wire actually gone out, then XTR, then I went into Gaia 2, then the Gaia 3 wire. Everything went out. You can see the wire is totally out of the vessel. Once the wire has gone out of the vessel, I decided the second technique is actually you can go with a parallel wire technique, or you can escalate the wire into a different technique. We decided to take both. From Gaia 3, I went into Congress Pro 12 and I decided to take a parallel wire technique with a miracle. You can see that the wire is buckling back. That means my CTO is, I was expecting is a simple one. It was not a so simple one. But the distal wire is not in the lumen. Wire crossed, but you can see, you look at the second frame, the wire is totally out of the vessel. But you can understand that I crossed the proximal cap, but I'm not reaching up to the distal cap. That means I can de-escalate the wire. That's the principle here. So the Congress Pro, I switched over to Gaia 2. That means I'm actually de-escalating the wire. The other wire actually switched into the miracle, but again, not in the lumen. I kept the wire because that actually gives. I have 3 wires. One is actually keeping as the anchor wire. With the microcatheter, with the 2 wires are there. But you can look at the wire. When I just, there is a progress there, but you can see that my Gaia wire is actually buckling in the distal end. Once the wire is buckling in the distal end, it is actually maybe creating a knuckling there. So I decided to take the microcatheter down. I de-escalate. I wanted to see the de-escalation because I have seen the distal vessel very clearly early. So I decided to de-escalate, and de-escalating with a polymer jacket wire with cyan black. So you can look at this next frame. The wire actually jumped over to the distal vessel. Once you have this wire going into the distal vessel easily, then you have to check properly with the other wire. This actually will be understand. Now the wire is in the distal vessel. Now the process is actually a simple intervention. Balloon dilatation 2 millimeter, but we always evaluate with an IVUS to understand how much subintimal segment I crossed. You can see an RCA run. There was a lot of hematoma created by the multiple wires in the manipulation. So I created a lot of hematoma. There was a lot of calcium there. So that is actually, now I have to understand what is the size of the vessel. So the stenting strategy depends upon the size. The proximally it is 4 millimeter and the distally is 3.5 millimeter vessel. So 4 into 38 stent, 3.5 into 38 stent distally. And then I did an IVUS again, post dilatation with a 4 into 12 millimeter balloon. IVUS again to understand that what is the post. There is no proximal edge dissection, and throughout there is a well expanded vessel stent, and uniformly I got a reasonable area of 8 millimeter to 11.66 from proximal distal to proximal. So this was the final result created. How I did this case? Fine close with a filter FC. I used an XTR wire, Gaia 2, Gaia 3 and anchor balloon, a parallel wire technique where I used a Miracle 6 and a Congress Pro 12, de-escalated to Gaia 2, again de-escalated to cyan black wire, checking by retrograde injection, and IVUS, balloon dilatation, stenting, post dilatation, and IVUS again. That was the principle. So if I fail these things, what is the next technique? Now is the IVUS guided puncture. Here it is actually understand a proximal LED CTO origin is totally unknown. The only option left out is an IVUS guided approach. Actually, that is what we have done. For I did an IVUS evaluation from diagonal to see the LED proximal cap. You can see that when you look at this is the frame we have to see. When I push from the LED, you can see the LED coming up in the 6 of clock angle. That is actually the CTO segment. So the next frame, if you look at, I can see that the wire is coming up. This LED wire puncturing into the part. So the diagonal wire is there. We just decided, we finished the case and then we did a diagonal and finished off. This is actually the IVUS guided puncture when there is a proximal cap ambiguous where IVUS is the choice of thing. Then what is the next program in the Asia Pacific CTO program is actually the parallel wire technique. So what is parallel wire technique? I will show you the parallel wire technique. The wire enters the subintimal space. The second wire is advanced next to the original guide wire. It can be through a second microcatheter, then it is called a seesaw technique. If you are not using a second microcatheter, the second catheter taken as the first wire escalation, then it is called a parallel wire technique. That means in parallel wire technique, one microcatheter with a wire, another wire. If you are using a dual lumen catheter, that is the third choice. How is the wire to be used? You are using a stiff, highly torqueable wire. That should be the wire used, and a stiff polymer jacketed wire. The second wire should be stiffer than the first wire and should be having a superior torqueability. So my first wire was a Gaia next, Gaia second, and the second wire was a Gaia 3, which was crossed. That is what is shown in the. Then the new fashion of CTO intervention now is HDR, an antegrade upfront crossing of CTO that utilize an upfront interplaque contrast injection to facilitate the polymer jacketed wire passage. So CTO crossing without wire escalation or entry into an extra plaque space, that is actually the technique to be used by Dr. Trivedi. Actually, that is what with the less equipments. Suitable anatomy should be a suitable anatomy, identifiable cap. It can be tapered or blunt, and angiographically visible target. You should have three important things. One, you should have a cap puncture, contrast injection, and passage of a soft wire. So we just see this one. This is an RC circumflex CTO, diabetic patient EF. If you look at very carefully, there is a distal vessel very well seen. That is actually this was the CTO segment. Once you have a CTO segment, I have taken the wire with the microcatheter. So once the microcatheter came, when I wanted to push the wire, you can see the fine cross backing up. If you look at this frame, the fine cross is backing up. Once it is wire is not going distally, and if you look at the second frame, my wire gone distally, but it is out of the vessel. So out of the vessel distally, but proximally I punctured. I decided to take, since I punctured the proximal cap, I just go, you can see this one, this left-hand frame, that is actually the microcatheter is there. I give a small 0.3 ml of contrast, which actually my wire, you can just watch the wire goes easily down. Wire gone, which I struggled earlier, it gone easily because I created a soft loose tissue, and this you can see the wire is in the distal lumen. That is called HDR. The last and the foremost one is the Asia Pacific CT algorithm showed retrograde approach. This is actually a mid-lead occlusion, which I failed antegrade. The vessel has an angulated entry, no calcium seen, nearly 20 millimeter. So wire escalation I did, XTR, Gaia series, Miracle series, all failed. IVS guided entry, there is no good choice. It's not a good choice because there is no side branch. Then only choice is retrograde approach. When should I consider a retrograde approach? One, primarily when there is a proximal cap ambiguity, bifurcation of the distal cap, difficult to engage the CTO vessel, flush aortosteal occlusion, and diffusely distal vessel. The most common cause of secondary retrograde approach is actually a secondary, that means a failed primary antegrade approach. This case actually the same which I was shown. I finished the case with the 2 stents and finished the case. This is, thank you very much for the time. I saved 2 minutes. Thank you.
Thank you, Pratap, for that nice presentation. I think we just move forward. Yeah, thank you.
So, namaste, very good evening. I hope, we have no slides. Thank you for the invitation. I don't know how many of you are performing protected PCI with Impella. Probably few of them, and I believe it makes sense to identify what is still very important, not technical issue, but the background for protected PCI is even more important. I'm coming from University Heart Center Freiburg-Bad Krozingen, which is very huge, very large center, very close to Swiss and French border. And you see we are very countryside area here. But if you see this gray building inside, it looks like very nice hotel. So we have here outpatient area, coronary unit with 45 beds, electrophysiology unit, and valve and heart failure unit. So we have 11 cath labs, 5 cath labs for just coronaries and big stuff. You see program for multi-vessel PCI, and of course established CHIP program. So what we do now at the moment, we have ratio around 2% of protected PCI in our cath lab. And you see a combination of all this difficulties which we have to manage in the cath lab. So we have some patients' comorbidities, we have anatomical issues, and we have in many cases depressed ejection fraction. And in combination, if you have everything together, then you have to think about hemodynamic protection, hemodynamic support. And in particular, patients post-CABG, they are exactly the most difficult patients. They are patients with multi-vessel disease. They have severe calcified lesions. They have, of course, bifurcation, left main disease, CTO usually, and they have a very long history of atherosclerosis. It means they have also peripheral disease, and this is important to get good, safe access. And what is really important in such patients, we need to perform extensive lesion preparation, and this takes some time. And if patients have reduced LV function, so we can get very easy hemodynamic problems. So that's why the concept of hemodynamic protection is very useful. And of course, in all these patients, we need to achieve, if possible, complete revascularization. But please, again, not everything in single PCI. Please, you can do one vessel, most critical issue, and then next vessel you can do 6 weeks later. So we approach such patients definitely as first step. We discuss such patients in the heart team, and we try to get a very individual decision, best decision for our patient. Sometimes there is some option to go hybrid. Maybe left system can be approached by surgery, the CTO of the right, maybe by interventional cardiologists. And what is most important point, you have to plan time procedure. You need a slot of around 2-3 hours. And if you have this algorithm, very simple, if you have a complex anatomy, high syntax score, reduced LV function, significant comorbidities, you will go to protected PCI. And of course, you need all these difficult and tough devices in your cath lab. If you don't have it, sets of microcatheter, guiding extension, sets for lesion preparation, imaging, etc., you will be not able to approach. And of course, guided ultrasound guided puncture in the groin. We are waiting for PROTECT 4 study, complex anatomy with reduced LV function. We are one of the centers who could include nearly 30 patients in this study. So what we do, we try to prepare the patients perfectly. Important point is patient preparation, management in the cath lab, and then weaning and impeller explantation. So let's take a look to point of preparation. You need definitely angiosity, and we lost our patient initially because patient got bleeding, fatal bleeding. So I was working 3 hours, open everything, and then 2 days later, patient has hemorrhagic bleeding, hemorrhagic shock, and die. And even I opened every vessel, but it was too long, too much for very old patients on the table. So we prepare our patients according the groin preparation, like TAVR patients, so the same situation. So what is a contraindication? Definitely if you have very severe aortic valve dysfunction, that's clear, or if you have mechanical processes, and if you have ventricular thrombi. And this is also standard for every protected PCI. We check the axis, and this is very important because if you have a lot of calcium, that's a really issue. If you have just tortuosity, you can overcome this tortuosity with a long sheath. And again, very important to see if they're circular calcium or eccentric calcium. If you have eccentric calcium, usually you can go ahead with a 14 French sheath. What is important to have a check, how is the volume status, are patients decompensated, how is anticoagulation status, how is hemoglobin, renal function, prepare erythrocytes transfusion if needed, and you need definitely the ICU bed for the patient. And this is a planned procedure. If you go with protected PCI, that's a planned procedure. So you need to be prepared if something happens, and you need a plan B. What will happen if the patient doesn't improve during PCI, even under impeller protection? So should we escalate to ECMO? This must be clear before you start. What we do, we usually go with pulmonary arterial catheter just to have monitoring of the wedge pressure. This is also very useful if you want to perform weaning in the cath lab, which is practically the best way for this patient safety. And we have a doctor who is just taking care from ICU team, taking care for patient management. So me as interventional cardiologist and technicians, we are just focus our attention to perform procedure. Materials, of course, we are prepared just for ventilation, echo, if there is some bleeding, pericardial effusion, whatever. You have to be ready for that. Of course, medication, we usually go with sedation and analgesics. Of course, there is ready catecholamine therapy. Just if needed, you just switch the infusion and patient is stabilized. So that's why confusion is extremely important for protected PCI. You need interventionalists, you need ICU team, and cath lab technician. There is a very important communication topic. And if we're ready, then we try to get impeller out in the cath lab, because then you can control the access like after TAVR. And this is, I think, extremely important point. We reduce catecholamine dose, reduce support of impeller, and then usually we are able to remove the impeller system in the cath lab. And we use closure devices, whatever you have, Prostyle or Manta system. Please check, of course, how is anticoagulation. And regular check-up with duplex for impeller position is important if you are on ICU. And usually next day or 2 days later, we can remove impeller on ICU. And what we use for that, Paclose or Manta, mostly Manta device. And if there is some problem, even consider surgical treatment. So, dear colleagues, in conclusion, optimal lesion patient preparation is fundamental. Optimal patient preparation as well. Of course, you have to be skilled. You have to have everything in your cath lab. And what we have learned, less is sometimes much, much more. You need, of course, experienced team. Good communication is essential. And what is really extremely important, try to avoid bleedings, because bleedings bring patients to disaster. Thank you so much.
Thank you for excellent overview of how to manage complex PCI, how to coordinate among different cath lab technician and a setting. So I think we'll go for Dr. P.C. Russ' talk about IVUS image-guided coronary angioplasty in calcified lesions.
Thank you, Dr. Atsar, for cooperating and doing this talk on the last. Sorry for all the trouble, but I really appreciate. And after this talk, we'll have dinner. All of you, request all of you to join the dinner in Kanak. Thank you.
I think, good evening, everybody. I think the time for your dinner, I'll try to finish off as early as possible in my 10 minutes time. Thank you, Srinivas, for giving me this opportunity. And Srinivas has been organizing this meeting very well for the last so many years. And every time I make sure that I am there. And this time he has asked me to give this topic. As you know, this we are more and more we are doing interventions in elderly patients. Many of the, at least 6 to 20% of patients undergoing PCI nowadays have severe calcific lesions. PCI optimization depends on calcium debulking by appropriate devices, which can be assessed by intravascular imaging. Now we have many devices, and we have cutting balloon, rota, orbital atherectomy, IVL, laser. So many devices are there. So you know when to use it. When you do the imaging, either with OCT and IVS, we have in OCT we have a grading system. We can see the rule of 5 if the thickness is more than 0.5 or length of the calcium segment is more than 5 millimeter, or circumference is more than 50 per each, 1 point. So if this grading is more than 3 to 4, then I think it requires some additional device to debulk the calcium so that the stent is well opposed. Similarly, in IVS also, the grading system is there, and that depends on the circumference calcium. If it is 270, more than 15 millimeter, with 361 point, if there is nodule, 1 more point. So this point grading system is also there in intravascular ultrasound. You can assess it if it is more than 3 to 4. I think you should use a calcium debulking devices so the stent is well opposed. So I just wanted to show a case, 76-year-old male patient. She has multivessel calcific disease. Syntax score is 29. She has severe COPD. So we had a discussion, surgery. It came actually for the surgeon. Surgeons refused to do the surgery. And you can see the disease here. She had disease everywhere. You can see the LAD, LCX, ramus, and see the RCA also. So disease everywhere calcium. And this is the case for interventions. So what we did in this case is the LAD, we couldn't do the imaging, the catheter didn't go because of calcium. So we did the orbital atherectomy first for the LAD, and after that we did the imaging. And what we saw in the imaging is this one. This is what we saw. Left main is around 4.5. Ostium of the LAD is free from disease. Ramus is free from disease. You can see the orbital Shepherd area in that calcium, very severely calcific LAD within 360 degree. Depth of calcium is more than 70 micron. Length is 23 millimeter. Ramus opening looks calcified but free from disease. And LAD proximal was free from disease, so we decided to land the stent in LAD in the proximal part of the LAD. So this is what we did. We stented the LAD using 2.5 28 millimeter DES, and that's the result. After this, it's so we did the OCT. Stent is well apposed, no malabsorption, and no dissection distally. And then this is the angiographic finding. Very good angiography result. We checked with the OCT. Result was very good. Stent was well positioned, no malapposition. Then we moved to the ramus. Ramus, again a calcified lesion. We decided to do the orbital atherectomy for the ramus, and after that we did the imaging also. Imaging of the ramus after orbital atherectomy demonstrated a good lumen gain, and we decided that we will do the drug-coated balloon for the ramus. And we did it with paclitaxel 2.5 20 millimeter, and this is the DCB for the ramus we are doing, and this is the result, which is very good result. Then we moved for that's the DCB for the ramus. Then we moved to LCX. We tried OCT, but OCT catheter again didn't go because of severe calcium. Again, we did the orbital atherectomy, and after orbital atherectomy, we dilated with 2.5 12 balloon, and after the stented 3 into 23 millimeter DS, and we did the OCT. OCT shows the dissection distal to the stent. We put one more stent, and that's the result of the circumflex. Angiographically looks good. We checked with the OCT, it was fine. And after this, we moved to the RCA. RCA again, calcified lesion, and we did the orbital atherectomy for the RCA, and that's the stented with 3 and 48 millimeter long stent, and that's the result, which is very good. So in this case, this is the final result of the RCA. So you can see final result of LAD, ramus, LCX, and RCA. So in this case, we used orbital atherectomy for all the 3 vessels, all 3, including ramus, 4 vessels. We used, I think, 4 stents, and 1 DCB, and OCT we checked in all the vessels. So there are many trials that has been done for the imaging. I did trials for the calcified lesion. And some of these trials, recent trials, are Eclipse trial, Disrupt CAD, PPAC CAD, OCT guided comparative trial in multicentric trial conducted in Mount Sinai, short cure trial, victory trial. Many of these compare intravascular lithotripsy with balloon. Some of this highlight of this trial, I just want. Eclipse trial showed that routine orbital atherectomy didn't improve stent expansion or 1-year outcome versus balloon first. So don't use orbital atherectomy routinely in all crossable lesions. So you can do the imaging, and in certain cases you can do balloon alone. If the balloon is good, then you can stent it. Disrupt CAD program is IVL. It's a strong registry, a lot of evidence to find, but IVL is good in complex severe calcific lesion, and this trial strongly support use of IVL in severely calcific lesion. Then we have Rotax trial, imaging OCT IVS, use routinely to choose devices, confirm calcium modification, optimize stent expansion, and all these things. There's trial with hybrid trial, use orbital atherectomy or rota and then IVL. All these things trials are there. But 2 recent trials are very important. It was done recently in 2025 short-cut trial, where it was shown that in moderate calcific lesion, cutting balloon is as good as IVL. So if your lesion is calcium is moderate, you can use cutting balloon, result will be as good. Victory trial is a comparison between non-compliant balloon and IVL in severe calcific lesion. It showed that it's not inferior. So these two trials strongly recommend that not all many cases you can do with cutting balloon and non-compliant balloon. There is a calcium modification. What is the best device? And it was shown that with IVL, you get a better minimum MSA and target vessel failure was less. With orbital atherectomy, your MSA was little less and target vessel revascularization, target vessel failure was little more. Now all the devices are available in USA. It's seen that slowly other devices are steady, but the IVL use is increasing very fast. Maybe because it is easy to use and safety is the most important thing. So IVL use is going very fast in USA compared to other calcium modifying lesions. This is a practical algorithm for the treatment of calcified lesion based on intracoronary imaging. So you do the imaging. If the lesion is uncrossable, use a rota or atherectomy. And if it is crossable lesion, and if the calcium is mild to moderate, use balloon, cutting balloon or NC balloon. If there is moderately severe calcium, if the size of the vessel is small, use rota. If the size is bigger, then use orbital atherectomy or IVL. So based on this imaging, you can decide what you want. If the lesion is crossable, uncrossable, then use laser or rota. If it's crossable, if the size of the vessel is small, around 2.5 to less than 2.5, then use rota. And if the lesion is not very calcified, use cutting balloon. If it is more than 2 point large vessel, then you have the option of using IVL or orbital atherectomy. So in conclusion, patients with significantly calcified coronary lesions pose considerable challenge during PCI and increased periprocedural MACE rates compared with non-calcified lesions. So should be careful about it. Intracoronary imaging is helpful. It tells you the amount of calcium. It gives the pattern of calcium, and you can decide what device you can use. Rota, orbital atherectomy, and IVL achieve comparable stent expansion and 1 year outcome. It depends which one you want to use. It's individualized. Recent trials showed that cutting balloon and non-compliant balloon were non-inferior to IVL in moderate to severe calcific lesion. So you have the option of using these things in moderate and not very severe, because I do not recommend very severe calcification, but I think certainly moderate. Device choice can be individualized without compromising safety or efficacy. Thank you very much for your attention.
Thank you, sir, for excellent talk on how to manage a patient with heavy calcium. You have covered orbital atherectomy, rotablation, and IVL, and have compared. I think we'll end the session here. Thank you very much, sir, and thank you all.